Assalamu alaikum. Good afternoon, everyone. Welcome in this ROB session, second one, surgical one. I want to thank Dr. Muhammad and Al-Qasimi team for the excellent arrangement and invitation. And let us welcome our expert speakers. Dr. Singul is a well-known surgeon in the vitreoretinal field. She is in Gazi University professor, and we have also Dr. Ahmed Habib from Ain Shams University, associate consultant and vitreoretinal surgeon, and Dr. Mariam Al-Fikki also at Ain Shams University, she is associate consultant and vitreoretinal consultant. I myself, Dr. Hassan Al-Hasid from Dubai Hospital. Today our session will be around the surgical management, and I will begin one cases about the complication of the laser in the Zone 1 ROB. So can I just share my presentation? You can see, yeah?
Yeah, we can see now.
Yeah. Laser complications, we know that there is earlier complication for any laser, like the second day after the laser. This is sometimes could be for the over treatment of the laser, like vitreous hemorrhage, sometimes exudative retinal detachment, hyphema, closed angle glaucoma, and sometimes we can see the second day the skipped area because of under treatment. Because this is we need to know these cases because it could sometimes affect our results. And we have late complication like high myopia, macular ectopia, constricted visual acuity field, and shallow anterior chamber, and even anterior chamber, anterior segment atrophy. So let me present one of our cases which we faced during our practice. This is babies when we reach our hospital. It was 33 postmenstrual age and 23 gestation age. Patient, the baby has multiple morbidities, RDS, anemia, sepsis, and something which we noticed that she has eye discharge with redness. There's discharge, it looked conjunctivitis. So we collected the eye culture for the patient, and the diagnosis was aggressive ROB in the Zone 1. So you can see here even we took RedCam, you can see the conjunctival, how it looked like before we began. And she has lens vasculosa, additional vasculosa, and here you can see the first examination for this patient. You can see the loops and the aggressive, the tortuosity dilation. So we diagnose this from now that this is aggressive ROB. So as the patient has conjunctivitis, so for us, we said that we wanted to document the case, or we go for FFA, and you can see here the MVEs and everywhere in both eyes, and there's leakage. And the primary eye culture was gram negative. So for us, it was here that should we go by the injection? Because for us, the treatment for this aggressive ROB mostly should be, according to our practices, that anti-VEGF. But the problem here, we can't use it because there is high risk to have endophthalmitis. So we discussed this is with multidisciplinary specialty, infectious disease, pediatric ophthalmology, about what we should do, how we can manage. All of them, they said you can't use an injection, any antibiotics until you have a free from discharge, at least 3 days. Somebody should have culture. So we go then for laser the case. So we do the laser for the case, and we do good laser. I did the laser myself, even in this case, because I know that could be sometimes complicated. The laser went good. She has edema, and generally we document the laser. And here the patient, the eye culture came as a stenotrophomonas. This is one of the maybe what she has in her upper respiratory and in the skin and even in the eye. And she was resistant for most of the antibiotics. And the patients here, we give her the problem is the patient, in spite of the laser, and you can see there is some kind of pre-retinal hemorrhage. We thought that this could be related for the anemia, but on the right side you can see there is some kind of NVE, and there is hemorrhage around that. So we expected that it's this persistent ROB. So we try to treat the baby for the conjunctivitis, and we prepare the patient for the injection. And this is before the injection. You can see even within 3 days, the patients have developed even the tractional retinal detachment. So we know that the surgical should be as soon as possible for the left eye. And even the right eye, this is one week after the left eye. And this is in spite of the injection in the right eye. You can see there is stage 4 in the nasal side. And so this is patient underwent bilateral lens-sparing vitrectomy in both eyes. You can see there is residual traction in the inferior arcade in the left eye, and the right eye is stable. The second case, which I wanted to present about that, the laser and the zone 1, this is another case, patient 30 weeks postmenstrual age. The gestation is 25, the same as all the scenario, the babies in the in ICU, RDS, anemia, necrotizing endocarditis, multiple morbidities. The patient has ROB in zone 1, and she's African family, refused the anti-VEGF treatment, and she said, I wanted to do the laser. So we took the consent for the laser, and here you can see the patient has stage 3 with a plus in the right eye, pre-plus in the left eye. So it went, we document the laser rendered cam to avoid any missing or skipped area, because for us, this is something revisiting the baby and general anesthesia. For us, we put that we should document even, and we examine by this one eye done by me and the other by my colleagues. So the patient went well, regress, everything is good. But 6 weeks later, we have reactivation in the right eye and the left eye. So for us, we can see that there is no even skipped area, nothing there. We can see could we go for the injection? Could go for laser, where we should laser? So we did for her angiography. So you can see in the right eye, in spite of, we have evidence that most of the retina is already destroyed, but maybe there's some areas where we can see the pigmentation, just the pigmentation. So we decide to go and retreat these areas. So we retreat, you can see even we took the photo for that, where we treat the areas. So, and the patient has, after that regression, the regression here in the inferior parts of that the patient after the laser, 6 weeks around the laser in both eyes. So aggressive ROB is the incidence around 8% in the depending on the sometimes depending on the areas or demographic, but mostly around will be 8% in the population. The laser treatment for aggressive ROB, mostly in 50 cases, it will be 50% of the cases will be end by poor anatomical outcome. And recurrence of the ROB treated by conventional laser in the zone 1 has around 40% for recurrence. This is according to the BH study and even the Rainbow study. In spite of, there is some few reports that they say that the laser could be have less reactivation in the zone 1. In spite of, for us, mostly we don't practice in the zone 1 we don't use the laser for the zone, but sometimes maybe we have few cases. I like to share it with our experts. Maybe we can even hear about that. So just I want to summarize in the end that anti-VEGF is still the standard, is the standard, not still, is the standard treatment for aggressive ROB and ROB type 1 in the zone 1. And if you have any plan to do the laser, it should be confluent retinal burn, and it should be whitish reaction, not just the grayish. According, you need a good reaction until you have the result and avoid any reactivation in the futures. And thank you for listening.
Thank you, dear Hassan. It was really great cases and a very nice demonstration of the aggressive ROP cases, the problems with the aggressive ROP cases. Will we have should we have the discussion at the end? Or?
Yeah, I think we have time now, because for me, we have around 6 minutes.
So I like to discuss just after. So I just want to comment on the cases. First of all, in the first case, if I were doing the cases, then I would just start an antibiotic, topical antibiotic, use it just for 2 days, and then we'll go on injection.
We did, Dr. Sungul, let us discuss as we wanted, because for us, this we use for the Vigamox directly when we saw the baby. And the patients, after the second day, still have the discharge, said, let us wait, we add gentamicin. So the patient is still positive and document. They said, no, you should stop, then reculture. When we did the reculture for her, and we use fortified ceftazidime because she's gram negative. And then until we discussed with them, they said you should go for the Bactrim. We use it as fortified, and we use it in the systemic even for the, because she has upper respiratory infection. So after we used the fortified Bactrim, the patient was clear, even from discharge. This is something is for me the first time I saw it.
I see. I understand your concerns, of course, and you did it very well. You managed the case very well. But, you know, we sometimes have cases like, you know, adenoviral conjunctivitis cases superimposed with some bacterial conjunctivitis. In ROP cases, aggressive ROP cases, in such cases, you know, we put Baticon and povidone iodine, and it clears the surface quite very well. And then sometimes I use povidone iodine in a, you know, very low concentration after the injection, continue it. And then, you know, since the risk of progression after laser is very high in aggressive ROB cases, I discuss with the parents and the risks of waiting and the risk of endophthalmitis. And then after sharing all the concerns with them, I would usually go through the injections. But you managed the case very well, and of course, after the surgery, they did it very well.
Babies, mostly they have discharge, these preterms, mostly they have mucus discharge without any symptoms. But generally, you use the antibiotics one day before, or you don't use it at all. How you will practice if you will in the injection, in the intravitreal injection, in the ROBs? You use the antibiotics 2 days before, 1 day before, you don't use it? Well, how you are practicing in your institution?
I don't use antibiotics routinely, but if there's any discharge, then I start using antibiotics before the injection, and I don't wait too much. Just if it's aggressive ROP, maybe 1-2 days at most, not more than that, and then go on with the injection. And I may continue if it's culture positive, or if it is, you know, a very bad infection, it looks very bad infection, then I continue with povidone iodine, like 1% or so topical, together with antibiotics. So it supports the prevention of endophthalmitis during the after the injection, like 3-4 days, not more than that. And for the second case of yours, I would check if there's anything like fever with genetic testing. You know, in such cases, you did the laser very well, and it's not an aggressive ROP case. So the reactivation rate should be very, very low, you know, but it was reactivated very badly. So, and the lasers were so perfect. So I would again think of something like genetic problem, maybe NDP mutation or something like that. And I would just check genetic mutation for that.
In your practice, did you use the laser in zone 1, or compulsory you go for the zone 1, the laser?
For zone 1 disease, I always use anti-VEGF. And then after 60 weeks, for example, if there's still peripheral avascular retina, I do laser afterwards.
Thank you. I don't know that if Dr. Ahmed or Dr. Mariam, you have any additional information for us, we can just maybe, because I know that you have huge experience in Egypt because the numbers. So did you face this kind of conjunctivitis about retreatment in the zone 1? What's your opinions?
Actually, one time we had the infection, but it went away with only topical antibiotics. It's usually benign and goes away in two days. About the reactivation, not that much aggressive, but we had reactivations after laser and more after the injection. We had to re-inject in a few cases.
I don't know, Dr. Mariam with us?
Should we continue with?
You can continue, Doctor. You can share your Dr. Shengel. Can you use your you began your lecture, please?
Mariam
Okay.
is not ready, I guess. Is that right?
Justin, yes, you can start and then I'll be after you. So it will be fine.
Great.
Fine.
I will do it. So can you see it now?
Yes, we can. Yes.
We can see.
Okay, great. So I'm happy to be here with you. Thank you for giving me the chance to share my experience on the cicatricial ROP cases. The cicatricial ROP has been defined first for the first time by ICROP group in 1987, and they described some peripheral and posterior segment changes, and the peripheral changes were like failure to vascularize in peripheral retina, abnormal branching vessels, pigmentary changes with retinal interface changes, peripheral retinal folds, lattice-like degenerations, and some directional and rhegmatogenous retinal detachment. And for the posterior pole, they describe straightening of the blood vessels in the temporal arcade and dragging of the retina, macula, ectopic macula, and optic disc. So after that, when they become, adults, we can have high myopia, astigmatism, amblyopia, glaucoma, cataract, vitreous hemorrhage, and sometimes late reactivation of fibrovascular proliferation and exudation after having stable and regressed ROP in some of the cases. And also we can have rhegmatogenous or tractional retinal detachment. So this was a case of premature regress premature case. He was 20 years old when he came to me. He was followed in USA and he had previous patching treatments for amblyopia and strabismus, and he had some laser photocoagulation for lattice degenerations in both eyes. But he came to me just for control visit. His vision was quite good. And this was the posterior pole. You see some narrowing of the angles of the major retinal arcades and a little bit ectopic macula to the temporal side. Macula was great in all CT, but when we have the fluorescein angiography, you see very well documented avascular retina and some pathological vessels in the ridge area and with some lasered lattice degenerations. So this was in zone 2. That was very interesting for me. And then we did laser to those peripheral avascular retina totally. And he's doing well since 6 years. And what if we don't do such lasers? They can have rhegmatogenous retinal detachment in those thin avascular retina. And when you see an adult ROP case with rhegmatogenous retinal detachment in adolescents, for example, they are usually misdiagnosed as Stickler disease. Please ask about prematurity when you see an adolescent or young rhegmatogenous retinal detachment associated with high myopia and especially with a shallow fovea. And we also have tractional component also. we may have. So when we have rhegmatogenous retinal detachment, they are usually more complex detachments. They usually require multiple procedures, and they end up with lower visual and anatomical outcomes. And 2/3 of the patients who underwent vitrectomy had poor postoperative visual acuity. This was such a case, an 11-year-old boy with sudden loss of vision in the left eye, which was the better eye previously. He was born prematurely, but didn't have any treatment before. He was followed by the local doctor since 4 years old. Before then, he didn't go to the doctor before. And then vision was 0.05 in the right eye, 0.3 in the left eye, which was the better eye. Now he came with counting vision in the left eye. The right eye was already had macular fold and peripheral avascular retina, but the left eye had rhegmatogenous retinal detachment with counting fingers level. So this was the surgery. We couldn't see the retinal break, so we had to do vitrectomy. We started with the encircling buccal. Lens-sparing vitrectomy was planned. And as you see here, the vitreous was, posterior hyaloid was very tightly adherent. And we started by manual surgery, and we could peel some membranes, posterior hyaloid. And these are not the PVR membranes, but these are actually original ROP proliferations. So we started to peel the membranes as much as possible from the macular area, and then try to detach the vitreous as much as possible to the peripheral retina. But we couldn't achieve till the periphery, only just to the post-equatorial area. And then we could find a retinal break here, which was the causative retinal break. But I couldn't, peel the posterior hyaloid totally around the retinal break area. And I also did some ILM peeling just to be sure that there's no membrane left in the macular area. I've left some membranes in the ridge area because there was no other retinal break in those areas. So I supported the retinal break area with the buccal and put silicone oil. And then lasered the peripheral avascular retina in the fellow eye to prevent a retinal break. And in the post-op early period, it was quite well, the first week and first day. But during the first month, although it looks quite nice as compared to the previous one, we just detected a macular hole, which was, not expected. But since the residual membranes were causing still some traction, so it ended up with a macular hole. So what I did, I have to be more aggressive now, and I had to peel the membranes as much as possible. I took the risk of having retinal break, and I even had to do a retinectomy in those areas that I couldn't peel the membranes, and then put an amniotic membrane to the macular hole area because I felt that a PVR may be a real problem and may cause traction and may pull the hole again. So this was 2 weeks post-op, but after 2 months, again, macular amniotic membrane contracted. And we did a third surgery and a fourth surgery. And finally, we could have a macular hole closed with amniotic membrane. Silicone oil was out. We did cataract surgery, and just vision was counting finger from 1 meter after so many operations. This is another adolescent ROP case, 13-year-old boy with chronic inferior retinal detachment. And we could see the peripheral retina break in the inferior part, and we did just encircling buccal and cryo, and it went well. So we always try to avoid from vitrectomy if we can see the retinal break. Just try to support it with the buccal and try to avoid from the vitrectomy, which ends up with bad prognosis. What if we have attractional retinal detachment? This is another problem. we should think of, is the retina detached since the neonatal period? Is there amblyopia? Will it be possible to get useful vision if anatomical success is achieved, or there's also a risk of losing the present vision? No surgery may be better sometimes. So this was a case of 6-year-old boy, and with visual acuity 0.1, we operated in 2015. But as you can see here, the fovea was superiorly and temporally ectopic, and I can see the peripheral membranes, which are causing anterior-posterior traction also. So I felt that they can be removable without causing too much problem, too much risk. Then I just peeled all these membranes and leave it with air. And this was the post-op appearance, as you see here. And vision also improved to 0.3, and it's more secure right now. Another case, 6.5 years old, and both eyes had tractional retinal detachment. Retina was pulled towards the infero-nasal part. Previous premature and no treatment before, as you see. Vision was 0.1 in both eyes. So again, as I feel that there's an anterior-posterior traction which can be removed easily without taking too much risk, then I decide to do vitrectomy. If I see just tangential traction, which cause, tractional retinal detachment, in such cases, you may end up with retinal break. So I'm not so willing to do such cases. But in these cases, they help very much. You see, I try to peel those membranes as much as possible, but I did leave the part if it is strongly attached. So this is the residual membrane. I do some massaging and leave the eye with air only. And this is the third year after the surgery. Vision improved to 0.7. And, life of this baby this child has changed. And this is the fellow eye. It ended up with 0.3, and the retina was attached quite nicely. And this is another case with 20, again, premature, but came to me after 4 years. The fellow eye was already light perception, no light perception, but with the right eye, there was some hand motions. And the posterior ultrasonography was not so bad, so I decided to do operation to the right eye. And as you can see here, it was leukocoic, so I started with lensectomy. And after peeling the membrane step by step, layer by layer, and I could relieve the retina, as you can see here, and it ended up with very good result. You see, this was during the end of the surgery, and this is 5 years afterwards, and he has quite good ambulatory vision right now. So we collected our data and published in Indian Journal of Ophthalmology. And my take-home messages are: premature babies need lifelong follow-up, and late reactivation with proliferation from peripheral avascular retina and exudation and vitreous emerge may develop in these eyes. And high myopia, lattice degeneration, vitreoretinal interface disorders are very common. When you have a rhegmatogenous retinal detachment or tractional detachments, they may be, complex detachments, and prognosis may be guarded, but you should decide by case for these cases. And I would like to invite you all to young colleagues to our ROP course, which will be hands-on training skill transfer course for 3 days in Ankara in September, and a limited number of attendees will be accepted. And we will also have an EVRS meeting on September, at the beginning of September in Cappadocia, Turkey, which has a considerable amount of ROP sessions. Thank you.
Thank you, Dr. Shingul, for this excellent cases and very, very informative lectures. Maybe we can just postpone the discussion because already the time we can take Dr. Mariam presentation, or still is not ready.
No, I'm ready.
Yeah.
Yes.
Please, can you share?
Okay. So can you see the presentation now?
Yes, we can see it.
Yes. Thank you so much for the invitation. I will be talking about the stage 4 surgery for retinopathy of prematurity. As we all know, the idea of the surgery in ROP is to relieve all the forces of traction without creating injury of the retina. So the main goal is to find your planes. To know your planes of traction or where to dissect, you have to do a good preoperative examination, intraoperative examination, use all your tools, be patient, and also postoperative, you can do a sequential surgery that would be specially for stage 5, not for stage 4. So let us go for stage 4 ROP. Usually in those cases, we do a lens sparing pars plana vitrectomy, except if the retina is very close to the lens and you think you can injure the retina preserving the lens. So now you would leave the lens to remove it, not to injure the retina. So the prognosis of the surgery, as we all know, for stage 4A is much better than for stage 4B because of the preservation of the foveal anatomy and thus better preservation of vision. So let us go for our cases. This is a case of a stage 4A with a highly active plus disease. So what are the forces of traction here? We have a force that is dragging the retina center, which we call the centrifugal force, and another one pushing it outside. And we have this circumferential force of traction on the summit of the fold, and also an anteroposterior force dragging it upwards. So first I go for trimming of the vitreous, which is holding the retina to the peripheral wall and also anteriorly up to the lens with the cutter 360 degrees. And before completing this completely, I have to go to the center of the ring to cut the vitreous so that the ring will not close completely over itself after leaving the peripheral traction. As you can see. And after I do this, I will go to cut the part of the ring with no vessels. I did not go any close to the fold itself because it is highly vascular. So if you go very close, you will cut the blood vessels and you will have a post-operative bleeding. And as you see, I inject at the end of the surgery Helon because it will keep the tension well formed after the surgery. I secure the sclerotomies very well to make sure I don't have a post-operative leak, which is one of the causes of post-operative hemorrhage. And this is a picture of the case finally. This is another case which had a highly active plus, and as you can see, there is a lot of new vessels in the edge. The retina was not too high. So in this case, I decided to do first an intravitreal injection, and you can see when I entered that the retina is much less vascularized. So in this case, I attempted to do a central PVD. I don't like doing PVD in those cases because it is risky, it may cut the retina, but if I can remove the vitreous over the central part within the ring, it will allow the retina in the central part to flatten and not crunch over itself post-op. So if I can elevate just a part of the vitreous, I don't aim to remove it, even just opening a part, and then it will do a spontaneous PVD. As you can see, when I'm elevating it, it is very adherent to the retina. I stop when I feel it's risky and it can create any breaks. And actually, this is controversial. You can do it without a PVD. This is controversial. And again, this is the picture of the case pre and I think that was 1 or 2 weeks, 1 month post-op. This is another case which was a very highly aggressive retinopathy of prematurity. That case was not for surgery primarily, it was for injection. You have a fibrovascular proliferation 360 degrees. There was some retinoschisis. The retina does not look to be detached now, but I knew that after the injection, it can go for retinal detachment. So if you have a case like this, you have to keep in mind that you may need surgery and be prepared for what will happen next. So this is a picture of the case after 1 week. The new vessels are regressing, the plus disease regressed and the new vessels also, but the retina is starting to get elevated here. And this is the picture after 2 weeks. You can see that the retina got highly elevated in this part, and it is going into the fovea. If I would say this edge is going into the fovea. So now I decided to do a lens sparing pars plana vitrectomy again. Sorry. Oh, sorry, because one slide is dropped here. Okay. So I'm sorry for that. So again, in this case, I decided to do, after doing a core vitrectomy, I decided to elevate the hyaloid, but in this case, it was very sticky. So I made like a small opening in the vitreous over the central area only with the bent needle. And then with the vertical scissor, I'm creating I'm trying to cut the vitreous 360 degrees, this vitreous condensation. It's not actual posterior hyaloid. It's like a vitreous sheet covering all the central area. I'm trying to make an opening 360 degrees around just the fovea to free this central area from the periphery of the retina. So if it's trying to flatten, it will be easy to flatten with the flattening of the retina, the normal forces of the retina. Until this is completed, that was a picture of the case after pre-op and 2 weeks after the surgery, and again 2 months, and you can see that it is very slowly flattening. I'm sorry for this inconvenience. This is another pattern. When you have the case coming too late, that was a 7-month-old child. She is already now having a cicatricial form of stage 4B ROP, not 4A. So in this case, you can dissect close to the surface of the retina because you don't have any active plus disease anymore, and no active blood vessels on the surface of the retina. So I have to dissect the forces which are getting this fold closings in the central part, and the forces which are dragging the retina peripheral, and also the force of the vitreous condensation surrounding the fold, and the anteposterior force which is dragging this retina upwards toward the lens, as you will see in this surgery. In the very start beginning of my surgeries, I will go to the start of this. I used to use, sorry. To use 3 trocars. Now I stopped doing this, and I will tell you why from this surgery, because the retina is very, the eye is very small, the retina is very high, and when you have 2 trocars here for the instruments, you find that the trocar is long enough to disturb your movement inside the eye. You need this lens of the trocar to be free. You can move your instruments freely and go to planes even very close to the sclerotomy. So those trocars hinder the movement. So I stopped putting these, you will, as you saw in the previous surgery, and I put only a trocar for the infusion, and I don't use trocars for the instruments. So in this case, I start first cutting the vitreous, which is attaching the fold up to the lens with a scissor or something. I don't want to injure the lens. And then after the fold is completely free, I open the central part because it was closing over itself. And then again, I go to the periphery. So the same plan of the previous surgery. In this case, I used Kenacort several times to stain the vitreous remnants. And you will be surprised that you will have a lot of vitreous remnants every time you stain. You remove as much as you see is causing traction only, and the rest you can just leave it. And as I said before, because this case is not an active case anymore, I can cut the vitreous which is on the surface of the fold. I'm trimming the vitreous, like this is a summit. I'm trimming the vitreous on the surface of the fold to allow both layers of the retina to flatten to the periphery easily. And you'll see the effect of opening this part, how the fold will flatten. But you cannot do this if you have an active neovascularization on the surface. It will bleed. So that was a picture of the case like 4 months after the surgery. And you can see how it flattened because you relieved the force of traction and allowing the retina to flatten with the growth of the eye. That was her other eye. And again, I have the anteroposterior forces and the peripheral forces. In this one, I was a bit between removing the trocars. So I put one trocar and I removed the one towards the side of the high retina. And again, I trimmed the part which is holding the retina to the lens. I'm trimming on either sides of the fold. And again, injecting Kenacort after you do a core vitrectomy, you will be surprised for the amount of vitreous still there, which will hinder flattening of this retinal fold. And finally, I cut the vitreous on the summit of the fold to allow the retina and the vitreous on both sides to stretch, and it will settle down. And that was again the picture of the case 4 months later. This is the last case and a typical case presentation. So not all your cases will be, I don't know if we will say this is a stage 4 or a stage 5 ROP. It does not fit in any classification. This was an aggressive posterior retinopathy of prematurity case. She's coming late when she already has a central retinal detachment, very aggressive, as you can see, extensive neovascularization. So in this case, I first decided to, that was her other eye. And I decided in this case to do a bilateral intravitreal anti-VEGF injection as a preparation for vitrectomy. And I kept following up the case week after week, and those blood vessels are not regressing until I had to wait like 1 month. And that was the picture for the right eye. And again, the picture for the left eye. And I thought I would do just a core vitrectomy to allow this retinal fold to set in posterior. But I thought that I lost the case by those 2 pictures. But when I did the core vitrectomy, that was the surgery. I'm getting the surgery to show you that I did a very simple, just core vitrectomy, and I only did a cut of the vitreous, which is surrounding the fold from the central part only. I did not do any management for that retinal fold, just core vitrectomy around it and cutting the vitreous band, which is on the summit of the fold. And surprisingly, I had a flat retina after 2 months. I have a disc and I have a flat macular area on both sides. I don't know if I was delayed in the surgery, but I think that was a good result for me, because if I entered on a highly active plus, I think it would have crunched anyway. So I would not go for a good result. And that was actually the baby. I got you this video to see, although that this child is not having a very good retina, but she can see well. So my take-home message is that complications of this surgery is either lens touch. Lens touch is usually forgiving in those cases, so don't worry if you touch the lens. It can stay like that with a central fibrosis for like 1 or 2 years, no problem. Breaks in the retina is not forgiving. Maybe Dr. Singul showed us some good cases, but it's not always the situation, and it's very tough surgery. So if you want to do a PVD, make it a localized, and don't be so aggressive in your surgery. If you have breaks on detached retina, usually this is too difficult to manage. But if you have a break on, because the retina is detached, is stretched, and flattening this area will need a retinectomy, which will end with extensive PVR. But if you have a break on a flat retina, like the areas where you are creating a PVD, just make a localized PVD around this area, do a laser around this area with a break, and put a tamponade and follow up your case. This may be forgiving. Vitreous hemorrhage is one of the complications. So please close sclerotomies highly tight and put, I like to put a good tamponade like Helon. I don't like air or gas because sometimes they have a late hemorrhage. And also keep an eye on the IOP because instance of glaucoma is 10%. My take-home message is, although the prevention is the rule, but if you have stage 4, it is still treatable. Usually 4A is the best prognosis, and lifelong follow-up for glaucoma and redetachment is mandatory. Thank you.
Thank you, Dr. Mariam, for this excellent presentation. And you summarized maybe the stage 4 for us. Thank you very much. Can you, Dr. Ahmed, get your presentation, then we go for a discussion, because all of these 3 surgical sessions, then we can at least save the time, because we have still 15 minutes. So can you just share your presentation, then we go for the discussion?
Okay, is it on?
Yes, we can see it.
Yeah, we can.
Okay. So stage 5 ROP is you can't. Okay. So I'll do another.
It's a black screen right now.
Yes, now we
I
can
think
see
I know the problem.
Now we can see it.
We can see it now, but when you go to full screen, we can't.
How about now?
Still not full screen, but we can see it.
Yes, now we can see it. It's okay.
Okay.
Now we can.
Okay, so the stage 5 ROP is the last step in ROP surgery, and we actually don't want to see it. But I'm here to say that the stage 5 ROP surgery is not hopeless. It has some hope, and it has a success rate. And if we can make the patient, the baby, reach some form of vision, like hand motion or form vision, this will differ in his life. So the parents first, when you see a baby with stage 5 ROP, they ask two questions: what does my baby need, and what is the success rate? So in counseling, I always tell the truth, nothing but that. I arm myself with evidence-based data, point out the possible need for multiple surgeries. This is very important. I should make it bleak so as not to increase the expectations, but I don't make it hopeless, because there's actually hope for some use vision. And at the end, I give my advice: if this eye is promising for the surgery or not. For example, sometimes if the baby is if the child is more than 2 years and he has one good eye and the other was stage 5, I advise not to interfere unless they know that it will not be that much useful. But in cases with bilateral stage 5 ROPs, I always push for the surgery. So evidence-based data, the best reported results with anatomical success is 30 to 35% retinal reattachment. Some small papers give actually better. And by success, I mean part of the retina attached, not the whole retina, because usually the whole retina is longer with sustained traction. It is longer than the actual choroid. So it is very rare to find a fully flat retina after stage 5 ROP surgery. Then the visual results is actually 75% light perception. That means that some of the patients that even if it's not attached, it is still they still see light perception, and 5% of those have informed vision, and this is very useful vision actually. Also, the light perception is useful vision, because the baby knows light day from night, and this is important for his sleep, his immunity, and growth, and much more. But the form vision, actually, with the form vision, the baby growing up with the form vision, the baby will manage, and actually it gives him navigational vision. So there are different severity types of stage 5 ROP. We used to call them the good, the bad, and the ugly, but now it's 5A, 5B, 5C, thanks to the ICROP3. So 5A is when you see the disc, 5B is when you don't see the disc, and 5C is with anterior segment complications. Actually, we can enter up to 5C, and if you see the cornea a little bit hazy, when you enter and clear the AC, the cornea sometimes, or more often than not, it clears up and you can work. Also, the configuration of the detachment is very important. We classify them as anterior and posterior. It either open anterior and posterior, or closed anterior and posterior, or open in anterior or posterior, and vice versa. Sometimes the retinal folds are twisted, and there's an important piece of information that the vitreous, when it is contracted and condensed over the disc, it forms a very thick central stalk, as we call it, and usually attached to the disc. And this is one of the surgery targets. So we come to the surgery. Actually, pre-operative assessment. The age is important. Actually, if the age is very young, 2 to 3 months. Sometimes the plus disease is still aggressive, so we wait for some weeks, as Dr. Shimbul taught us. Then, if the patient is very old, more older than 3 to 4 months, we don't expect that much of an improved vision. Bilateral or unilateral, as I explained before, and expectations of the parents. This is very important. Sometimes the expectations are more than the reality, so we have to adjust the expectations of the parents so we don't find angry patients in your clinic. Electrophysiology is not that important. It will always give you the same report that it is affect the retina and the optic nerve is affected. So I don't use it that much. So to the surgery, we first enter into the limbal approach. We put the infusion in the anterior chamber, and they usually do lensectomy and complete capsular removal. That's very important, and do iridectomy to be able to access to the periphery of the retina. And we start using a bimanual technique with 2 forceps. That's very important. The forceps should be high quality. Usually I use the Maxwell forceps. Then we first dissect the mid-periphery. Then we go to the central stoke. Sometimes we use a chandelier, but the soft ones, not the very hard ones. But we use the oblique illumination by the assistant. It's better, and the oblique illumination is gives you a better perspective of the different layers and their depth. And we try to release the central stoke from the center of the retina until we reach the disc. Of course, that's a no error surgery, so we cannot afford any breaks. So if it's risky, we stop. Then we go to the periphery. My fellow surgeon, my assistant, the other surgeon, the team will be indenting and obliquely illuminating until we remove the as much as we can of the membranes in the periphery. If we see folds between the retina, we call them gutters. We open them so as to give the retina space and freedom to be able to flatten as much as it can. But sometimes the internal fibrosis is present, and we cannot actually do anything about it. So this is a fast-forward surgery to revise the plan. We do mid-periphery and then central stoke, central, mid-periphery, center, and then periphery. Of course, the previous surgery, we used the Ingenuity. That's a recent development, and the Ingenuity gives you better depth perception, so we can use the microscope itself to, with the oblique illumination, to be able to reach deeper parts with both instruments. Of course, the indentation is very important to reach the periphery, and remove as much as possible and release as many gutters as possible until we reach a conclusion. And we try actually to finish the job in one take, because that's because when we enter in another time, the membranes become more stiff and more difficult to deal with. So the results are they actually take a long time, over 2 to 3 months until they reach the desired outcome. If it's from one time, or we can enter again. Actually, the results improved after we used the new technique with peripheral vitreous removal, and until we for example, this baby had bilateral stage 5 ROP, and now after 2 years she can see the ball, and she can have navigational vision. So the surgical perspective, that's the last slide. The plan is to do the mid periphery, center, then periphery. 2 forceps is a good strategy. Peripheral folds and others should be open. Indentation is very important. Instruments, the maxi grip, the shaft forceps, the curved and straight scissors with high quality. It should be available in ulcer or in your arsenal. Illuminated pick, we used to use it a lot. Now it's less with better illumination and the visualization by the Ingenuity. The Ingenuity gives you better depth of focus, greater magnification, and the light gain manipulation. We can use it to with low light with increasing gain to be seen better. With also the group opinions, the light, the oblique illumination, the chandelier lights are very important. And we also use the black HDL biome or Recite lens from Oculus. That's a small diameter. If you want to enter by the to see by the Recite or biome, and at the same time we can do the oblique illumination from beside the lens. So thank you, and any questions?
Thank you, Dr. Ahmed, for this excellent presentation, and really you summarized for the stage 5 for us. And there is just I want to ask you, you don't use any trocar for the stage 5, just you put you don't even try to put the trocar if you finish the periphery, or you don't have, maybe you do, just to depend to.
I don't have any space.
Just I have one question for Dr. Mariam about the scleral buckle rule and Dr. Singul also. We need all of your opinion about stage 4. There is some mention about using the buckle, and in the real life, this is tractional part. How we can use it? Which the best candidate patient for the scleral buckle in the stage 4? Stage 4.
So I think Professor Sengul will be much better than me. I don't have a good experience in this. I just did one case with localized retinoschisis. So I put a radial buckle to push it, and it stayed stable with the cross of the eye. So that was my only experience. So I don't know if it looks like Professor Sengul has better experience in this.
Thank you for asking that question. Actually, scleral buckle and circling buckles were being used previously quite a lot, but in the recent years they are becoming abundant in ROP cases because of the the increased quality of the vitreoretinal surgery. In ROP cases, probably we need much less, but even if you put encircling buckle, you have to remove it like 6 months after, since the eye is growing. I only use those buckles in cases which are, which come late with tangential membranes causing traction in the macular area, which I feel that if I do the vitrectomy, it may cause more problem to the eye. It may cause retinal break since they are not anteroposterior, but just tangential. So in those cases, very rarely, I use encircling buckles, and I remove it 6 months afterwards. And also, I can just put local buckles. If I want to save it for a long time, for a longer time, sometimes I put a small buckle, a thin one, of course, segmental buckle to support only that traction area. But it's very rare. Where I use the buckles is if I have a retinal break, peripheral retinal break. In an ROP case, if it is in a silent area, as Mariam pointed out very nicely, if it is in a silent area, then, and if it is in the peripheral part, when you put a buckle, it works very well. Just a local buckle to support that area. But if it is in the very proliferated area, I mean, in the rich, very elevated, highly elevated rich area, even that buckle may not help, but I always try to give a trial to support that retinal break area. In some of the cases, it may work. So I mainly use the buckles for the breaks.
But Dr. Shungul, can I ask a question?
Okay.
Yeah, please. Ahmed, please.
Yes, about the first case that you had done, you were already planning the 10-year-old boy with the late ROP RD. You were already planning to do vitrectomy. So what is the buckle for?
Oh,
what is the rationale for buckle?
Very good question. Thank you. Since it is a lens sparing vitrectomy, so we may not be able to clear the vitreous space totally. So in such cases, I always put a buckle. He was 10 years, 11 years old. So I will not remove, I don't have to remove the buckle. And I always put the buckle to support the vitreous space because you may not be able to clear all the vitreous space since it's a phakic eye.
And what is the
directions?
Okay, thank you. And what is the age at which you remove the buckle? I mean, what is the minimum age that after that you don't remove the buckle?
I don't remove the buckles after 4 years age. Before that, I usually remove it because at 3 years of age, the eyeball reaches to like 90-95% of the adult size. So.
I actually have a patient. He's 2 years, and I did for him a buckle, but now his eye is actually smaller than the other after 6 months. So I'm planning to remove the buckle.
I think Dr. Muhammad already with us in the screen, and we are running after the time, I think. So
I'm sorry.
I want to thank Dr. Mariam, Dr. Ahmed, Dr. Shungul, as usual. Really, this is fruitful presentations. And I hope that we'll see you more and more and here live in Dubai, inshallah, in the future. Thank you for sharing the information. And I hope that we'll see you here soon, inshallah. Thank you, Dr. Muhammad, for the invitation.
Thank you very much, everyone. Thank you, Dr. Shungul, Dr. Ahmed, Dr. Mariam, and Dr. Hassan. It was an excellent and great session as usual. Thank you.
Thank you. Thank you.
Can move now.
Bye.
Bye.
Thank you.
Dr. Ahmed, you are here?
Yes.
Ahmed Salam also? For the next session?
This is like another meeting. Okay, so, okay.
Yeah,
bye.
you can enjoy, stay with us. Thank you. Unmute yourself, Ahmed. You are...
Yes.
Thank you.
All right, excellent. We'll get started for the sake of time. Good afternoon, everyone, and good morning if you're on the other side of the world. It's my pleasure to introduce this session on uveitis case presentations. And my name is Ahmed Salam. I work at the University of Arkansas for Medical Sciences, USA. So we have excellent guest speakers telling us about mystery case in uveitis, and we'll get started with our first speaker, and that would be Professor Hasna Lamari from Morocco.
Thank you very much.
Thank you for being with us here. Excellent.
I will share my
Dr. Hassan, can you share the screen, please?
yes,
Okay.
It's coming. Yeah.
It's coming. Yes, great.
thank you very much for the invitation. Ankylosing spondylitis is a chronic inflammation disease involving sacroiliac sacroiliac joints and the spine. It can be actually B27 positive or negative. The most common ocular manifestation is anterior uveitis, 30 to 40%. The posterior segment manifestation is less found, usually associated with anterior uveitis. And I will report a case of isolated vasculitis in ankylosing spondylitis. My patient is 31 years old, followed for 6 years for ankylosing spondylitis and methotrexate. She was actually B27 positive and disabling right sacroiliitis with cervical stiffness. She was under Embrel since 18 months. I see her 2 times for 2 episodes of anterior uveitis treated by topical steroids. And she was referred by her ophthalmologist for decreased visual acuity of her left eye. The visual acuity was very low in the left eye, 110, and the anterior segment was normal, no uveitis, no anterior uveitis, and this is the fundus of the right eye. It's normal, and angiography also is normal, and this is the found eye of the left eye, and we see very extensive vasculitis with hemorrhage and papilledema. The angiography confirmed the vasculitis and show leakage of the papilledema. The vasculitis was very extensive, and all the vessels or the zones of the retina was touched. OCT show macular edema and papilledema of the left eye. So what is the diagnosis? We have vasculitis, unilateral vasculitis associated with ankylosing spondylitis without anterior uveitis, and usually we found anterior uveitis in AS. So we make a very big investigation. The inflammatory blood work was normal, sedimentation rates normal, CBC normal, CRP normal. Negative infectious screening, we search syphilis, we search tuberculosis, CMV, VIH, and all the infections can make this vasculitis. So because the screening was negative for infectious, for infection, we put the patient under bolus of corticoids for 3 days with oral relay by 60 milligrams a day. And I see her 14 days after, with a very good evolution, we see marked improvement of the A fundus with the increase of the visual acuity of the left eye. Angiography show also net improvements. The OCT is normal, and retinal vasculitis is very rare in AS. We must eliminate other etiologies, especially tuberculosis in our context, because the patient is on corticosteroids or immunosuppressant. The treatment of the retinal vasculitis is based on corticosteroid bolus with oral or peribulbar relay. This paper say that posterior uveitis is rare, mainly dominated by Yalitis. This is a case report of retinal vasculitis with AS. It's a very rare association, and this other paper says that retinal vasculitis is rarely associated with ankylosing spondylitis, but we don't know the real frequency. I think it's underdiagnosis and underdiagnosed. There is not a special aspect, and sometimes can be occlusive. Optic disc staining or papilledema is frequent. This is a paper from Center Specialist on Uveitis, and he find a very high level of posterior involvement and peripheral vasculitis, more than 30%. So they conclude that is that they have a high level of posterior uveitis because there is a systematic screening, including multimodal imaging, and posterior manifestation must be asserted, particularly if there is an anterior uveitis. The posterior ocular cell manifestation in patient associated uveitis need the most aggressive treatment and have a worse prognosis. These papers say that AS with HLA-B27 is associated to an increase of choroidal thickness, especially if there is an anterior uveitis or a systemic inflammation. The uveitis in AS increase risk of acute coronary syndrome and stroke. What about etanercept? It's a tumor necrosis factor. The studies demonstrate its efficacy in improving the inflammatory symptoms associated with the rheumatoid arthritis with minimally adverse effects. So we can ask two questions. Can etanercept treat uveitis, or can it induce uveitis? For the first question, the etanercept has not efficacy over placebo in preventing relapses of uveitis in patients. And for the second question, the answer is yes. Uveitis, but uveitis associated to etanercept is paradoxical. That means it's the first episode. Generally, in the first year, it's corticoresistant inflammation decreases only if etanercept is discontinued. So for our patient, we have two episodes of anterior uveitis. The retinal vasculitis is isolated without anterior uveitis. Etanercept is begun since 18 months. There is no systemic inflammation, there is no infection, and there is good and fast response to the corticoids. So can we conclude that the vasculitis is secondary to AS? Thank you for your attention.
Thank you so much, Dr. Hasna, Professor Hasna. It's fantastic. I was actually going to ask you about the Embrel, but you've nicely summarized this at the end. So I think the point from your talk is that with new imaging, 50% of patients with ankylosing spondylitis may have posterior segment disease. It just how severe is it to become clinically obvious, and also whether we're doing imaging enough in those patients or not, right?
Yes.
So if you have patients on Embrel do you automatically advise, for example, let's say I have ankylosing spondylitis patients on Enbrel, do you automatically advise change or only if they are getting recurrent uveitis?
I think I work with a rheumatologist, and I see their patient regularly. We make work when I was in the hospital about interferon complication, and since this time I ask her to send me their patients, not only if they have uveitis.
Right, but unless they're having recurrent uveitis on the Enbrel, you would not advise like changing the medicine, right?
It's the first case which I see, but I have a patient who has tuberculosis, tuberculosis after taking Enbrel.
Right. Because we have a good number of patients here on Enbrel, and they have had ankylosing spondylitis in the past. But usually what I do is if they are not getting like repeated eye inflammation flare-up, I just leave them on the Enbrel, and I tell the patient and the doctor that maybe Enbrel is not the best medicine for the eye, but let's continue to see what happens. We have a good number of patients on them. That's interesting.
Dr. Salim, may I ask you, it's Dina here.
Please, yes. So yes, welcome.
Thank you for the invitation, and thank you, Dr. Hasnain, for your very enlightening case. Now I'm thinking, should I get OCT and possibly OCTA on the patients with recurrent or severe HLA B27 related uveitis? Would you recommend that? Would you recommend changing the screening for those patients with going to multimodal imaging?
Professor Hasna? Yeah.
Yes, I think when we have anterior uveitis, we must check the posterior segments. It's obligatory, and we must do also angiography for peripheral vascularitis. It's not seen in the ophthalmic exam, and OCT must be done because all uveitis can be complicated by macular edema, by cystoid macular edema.
Absolutely, that's a great take home. Thank you, Dr. Hasnain. Thank you very much.
Yes, I agree. I think there are great take-home messages from Dr. Hasna, Professor Hasna's presentation. One about the Enbrel, and it's good to just be aware that Enbrel does not treat uveitis well for some reason. We don't know if it's the attachment of the Enbrel to the TNF is not as solid as the attachment, for example, of Humira to the TNF. So then the TNF falls off and it releases, and then the TNF is released, and that causes inflammation. But if this is the case, why does it work for joint disease? Or it's the type of receptors they are working on. So it's not clear, but it doesn't work for uveitis, and it even may cause paradoxical uveitis, just for people to be aware. And I think the second take-home note is that 50% of patients with ankylosing spondylitis may have some perceived segment disease, vasculitis, or choroidal thickness, and at some time that might be very significant and require treatment. So it's a great point to take home. So, so Professor Hasna, in the context for people following us who are into general ophthalmology or interested in the differential diagnosis, so what would be your main differential diagnosis in a case like this with ischemic vasculitis?
If my patient don't have ischemic vasculitis, but we can have ischemic vasculitis. This time we must complete with the laser photocoagulation and to reinforce the corticosteroids.
Okay, yeah, sorry, I'm sorry for that. Yeah, non-ischemic vascular. So would you think Behçet, especially in that part of, in your part of the world, in the Middle East, would be one of the top differential diagnoses in your case?
I don't understand what you
Would Behçet be an important differential diagnosis? Behçet disease, Behçet?
Basically, no, she don't have Behçet disease. She have very specific joints lesion. Spondylodicity is very net in the eye MRI.
So you exclude Behçet
But
based
we
on the.
have when we have ischemic vasculitis, we search for tuberculosis in our context, and we look for Behçet. It's sure we have a lot of patients who have Behçet.
Okay, excellent. All right. Well, thank you so much, Professor Hasna. And now our next speaker is Dr. Dina Badar, who's a uveitis and medical retina specialist in Cairo as well. Dina, thank you so much for being with us here. Please go ahead.
Thank you very much for the invitation. I will start sharing my screen. All right, can you see my screen?
Yes.
All right, very good. Okay. All right. Okay, so as my title says, I'm presenting a barn of varicella. So this is a 38-year-old seemingly healthy male patient who comes in for a second opinion regarding his floaters and drop of vision in the right eye mainly, but and he's also suffered binocular diplopia 20 days before the ocular symptoms. He had the referring doctor had already ordered serum immunoglobulin levels for viruses and a prescription of valganciclovir. So these are the images of the back of his eye in both eyes. Now we can appreciate that though the vision is still intact. So we're looking at 0.8 and 1.0 in the left eye, some AC cells, but also there are multiple retinal lesions in the periphery in both eyes associated with some vasculitis and possibly a confluence in the left eye. So what I do now, because we don't have ICG, is that I use the multicolor imaging for looking at the choroid and the retina. So if I choose the green channel, is 100% green image, I can appreciate the retina better. And if I use the red channel, I can see the choroid better. So we can see that the lesions are mostly retinal and that the vasculitis is well demonstrated on the green channel. What I also do is that I, those heat maps, the thickness maps on the OCT, they showed vasculitis in both eyes pretty extensively in the macula. The OCT-B scan, can you see it or I need to hide? Okay, I don't need to hide this. Okay. All right, so the OCT-B scans, you can see the amount of cell in the hyaloid, but not a lot of inflammation affecting the macula, and that's why the vision is still okay. But now this is something that I do, and we do our images ourselves in Egypt, is that I scan the lesions in order to understand more about the pathology. So as you can see, the pathology here is mostly retinal. There's, yes, thickening of the underlying choroid, but the RPE is more or less spared, more or less intact. So we're looking at a lesion that is retinal with a lot of vitreous cell actually overlying the lesion. So I do my regular workup. I do the baseline. The already patient had the serum viral levels ordered. I do the ACE and quantiferin TB, and I do the CT chest, and the patient had already had the prescription. So these are his results. The serum viral levels came back high positive for both VZV and CMV. He also had a CT chest that shows an enlarged thymus gland. Now, I'm an eye doctor. I don't know what to do with this info. So I referred him to the cardiothoracic surgery because this is viral retinitis and it's a very serious disease. I don't know if the patient is immunosuppressed or what's happening. So the patient comes back. He has not started treatment and the lesions are becoming more confluent and they're taking a circumferential spread, very typical of acute retinal necrosis, but I am still confused. Is this possibly VZV or CMV, which is something that, you know, even if you're not a uveitis person, you can meet in everyday practice. So the patient finally started his valganciclovir, and we're still thinking, is this CMV or VZV? But actually the lesions have responded quite well, and we can appreciate that the retinitis has reduced in size and is becoming more fibrous and less active. So we did the AC tap, and for that we needed to schedule OR, and I know it's different from in different parts of the world, but in Egypt here I prefer to do them in an OR. So I tapped him and I also injected ganciclovir. And finally, the viruses are back, and it's very similar to zoster, but the patient still did very well with valganciclovir. However, when I referred the patient to infectious disease, we agreed to shift the patient to Valtrex. And also with ultra-wide field imaging, we can appreciate that the patient had like hiding lesions in the nasal quadrant. They look like their borders are getting more well demarcated and they are on their way to becoming better and more quiescent, but we started the Valtrex with liaison with the infectious disease. So the patient is now on 2 grams of valacyclovir TID, and we continue to do injections for the right eye because it augments the treatment, and the lesions have all subsided in the right eye. The left eye did not need any injections, only with systemic medications. The patient is not immunosuppressed. So the reason why I'm presenting this patient is to invite all the younger generations and everybody who's not a uveitis person to learn the features of infection easily with multimodal imaging and get the scans on the lesions themselves, which can tell us whether this is possibly toxo. This does not look like toxo. Is this retinal? Is this choroidal? It sort of narrows down the differential while you're in the clinic and talking to the patient about the possibility for his uveitis, right? And also take a prompt action. So you can, and I've learned this from Dr. Salem himself, like start antivirals, but also refer the patient to either infectious disease, cardiac surgery. It really depends on the workup of the patient and systemically how the patient looks. Like if you think your patient has HIV, work them up for HIV and refer them to your colleague. And also, I've gladly learned that valganciclovir does cover VZV infections, although we know that Valtrex is the mainstay for treatment of VZV. Thank you very much for your attention.
Thank you so much, Dina. This is a great case, and it opens the room for excellent discussion. So we had a similar situation where in the past, that again, the same confusion, and yes, it's good to know that valganciclovir does cover herpes simplex and herpes zoster as well as CMV, just as a toxic medicine. That's
I understand.
As well,
I fully understand. The patient has had the prescription. It's also for where I practice, it's very expensive, like seriously expensive, very hard to find, and patients pay out of pocket. But the patient has had already the treatment, and I was like, you know what, if you have it, if you're happy to start it, go ahead. Just a couple of days before we can get the tap and inject.
Yeah, I think great point. So Professor Hassan, if you're still with us, can I just ask you, for the sake of the discussion, what would be your differential diagnosis in patients presenting with retinitis? So let's say we have a patient now presenting to you with retinitis, same age as Dr. Baddar's patient. How would you think of the differential diagnosis of retinitis?
We we don't have a lot of CMV. I don't see, because there is another center who is specialist for this patient. But it's too difficult to find the treatment in our country for VIH patient. There are center for them, but for other patients, no.
You have access in Morocco to do viral PCR and toxoplasma PCR from the vitreous
Yes.
or from the AC?
Yes, we can do it. Yes.
Is that like simple to do in the clinic, or you have to take patients to operating room?
No, we can do it in the clinic. We can do
You
it
can
in the
do it in the
clinic.
clinic. Yeah, that makes life
uh,
easier, of course. Yes.
Only we must find the laboratory who can treat this.
Right.
Yes.
That's interesting. Okay, well, I have a case that may tie well with Dr. Dina's case, and then maybe after that we can have a discussion about the retinitis more. So I'll share the
Great.
quick.
I know you like that kind of challenging cases.
Yeah, no, it's actually it's interesting. It ties very nicely. So
I have one patient who has a very extensive occlusive retinitis and vasculitis, and all the investigation was negative. I don't find what is the problem. It's like CMV, but CMV was negative. He don't have VIH. He don't have anything. Only very extensive necrosis retinitis, and after when I don't find anything, I make him boluses of corticoid with aspirin, and after he has a good evolution, make laser on the ischemic zones, and he comes with 110 for acuity, and now he's 1010, and this is I follow him for now since 8 or 9 years, and until now I don't know what he have. Perhaps herpes, perhaps, I don't know.
that's interesting. Is he still on antiviral or?
Antiviral? Yes, I gave
He's
him
still on.
antiviral.
Is he still on systemic?
No.
So maybe a good question. Yeah.
Only
Yeah,
aspirin.
right. So maybe a good question to Dr. Dina before actually we move to the next presentation, since we have good time left. I think two questions, Dina. One is how long do you keep those patients on antiviral? And Valtrex 2 gram TID is a high dose. So you maintain the high dose for how long, and then how long do you keep them in general on the antiviral? And my second question is, do you use systemic steroids?
Very good questions. So the first question is, how long did we keep them? So I was working with infectious disease, and we decided, like, by the 3rd week, all the edges of the lesions were gone, and also we were augmenting with intravitreal. So we dropped him to half the dose. We dropped him to the maintenance dose, which interestingly he was still on when he left, because he got a job in Saudi Arabia. And I was like, you know what? I don't want nothing happening to you when you're only starting work there. So he's a young chap, he needs his eyes. And interestingly, when we took down his antivirals, he started having some vitritis, some sort of, I would not call it immune recovery uveitis, but I think I would believe that this is like an autoimmune process rather than an infectious process. And I started using steroids on him because also he was developing some fibrosis at the place where the retinitis was. And I really wanted to reduce this as much as possible. I consulted with VR, and they said, you know what, let it sit there, just watch it. And so I put him on some steroids, reduced it, and then but I have not completely stopped. Like I'm keeping a maintenance dose, and he's now in Saudi.
And how long has he been on antiviral now, the Valtrex, like altogether? So months?
I want to say 2 to 3 months.
2 to 3 months. And what's the plan? Is to keep him for what's your usual in another patient who, for example?
No, I would stop. Like I would watch them happily for I do, you know, like I do Cariat on everybody, and I watch them for, you know, 3 months, and then I take them off, but bring them back on a schedule. Like,
yeah, I mean, I think in this particular case, it's interesting and a bit nerve-wracking because it was bilateral as well, right?
yeah, and he was very young, and you know, like some people may have something happening, and I didn't know. I personally don't know anything about thymus glands. Like, if you ask me. I don't know why this patient had large thymus, and you know, it could be a sequestration site for his white blood cells, but his white blood count was okay. Is it related to the function? Is it related to him changing careers and moving? Did he have this flare of VZV? I still don't know.
Excellent. No, that's it's a great case, and I'm glad this patient did so well. Share my. Can you see my slide?
Yeah, perfect.
So this was one of our uveitis grand round cases, and my colleagues Eric Clegg, who was our resident at that time, he finished now. He just graduated, and Dr. Sanders was our current fellow, our previous fellow, and now graduated as well. So this is a patient who was hospitalized and was referred mainly to rule out fungal chorioretinitis because the patient had some eye. It wasn't really clear if she has some eye findings or not, but we were told to have a look on her. And usually we look at those patients not very urgently, especially if they are on antifungal medicine. But the story is this 27-year-old, she had AML, was after chemotherapy, and she went on to have bone marrow transplant. And she was admitted for a neurotrophic fever, and she was on lots of medications and was found to have candidemia, and there was no vision complaints. Although when we asked the patient, she said, actually, my vision is a bit blurred. Occasional headaches, joints pain. Otherwise, everything else is negative, and no other reported post-ocular history. And then this is her medical history. We know about the AML. We know that she had opportunistic infection. She had CMV viremia following the transplant that treated with antiviral. And she, of course, had the pancytopenia and electrolyte abnormalities. So nothing, she's married, single relationship, and no smoking. And she's, of course, on a list of medicines here. I'll point out the important medicines, which are the top one, acyclovir, is one of the important, I think we may need to know. And also letermovir, it's another antiviral here. And then she also she's on voriconazole at the bottom, as well as immunosuppression with tacrolimus. This is the situation here. Everything looks fine with the anterior segment and her vision. And these are her fundus pictures. So we said, fine, nothing really to do. I think it's not showing on that slide, but we show one area of cottonwood spot. And then because of that, which was not really shown in that picture, but we said, okay, we'll see her again in 2 weeks. So then she came back, and at that time she had fever and was readmitted, and now reporting significant blurring of vision. Her medicines are still the same. So she's antifungal, bacterial, and the medicines we talked about, the viruses. This is the situation now, 20/70 in the right eye with this visual field defect on confrontation. And that's the appearance now. So this is the right eye. We can see those lesions. So as Dr. Dina said, and again, Professor Hassan as well earlier, it's good to characterize the lesion as was done in both presentations. So we're trying to think of the lesion. This is again scanning over the macula and over the lesion to try to understand more about the lesion. And you can see here lots of things. You can see the macular edema, the subretinal fluid, the inflammation, and more important, the area of the problem, which is the retinitis here. And you can see the scleroidal inflammation as well, but the lesion is mainly of retinitis. And you can see that the retina is not only thickened, it's thickened, but it's also the boundaries are blurred, the layers are blurred. You cannot differentiate the layers. So the retina itself is inflamed. So we're dealing with retinochoroiditis here, which is bilateral in this patient. So that's the situation we're dealing with. And this is a big list here of differential diagnosis. So we like this way of classification: infection, inflammation, and masquerade. So infection, we go with bacterial, viral, fungal, protozoal. And with inflammation, we try to think what are the important diseases that cause retinitis in these patients. And the top one is, of course, Behçet. I mean, sarcoid can cause retinitis, but mainly it's choroidal rather than retinitis. But again, it can cause just retinitis as well. And then masquerades, we have leukemia and lymphoma, and this patient already had AML. And then, I mean, you can add vascular as well. So the retinal opacification or PAM with vascular occlusion. So the question is, in this patient, what to do? And this is the situation right now, and the patient has significant problems with the vision now. She has the right eye, the left eye findings, so it's bilateral, but the right eye is the main area. This is the area there with hemorrhages, center involvement, and then you got the peripheral area as well. I think one of the things to take home is always that in the context of retinitis, first thing you have to exclude infection before deciding that this is, for example, Behçet. And then at the end, especially if it's a patient, but not like this patient, if a patient who is fit and well, then you can think of lymphoma a bit later on, unless there are compelling signs from the beginning. But that's how I think about it. Okay, well, retinitis, this is mostly we're dealing with infection, unless it ends up being Behçet. So, and then infection, we go like, as we said, bacterial, viral, fungal, protozoa. So in this patient, I was thinking that this is virus, a bilateral disease, and the patient is immunosuppressed. One thing did not add up, that the patient was already on antiviral medicine. And I thought maybe she was on acyclovir, it's not that potent. But she was also on the other medicine, letermovir, which is a very potent antiviral medicine. So this is what we usually do in this situation. So we cover for viral. So we do intravitreal, tap and inject. And we send AC tap or vitreous tap, depending on how things go, or viral PCR and toxoplasmosis. And then we check CD4 count to know just what's the situation of immunity for this patient. And we recommended at that point valacyclovir, but to be honest, at that point, I was not really knowing much about the letermovir and how potent is it. And the infection disease, we're saying, is very, very unlikely she's on potent antiviral medicine, but they went on with us with what we discussed. So here, and then this is her, the CD4 count was 15, so we know that she has low count and probably low function as well, even sometimes more important. And her viral level PCR, where the viral PCR were negative for herpes simplex, herpes zoster, and CMV. So what are you thinking of now? And again, if we go to the list now, that list includes syphilis. It doesn't look like this. And we had bloods, and the bloods were negative for syphilis. So one thing to always think of is toxoplasma in immunosuppressed host, because it can be.
I'm just going to ask you about the IUP.
About the toxoplasma?
The IUP, the pressure, the pressure.
Oh, the IOP, I think was fine. The intraocular pressure was fine. I can't recall it was high. So this patient had toxoplasma PCR, which again, in immunosuppressed host, I mean, this is the usual appearance of toxoplasma. It may even present with primary focal retinitis, even without a scar, but still in the posterior pole, and that's easy to diagnose. But we need to remember it may present in different ways, especially in immunosuppressed host. This is, for example, a patient of mine that presented who was immunosuppressed because of rheumatoid arthritis, immunosuppressive medicines, including methotrexate and steroids for a long time, and was presenting with this progressive retinitis, which heals then progresses, and ended up being not a viral retinitis, but toxoplasma retinitis. So I think this point takes us that toxoplasma can present like viral retinitis in the immunosuppressed host. Maybe I should have thought of it from the beginning, because the patient was already on antiviral medicine. So then the next one was like to think of was toxoplasma. But I just want to remind you again of this differential diagnosis. I think retinitis is an easy one. The reason is that it's usually infection, unless it ends up being like Behçet or lymphoma. So it's really easy one. It's you know that you're most likely dealing with infection when you have retinitis. I'll stop here, and we can maybe chat more about the retinitis and the differential diagnosis. Just get the Zoom. Sorry, Dina, do you have any other comments on this case or on retinitis?
Well, this case is very telling. Like, the patient is on antifungal, antiviral, and also, but she's also on tacrolimus, I believe. So she
was on tacrolimus, yes.
And
she had significant chemotherapy before and bone marrow suppression. She's immunosuppressed.
Yeah.
Another question on these leukemia case lesions, because she had AML.
Yeah, so I mean, the lesions are very close to the vessel, which could be infiltrative. Like, you could think of infiltrative, but also toxo has an affinity to the vessels. So it's a very good case, and those cases, they're never straightforward, in my opinion. I think when you get those kind of retinitis patients, you need to sort of stop the clinic and give them a lot of thinking and time.
And Professor Hasna, any comments?
Immunosuppressive modified clinical the clinical symptoms. The inflammation is more or less than the normal persons.
Yes.
That's why we have only this. We don't have vitritis, and we have only the retinitis.
Yes, and I think that's why it makes toxoplasma present like viral retinitis. So it's bilateral and also multifocal, which is not very, not the typical presentation of toxoplasma, which is usually a unilateral issue at least at presentation and unifocal, and more like in the posterior pole. So I think, as you say, yeah, of course, it's immunosuppression changes the presentation. We even had one patient who presented similarly, although was unilateral, with aggressive toxoplasma and multifocal like viral retinitis. And that patient was 75-year-old. And that was reported as well, that even in elderly, I mean, for some reason, they get like some sort of immunosuppression of the T cell function. And it may present in a weird way. It may present like viral retinitis. Just being old can cause the toxoplasma to present like this. So something as well to take.
Yeah.
We had a case yesterday. Yeah, sorry, go ahead.
I'm sorry. Do we have time for, can I?
Yes,
can I
yes,
take
we
it?
have a few more minutes, yes.
Okay, so I was just gonna ask you, Dr. Hassan and Dr. Salim, about young patients that that present with vascular occlusions. That is a vascular occlusion for, you know, like a coagulopathy, but they kind of look confusing as to being inflammatory. Do you see that in your practice? Like a 16-year-old with a vascular occlusion, and she's referred because they're thinking it's inflammatory, but in fact it's a hypercoagulability of the sort. Do you see that in your practice?
Yes, we see these patients, and sometimes they end up having antiphospholipid syndrome. Sometimes we don't have anything. I think it's sometimes difficult to differentiate between inflammation and just vascular occlusion, because with vascular occlusion, you also, you know, have features of even sheathing. Sometimes they say continuous sheathing is more with like just vascular, while interrupted sheathing is more with inflammation. I think it's a difficult one to diagnose. But you're right, in this context, and maybe that extends the discussion that I was having with Professor Hasna, with occlusive vasculitis, and as she said, TB and Behçet disease are most important. Other causes includes, which we discussed some yesterday. Sorry, there's this, what's the syndrome that affects the ear and the brain?
Susac?
Yes, Susac as well.
Yeah.
Although that presents like usually with like a unifocal lesion rather than like a branch
arterial.
Yes, more arterial, more like a branch artery occlusion. And then syphilis and viral, they cause occlusive vasculitis as well, but they cause other things. So that they may cause retinitis in addition to the occlusive vasculitis. We had a case for
Yeah, go ahead, sir.
Please go ahead.
No, I'm good. I was just gonna ask Dr. Hasnan because she practices in.
Yes, Professor Hasna, please go ahead.
And like how much do you see like intermarriages and then like inherited coagulopathies and inherited vascular diseases, collagen diseases? How much do you see? How often do you see this?
I have one patient with occlusive vasculitis, and he was treated as Behçet syndrome, and well, because his vasculitis relapses, we decide to give him TNF alpha, and we make a check of tuberculosis, and we find that tuberculosis was quantiferon was positive. So we make him under preventive treatment of tuberculosis, and all the lesion, retinal lesion disappear. So it was tuberculosis uveitis. Yes, sometimes it's very difficult to know what is the diagnosis and what is the etiology of the vasculitis.
Yeah.
So that patient, you diagnose him mainly as TB or not Behçet, and did you maintain his immunosuppression as well as with the anti-TB treatment, or?
No, we give him in the beginning. We give him only preventive treatment, and then we give him a full treatment of tuberculosis, and all the lesions disappear.
And no immunosuppression.
No immunosuppressor, because he have many times immunosuppressor, and the uveitis relapse at every 3 months or every 6 months. Uveitis relapse. So after we give him the tuberculosis treatment, I never see him after.
Right. Right. Yeah. So I think it's interesting. Behçet is very common in the Middle East, but it needs to be more of like a diagnosis of exclusion, right? Because you need to exclude other things. Because basically it's a clinical diagnosis, right? You have the picture in the eye as well as the systemic features, and more or less it's a clinical diagnosis.
In tuberculosis?
No, Behçet. So what I'm saying is, how do you diagnose Behçet? I mean, for example, if we're teaching about how to make a diagnosis with confidence that this is a case of Behçet, what would you say, Professor Hasna?
For diagnosis of patient, it's a difficult question. We must ask the patient if they how it began, what is his environment, if he has someone in his family has tuberculosis or other infection. When he leave, we find some uveitis similar to Lyme infection. We make a minimal, first we make a minimal investigation to have an orientation, and if I work with rheumatologist and with the internist, and we can find the most the minimal investigation to have a diagnosis. And sometimes clinically we can say this is HLA-B 27 uveitis, when the pain is very important, when there is a red eye and photophobia. It's easy to think to HLA prevention, but when we have only some things like vitritis, vasculitis, it's difficult to find that etiology. And in the best center, only 60% of the uveitis have a diagnosis.
Yes, no, of course. I was just trying to, come up with a conclusion that maybe that, just be careful, and especially in the Middle East, Behçet is common, but be careful of things that can look like Behçet. Most important, because of the retinitis, make sure you're not misdiagnosing a viral retinitis as Behçet, because the treatment is very different and patients try to get worse. The other thing, like a case we saw yesterday from Egypt as well, was a syphilis patient that was diagnosed as Behçet and put on immunosuppression, just because syphilis is not common in Egypt and people are thinking more of Behçet. So I think just wait a little bit, investigate, at least to exclude syphilis and TB. They should be easy to exclude by history and by test, and just think about viral retinitis. At least ask the question, is this a viral retinitis? So that's what I was, pardon?
In uveitis, we must eliminate infection before treat the patient, because corticosteroid must be done in these cases without infectious treatment.
Yes, I think that's a great point. I think with this that can be like a great take-home message for the end of this talk. Dina, do you have anything else to add before we conclude?
Oh, thank you very much, Ahmed, for putting this together. And I've learned so much from the cases presented. And if you want me to say one comment about Behçet in Egypt, is that like Behçet is never a slowly brewing disease. Like my experience with Behçet in Egypt is a very, very aggressive disease. Like the patient is usually has a venous occlusion somewhere, post-phlebitic limb already, it's not an anterior lung granulomatous uveitis kind of disease.
That's a great point. I think that's why I just have a moment and think about like the other cause of retinitis, which are mainly infectious, before you conclude that this is syphilis. this is Behçet. I think if you miss, for example, HB27 disease with Behçet, treatment is more or less the same, but the problem is you don't want to miss syphilis or toxoplasma retinitis or viral retinitis for Behçet. Well, we're coming to the end of the talk, and I can see Dr. Mohammed here signaling the end of the talk. So thank you so much, Dr. Dina Badar from Egypt and Professor Hassan Al-Umari from Morocco. It was a great session, and thank you so much.
Thank you very much,
Mohammed, back
Dr.
to you.
Ahmed. Yeah, thanks a lot. Dr. Hassan, you can join in Hall B. They are waiting for you for the other sessions. Thank you, Dr. Adina. Nice to see you again.
Thank you,
Dr.
Dr.
Ahmed, thanks a lot. Just an announce for all dear colleagues. In Hall A, there will be no session from 4 to 5 UAE time, so you can join Hall B. It will be a refractive session, interesting session with an eminent speaker, please. Thank you very much.
Thank you.
Thank you. So here we can just close this room for a while till 15 minutes before the next session management here. Okay.
Hi, Dr. Safa. Hi, management.
Hi, ma'am.
Nobody joined?
There are few doctors here.
Hello, Dr. Fatima.
Hi. Hi, how are you, Dr. Rafi?
Yes,
Nice,
yes. Good to
nice
see
to
you.
see you again.
Yes, absolutely.
How are you? How's everything?
Wonderful.
Yeah.
Hello, everyone.
Hello,
Hi.
Dr.
Hi, Dr. Hannah, how are you?
I'm fine, thank you. Thank you.
Yeah. Thank you.
So we have 10 minutes, right?
Yeah.
Thank you.
Dr. Fatima, your face isn't visible. It's the background illumination.
Okay. Hello? Hello? Okay, fine. I will do. I will.
Hello, good morning, everyone.
Only refraction where my high order abrasion sheet doesn't show a negative spherical abrasion.
Hi, do you hear me?
Yes,
Hi,
hi.
Hi.
Hi, doctor, how are you?
Hi, how are you all? I'm
Fine,
happy to see you. There's some one of you that I already know, just like my friend, my dear Dalila, Dr. Fatima. We talked before. Dr. Parol, I really admire you from far. I knew you since 2 years, but I've never known you in person. So I'm really glad today to be here. Dalila, welcome.
Hi,
Forward to meeting
how are
you.
you?
دكتورة فاطمة السلام عليكم ازيكم؟
الحمد لله.
Everything fine. Oh, I just want to mention something. Today we have Moroccan guests in an Anglophone meeting, and they get out from their comfort zone because our second language is French. We try and we struggle with English to understand and to be understood. So we'll have Dr. Dalila Swa'i from Morocco and Professor Ketani Asma also from Morocco. And we will enjoy this meeting. It will be a nice session, I think. Who's here? Dr. Ibtisam is here. اسماء الكتاني non plus. We have still 10 minutes before.
Yes.
Yeah, we will wait for somebody to join us also.
Let's wait.
No, I didn't see her.
No, she's not here.
I will call her.
How was your sessions, Dr. Parol? It was okay?
Yeah, everything went well. It's like an extended family now.
Yeah, I saw your yesterday's session about glaucoma. It was really interesting. I congratulate you. It was great.
Thank you so much. It was all the speakers had such a good variety of cases. It was really interesting.
Yeah.
I look
That's it.
forward to meeting you at this MIOM the coming year.
Yeah, we will meet each other and we will have fun, of course. We will not speak ophthalmology, we will not speak science, we will enjoy being what we are.
Absolutely looking forward to that.
السلام عليكم دكتورة ابتسام.
عليكم السلام، أهلا، الحمد لله. كيف حالك دكتورة؟
I see her for the first time. So
Nice to meet you دكتورة.
That's same. تشرفنا.
حبيبتي. دكتورة فاطمة I think not yet joined صح؟
لا هي هنا بس في الضلمة كده عاملة جو رومانسي.
أنا
مش عارفة هي عاملة جو رومانسي كده.
أنا فتحت غرضي الانيميشن. هسه
احنا محترمين التوقيت بس عارفين اني مش ضلمة عندكم للدرجة دي. خلاص
أبين ولا ما مش شايفة نفسي. أهلين ابتسام، كيف الحال؟
الحمد لله، الله يسلمك. أخبارك؟
أنا مو مبينة معاكم من؟
كيف؟
أنا مش شايفة نفسي.
واحنا برضو مش شايفينك، احنا متخيلين حاجة وراكي كده بيضة وانتي لابسة حاجة كده بينك بس التفاصيل مفيش. vous êtes à contre-jour. هي اللايتس من ورا، لما بتكون اللايتس من ورا مش هتظهري. يعني لف كده، لف الكمبيوتر عشان النور يكون facing your face not against the computer. Do you hear me دكتورة فاطمة؟ دكتورة فاطمة راحت مننا.
شكلها بتضبط
شكلها راحت مننا. كلمي صاحبتك.
خليني اشوفها.
J'appelle تاني.
Oui. Parce que là, on est 14h11. Normalement, il est censé être connecté pour les essais.
I will see if my other colleague is struggling with the meeting or everything is okay. So I will call her. I will mute myself to call her.
أنا موجودة ولا لا؟
صوتك موجود بس أنا أشوفك.
لا هو أنت موجودة. أنت موجودة.
بس كده أحسن.
بس في
أنت موجودة بس just try to rotate the computer. حاولي تكون وشك عشان نشوفك ويكون الكمبيوتر ظهره للشرج. مش كده تسموه الشرج عندكم؟
الشمس مظلمة عليك. أيوة.
كده أحسن. منورة. كده أحسن. دكتورة هلا. هاي.
Hello. Hi.
How are you?
أيوة.
good, thank you.
الستاير كلها. خلاص طكيت الستاير كلها.
كده أنت شايفة نفسك كده؟
أهلين.
الحمد لله. دقيقة أكلم أستاذ الكتاني. التليفون مش شغال. 2 minutes and we'll start.
أنا مش شايفة نفسي معاكم.
جد؟
ما شايفينك.
احنا شايفينك. انت حاسبي بس احنا شايفينك.
اوكي ما اسوي حركات يعني.
No. Maybe we can start and she will join us. 15.
1 minute more. I think we can
Yeah,
start.
okay. Yes. She told me that she was traveling. She came from Marrakesh. She did the trip, walking trip. How we call that? Les randonnées. When we go to mountains and like that.
Yes, hiking.
Hiking. عليكي نور.
Hiking.
We are struggling with English. It's not our comfort zone. We speak French. I proceed. So let's pass if we miss some words. If we will Google it and tell it after. So thanks to the technology, we will try to do our best to be understood. So if it's time, yes, maybe we can start. دكتورة فاطمة، دكتور ابتسام، إلكم الشرف تفتتحوا الجلسة. إحنا ضيوف عندكم. We are our guests. You are your guests. So go ahead.
دكتورة فاطمة تفتح. دكتورة فاطمة.
نعم.
افتتحي الجلسة.
يلا. اوكي
هي مدام مش شايفة نفسها مش هتتكلم. شوفوا لها make her see herself, because she doesn't see herself she will not speak.
Okay, I'm trying to. Okay. يلا بسم الله الرحمن الرحيم. السلام عليكم.
السلام ورحمة الله تعالى وبركاته.
Good evening, everyone. My pleasure. It's okay for me. It's okay for me. Good evening, everyone. My pleasure today to among this beautiful lady to start our session. And
someone have an echo in the mic.
It's echo.
I think it's best that everybody mutes until it's their turn to speak. This is how we don't get an echo.
Yeah. Okay, بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everyone. You're most welcome to our eighth QOIC conference. And my full thanks to Dr. Mohammed Al-Umari, who will arrange for us this conference.
دكتورة فاطمة, maybe the echo is from you. Maybe من المايك اللي عندك, لأنه فضل الإيكو بعد ما اتكلمنا. We still heard the echo after we muted ourselves. So maybe it's from the mic of Dr. Fatma, but it's okay. It's not that's not that important. We can hear you very well. صح? Do you hear her? Yeah, we hear her. So maybe we can. Dr. Abtisam, you are muted. Just unmute yourself.
دكتورة فاطمة, go on. خلاص, it's okay. I think it's fine. You can go on, Dr. Fatma.
Did you hear me now?
Yes.
Now it's better. Now it's without echo. Yes.
Okay, fine.
You can go on. خلاص. We will mute ourselves.
Okay, Dr. Safa, would you please go ahead and start our session?
Oh, yes, of course. Well, I'm really happy and delighted to be between and among you all today. There's some friend I already know, my dear Dalila from Morocco too. And there are so many among you that I heard and I heard from and respect from far since years. Dr. Hala, Dr. Parol, Dr. Ibtisam, and Dr. Fatma. I'm a member of MEON board since some few months, and I heard about your work, and I really admire you all. Well, today's session, we will make it a special session because we are special. We will not speak about ophthalmology. We all know what is glaucoma, what is refractive, what is cataract. We want it to be a friendly session, a dynamic session, and a beautiful session like all of us. So I will start by introducing myself, because many of you don't know me, as I don't know you in person too. I'm Safa Jihad. I'm 41 woman, Moroccan woman, and I'm married since 20 years. I have 3 children, 17, 13, and 7 years old, 2 boys and 1 girl. And I'm the third of a sibling of 4. I have 2 sisters and 1 brother that I adore. I lost my daddy years ago, and I have my mom that I entertain with her, a very special relationship. I'm trying to see her nearly daily. In spite of all those details, those boring details. I'm an ophthalmologist. I worked in the public sector for years, 10 or 11 years. Then I left and I decided to open my own clinic, my small own clinic. It's not a clinic like you imagine. I worked in many cities of Morocco with the public service. Then I opened my own office in Casablanca. My subspecialty is cataract, refractive, and keratoconus. Why am I telling you all those details? Because I believe that each one of us has those tiny details in her life that make her what she is really. It can make us sometimes impulsive, sometimes nervous, sometimes happy without reason, sometimes sad without reason. And I want to make this session to allow all the attendees, the women attendees, to maybe to find themselves in the journey of one or the other of each of us. So maybe we'll start by, and maybe we can allow to the man, the male also, to see their female colleague under another prism, without gloves and je sais pas quoi, Charlotte. We are women. We have lives, and we deserve to be here fully. So let's start by a round table. Maybe we can introduce ourselves to know each other better. Let's go. The stage is yours. Go ahead. Start by maybe Dr. Ibtisam.
Yes, I'm Ibtisam Mohsen Sajwani from Sharjah, United Arab Emirates, working in Al Qasimi Hospital. I'm the oldest in my between my sisters and brothers, 3 sisters and 1 brother. One of my sister is, as you said, she likes mountains and go for hiking, and now understand how is enjoyable going for hiking, being in the nature, away from stress of ophthalmology, medicine, and any stress in life. I'm married and I have 4 children, 14 and 11 years old, 7 to 8 years old, and 4 years old. I know that's not easy. I
unmute myself just to congratulate you to survive after 4.
Yes.
Yeah, and to be able to work, because I have 3. I'm not so far from you, but I know that it's not that easy.
It's challenging. It's challenging.
Yeah.
But alhamdulillah.
Yeah, ربنا بيساعد. God helps. Yeah, God helps. So what's your subspecialty, Dr. Ibtisam?
Retina and cataract.
Oh.
Medical
You go
retina
deep
and
inside.
cataract.
So
Again?
you go deep inside.
Yes.
Retina.
No, I like retina. Maybe I like retina. For me, maybe I'm not much fond of refractive. But I really like retina, maybe because in my university, when I did my ophthalmology subspecialty, it was a very big center of retina. For rare retinal diseases, even Professor Haas in Germany. That's why maybe I had a great exposure to retina, and I like retina.
Nice, 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 nice.
I think many people in Al Qasim Hospital, they like it.
It's a hospital specialized in retina, or you do all subspecialties there?
We have a number of specialties, not all of them, but retina is one of the main specialties in Al Qasim Hospital.
Nice.
Dr. Fatma can tell us more about that. Maybe we'll give her the stage now.
Yes, if she
Dr. Fatma?
wants, you'll be welcome.
Okay, Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I'm Dr. Fatma Ibrahim Al-Amiri. I am from United Arab Emirates. I am from Sharjah. I am ophthalmologist. My interest in retina and uveitis. And I joined the Al Qasim Hospital since 1996. And mostly I am the senior ladies in my department. Now, after Dr. Thuraya, she was our head of department. And I'm married. I don't have children. I spent my life with my mother and father, and they passed away. Allah yarhamhum. And my mother, she passed away 4 months ago.
Oh, we're really sorry. We're really sorry. You know, that's why I told you that there are some tiny details in our lives that make us sensitive. Yeah, it's
really, my mother and father deal with me like they are my son and daughter, and I am their mother. And يعني بس الله يرحمهم إن شاء الله ويغمد إن شاء الله. And really, I interest in my field. I'm doing well in my field, and I hope everyone like me to be around. And in Al Qasim Hospital, we have around 10 doctors. We have different specialty, and we are tertiary hospital in Northern Emirates. And we received all the cases from Northern Emirates and from Oman also, and some surrounding Gulf area. They are coming to us. Really, we are very good in retina treatment. We have a retina surgeon, and we have retinal medical also. And among United Arab Emirates, we are one of the best center in government sector.
Good.
My hobby is really, I like to read too much. I like to travel, but
you know, I was looking before speaking to you. I was wondering. I was really thinking, what are my hobbies? I didn't found any hobby. Any really. It was so
ophthalmology is the hobby.
I swear.
I think nobody have a newspaper in their home except me till now.
And the paper version of newspaper, not only newspaper on the tablet. Oh, no. You are an addict. It's done for you. You are an addict. So I was, you know, I had in 28. I was working. I was still doing my fellowship in the hospital here in Morocco. And I begin to have some syncope. I don't know what is syncope in English. Syncope.
It's the same. It's
the
called
same.
syncope.
Nice. I get the syncope. And when they did the whole assessment and so on, they found nothing. I did it once, twice, 3 times, and they found some trouble in my heart rhythm. So the doctor, I went to France. I did so many battery of exploration inside. Well, I will tell you that after Google it. I will tell you what is it, electrostimulation. So. Yes. And after when I came
I have the same thing.
Oh, when I came back.
I have exactly the same thing.
The cardiologist, I was in rest. I was not running or nothing. And my heartbeat the rate reaches maybe 120 at rest. So it was, and I was doing like this while sitting without any effort. So my cardiologist told me, tell me what are the pleasing thing that you do in your life. I told him, and I had 2 children at this time. Told him when everything is okay, when I have no problem at work, when my husband is happy, when the children are okay. told me, no, I'm not asking about your tasks and your duties. I'm asking what's your things that make you happy. Do you like shopping? Do you like traveling? Do you like doing your nails? What do you love to do in life? And I found that it was nothing. Your problem is just here. Try to find something that make you happy. When you find this thing, you can, maybe it will be the window that's the bad things go through. And I really want to invite Dalila, my friend, to speak about her life, because she had one turning point in her life that's make her being total different person, and it was a health person, and we will invite her to speak about herself. She will not like me because I know she will struggle with her English, but she will help you. Just be yourself, okay? So Dalila, we hear you.
Thank you, Sabah. Hello, everybody. Masa Noor. It's a real pleasure to be with you this afternoon. I'm Dalila Idrissi, 48 years old, married, and the mother of 2 teenagers of 16 and 14 years old. I'm one of the exceptional women that we all are. Please, a great fan. And especially running and trials, coach and hypnotherapist, ophthalmologist specialized in inflammation and ocular. I also practice cataracts and glaucoma surgery. I work in the liberal sector in Casablanca, Morocco. I'm happy to be with you.
We are also happy. She got medals. She does semi-marathon. She runs just like we are breathing. She can run without feeling. She loves running, and but you had a health problem 10 years ago, I think, or something like this.
In 2018, during the Congress of French Society of Ophthalmology in Paris, I had unexpected respiratory distress. I've immediately been taken to the closed emergency hospital, and I was diagnosed with a pneumothorax of the whole lung, the etiology of which was diaphragmatic endometriosis, a very rare diagnosis, only 7 cases described in medical literature, which need around 3 weeks of hospitalization in intensive care.
In France.
In French, yes, in Paris.
And your children were still here?
In Morocco with my husband. And being taken to the operating room 2 times. Those moments were the most difficult moments of my life. I was alone by myself. I had to deal with this situation alone for the first 24 hours before my husband joined me. I had the chance to be hospitalized in one of the best structures in France, and my greatest luck was the surgeon who operated me. It's Professor Jancovici, to whom I would be very, very grateful life with the just exceptional human quality. Before this incident, I was an anxious and hypochondriac person. My anxiety ruined my life for many years. But after this incident, I made stop of my person, and I've realized that nothing happens by accident. I invited the desire so much that it presented itself widely. I realized for the first time in my life that I'm responsible somewhere, and realized that it's really urgent that I change by my beliefs, and that I do personal development work on myself. And it's from there that my life has changed wonderfully, and that I became my best versions, that I continue to improve every day.
Great, that's great. You passed the death passed just near under your nose, just like this.
Yes.
Alhamdulillah.
Yes.
Thank God. You were running before, or you began running after?
I running before, but after I ran more.
But
it's
you
like therapy for me.
you had this problem when you were running after ophthalmology in France. You had this problem. So stop running after ophthalmology. Let's invite Dr. Parol and Dr. Hala to speak a little bit about themselves. It's yours. Go ahead.
All right. Well, I'm Parul Ishpujani. I live in North India. I work in the government sector here, and I'm 45 years old. It's been 15 years since I'm working at my current place. I'm a glaucoma specialist, but I love to teach. So I have graduates and postgraduate students. So teaching them is cathartic for me, because I think when you go into depths of what you know and what you don't know, it really brings out a new aspect each time. And every student is different. And I've realized that knowing the student or the young doctors, it gives you a lot of insight into what's happening around you.
Makes you stay young when you, yeah, it makes you, at least your brain stay young with when you are teaching. We are frequenting young people.
Yes. And well, as you said, I don't really have any hobby which I can really talk about, but I do love to write. So I did find out my passion in writing books. It may look like ophthalmology continuing, but trust me, it's not. It's beyond that. When I'm crafting something and writing or editing something, it seems like as if I'm creating a new piece, a new attire. So that's kind of satisfactory for me.
Yeah, because those are your babies. They were nothing before, and after you can see it in front of you. This is just magic.
Yes. So I'm divorced, did not have a great or a long marriage, but I realized that it's better to be happy. I realized that it's better to be happy and take care of your own self. And there is so much in the world to give and to accept. It's just that I have to be receptive towards things.
That's it.
So, yes. So yeah, that's essentially about it.
That's wonderful. That's wonderful. You know, I just believe in something. We are happy. Maybe it's a feminine quality. We are happy when we see people around us happy.
Trust me. Yes. So even coming to this group, it's hardly been 15 minutes, but the joy and the warmth in everybody, it brings out the happiness.
Feminine quality. I think that male doesn't have this quality. They are happy when they are in peace with their mind. They're happy. But females, we can be struggling, tired, doing multitask. But when we see a smile here or there or something, thanking us for something we have done, it's erased all this pain and all this suffering that we had before. And so we're seeing the smile on your face, and you have a baby face. Have somebody tell you that before?
It's all the fat that is plumped it up, but whatever it is, I'm really thankful to life. And life has taught me one thing: we need to be thankful for a lot of things that we take for granted. And whether it's a health scare, whether it's the loss of a parent, whatever it is, it's all been there in the master plan. But we got to stay motivated to contribute every day and to be blessed with whatever we have.
Yes.
So yeah, these are life lessons which we learn with age. Yeah, I'm happy and blessed to be in the company of all of you. And
it's a great pleasure to share this moment with you. Dr. Hala, it's all yours now.
Thank you. I'm very, very happy to meet you all, really. So I'm Egyptian. I'm a professor of pediatric ophthalmology in Cairo University. I was born in Egypt, but my father was a urologist, and he moved to Canada, and we moved with him when I was 9 years old. And so I grew up there. My father became a very world famous urologist, and he groomed me or wanted me to follow in his footsteps and become a doctor. And this is what I did. I did it because I wanted to be like my dad. And I married again an ophthalmologist. He's a retinal specialist. Between us, we have 4 kids. We brought up 4 kids together. I have exactly the same problem as you. I get AF when I'm stressed, but it's only related to stress. My last episode was just 4 weeks ago. I was doing glaucoma, a GAT procedure for a one-eyed boy who had repair of retinal detachment. He had silicone oil in the anterior chamber.
On the good eye? On the good
the only eye. The only eye. I was doing the glaucoma surgery. His pressure was hitting the roof, and I developed AF on table while I was doing the surgery. I continued the surgery, but then I was moved to the ICU, and because of really severe AF, my heart was beating at 160 beats per minute. And as they were taking me away, and I thought, my God, I'm really sick. But had I known that this was going to happen, would I not have done the case? And I said, no, I would have still done the case. So
that's really great from you, because something we hear from our environments: manage yourself, try to be less stressed, those kind of advices that means really nothing for us, because
yes,
we don't choose to be what we are. We are like this. When we are involved in something, we do it with our hearts. We cannot stop. And when we stop when we cannot move. That's the really only thing that can make us stop in our place and not move.
Yeah.
But, the pediatric field is very
it is,
because we have a big compassion with children.
Yes.
So you are emotionally, you are at zero, and you need to take from your energy to give it. See, this is very difficult. There are some specialties that I could never do.
Mm-hmm.
Like oncology, pediatric oncology. It was really traumatic. I had the training in a pediatric service when I was in the medical school. And I told myself, Safa, you will never do something related to children. I cannot, my heart, I feel it squeezing when I have children in front of me that I cannot help. I will help, but he will suffer while treating him. It's difficult. I understand you, but having this attack in the OR make us put in the question to us, am I really obliged to continue this way? The answer is,
again, I don't have hobbies, so this is my hobby, working, treating people, and teaching. I agree totally that teaching is so rewarding and so gratifying. And when you see you give information to someone, or knowledge, you pass on knowledge, and you see the recipient's face and how grateful they are. Again, it's extremely gratifying. I love teaching, and maybe at the end, someday I will stop surgeries, but I think I will continue to teach.
But maybe we can ask, Dalila, I want to ask you a question. Tell me if we can find in our work enough pleasure to make it be our hobby. If we can take this pleasure, that's the satisfaction in front of patient, it can be enough for us. I know that you do personal coaching and something like this because you were really deep and you come in the surface after. But can we find in our work this energy that can make us fulfilled? I'm okay, I don't need anything more. Or there is a limit between the duty, le devoir, and the pleasure. Should it be a barrier and a difference between the two fields? If you block and you stop on some words, maybe I can help you, but still it's in French.
Really, yes, I improve pleasure to run and to work. The real problem is the lack of self-esteem. What's this self-esteem? It's quite simply the reputation I have of myself. We always say to ourselves, I'm not good enough. We have this permanent impression of not being enough beautiful, enough rich, enough competent, enough capable. And the second part is the fear of being rejected. I will be rejected, and this fear of public speaking and work. Good self-esteem gave good self-love and self-confidence and ability to work good, to do sport, to live good.
So if I understand what you are telling me, we should really be happy with ourselves.
Yes.
To have enough energy to give it around us.
Yes, it's. I invited you to do a job of your person. We must practice development personal. We study a course of medicine. We study a lot of things, but nobody study how our mental work.
And we need our mental to stay working, and we need our mental to stay alive, because
yes, how to be happy, how to be peace, how to be good in work, in life, how to have this equilibrium.
Yes. Yes. I just knew something that made me really happy, and I wanted to congratulate Dr. Hala for being nominated for the Women of this meeting. It's great, well deserved. We are happy. We have among us the women of this meeting. Congratulations.
Thank you. Thank you very much. It was an honor and a big surprise. And I don't think I deserve it at all. I really don't.
You do. You really do. There's no doubt. We all deserve to be this woman, because you work, you give all what you have inside you, and you do it with the fair. So we need to hear this. You deserve, you are the best, and you deserve, you are the best. That's it.
Thank you so much.
Dr. Safa, I want to just comment on your the mark line between duty and our
pleasure. Yes.
For example, I will speak about myself. I'm doing my duty as sincere way, as I happy that I'm serving our people, giving the best and attention. What can I give to them? And my pleasure really, when start in 2011, when I joined the Red Crescent, and I, as volunteer ophthalmologist, till this moment, I'm working with them, and I have 2 clinics weekly, and in each clinic, I see more than 20 patients, and really, I try to give all my effort to these people to provide them with all treatment, to help them, because they are poor people. We provide them with the injection.
You have poor people in the Emirates too?
It is not Emirates nationality expert, from Pakistan, from India, from Iran, from Syria, from Arab countries. Yani. We have, from Africa, we have a lot of them. This nationality, they are coming and seeking the help from Red Crescent. And really, I'm pleasure that among these people, I'm providing them very free service, and we can help me with my colleague in Qasmi Hospital. Also, they are coming there. We provide them with we do for them investigation, we do for them diagnostic image, and some of doctor I sharing with them my idea and their consultation. Really, I'm grateful to everyone around me, because they helped me to provide this service to the people in my country.
Yes, yes. Yeah, you could join the both pleasure and the duty in the same source. What do you think, Dr. Ibtisam? What's your point of view here?
I agree with Dr. Fatma. Actually, it's a great pleasure and happiness when you deal with the patient in the clinic and when you help each patient and relieve the complaint. And when they come back, grateful that you cured their disease or reduced their suffer, that makes you very happy. They come thanking you, and they become with time actually really like customer or more than customer, is part of as part of your family. Yes, they will come just to say hi.
Well,
they will miss you. They will.
Yeah. I just want to stop at this point, and I want to ask you. If we keep this state of mind, so keeping and putting all our psychological energy in this job, what if, and it will come late or early, this job, we will not work all our life. So after years, 10 years, 20 years, 25, 30 years, we will stop. From where will we get this satisfaction? Well, I want to ask you if we are not obliged to, from now, while we are working, to create another center of pleasure and of now, while we are still active. Dr. Hala, you and I, and Dr. Parol, Dalila, I don't speak about her because she found her ecstasy otherwhere. So tomorrow she stops working. Maybe she will go running, after she will do spa, she will maybe read, but we are focusing on just one and only thing. It is not a bad way to see life. It should be maybe a turning point in our life today, and to ask ourselves, maybe we should do another thing, maybe something caritative things, far from ophthalmology, because if we do it with link in ophthalmology, we will put the duty in it.
Actually, you are right. You are right, 100%. Recently, I'm trying to create something to make this change point, but it's difficult. It's not easy. I need to have my happiness somewhere else, other than the job and the family. Even the family, you should have something for yourself.
Family will leave. Family will leave. Children will grow and will leave.
Yes.
And I have my big son. I have 17. So now next year he tell me, Mom, I don't want to stay here in Morocco. I will leave. Ciao bella. I kiss you and I will call you from time to time. Okay, I'm happy because I will have less responsibility. Yeah, less responsibility, but the second will follow, and the third will follow, and they won't be here. So we will. Safa will stay with Safa, and Ibtisam will stay with Ibtisam, and Hala with Hala, and Parul with Parul, Dalila with Dalila, and Fatima with Fatima, and so on. All the attendees who are hearing us today. So maybe we can work on this now when we have the still energy. Don't give this full energy to just at one and the same. You know, we all have a religion, okay, and we know that in our religion, Muslim, we can consider just as the work as a practice of our religion, العمل عبادة عندنا in our religion. So we can get the satisfaction from this side, but we will not work all our life, and we will not spend all our life doing just duties. So let's find something a bit far from ophthalmology to have some ecstasy. Ecstasy.
Yes. To build hobbies, really, to build hobbies, like Dr. Fatma, reading, sports, taking care of our health, hiking. Yeah. Hiking is a very beautiful, enjoyable thing. Very enjoyable.
I was asking Dalila.
Nice weather in Morocco. You can enjoy.
Yeah, we have a nice weather. Yeah, and we have nice places.
And nice mountains.
And I invite you all to come. We have many congresses, and next year we will have congresses in English. We are improving ourselves. We are apart from the مستعمر. We are leaving the I was asking, I met Dalila last week in a meeting, and I was asking her, do you really find a pleasure while running, or you do it as an obligation and a duty?
No, no, no.
No.
When I don't run, I feel bad. I feel bad.
Really, I am. If I'm not work 1 week, I feel I am not okay.
If you don't work, يخرب بيتك. احنا مش
No,
عايزين.
work. امشي.
Okay. احنا بنتكلم عن we are telling you to go far from work and you tell me work.
I'm working. Daily base, I'm working.
Yeah, that's good.
Finding balance, it's everyone's dream. There is not magic recipe, and you can't be perfect everywhere. In fact, we all have the same ingredients that we have to mix according to our needs of the day and the event that arise. The recipe that suits me personally, it's running, it's sport. It's my biggest addiction. It allows to
you run how much miles a week, or how much
3 times for week, 4 times. When I am happy, I run. When I am angry, I run. It's allowed to go me into state of hypnosis, which allows me to do some emotional self-cleansing, and which recharge my batteries to start beautiful day, work, and boost me. It's like in real life. Sometimes I start by training with the ball in my legs, but I don't let go. Mother discipline is needed, and the job must be done. Some days I end up like a butterfly with stars in my eyes, and sometimes I end up off my knees. I say that how it's today. It's a mini training for life. It may seem strange to you, but that's how things go in my head. The job must be done. Of music, painter, hobbies is more important. Safa is Safa, Hala is Hala. Ophthalmology is just accessory.
Yeah. Dr. Hala, what's your point of view?
I agree. I totally agree.
Can we be good everywhere? Because that's what we are looking for.
Yes.
All of us. Can we be good everywhere?
Well, we should try to be again more balanced, and balanced is the right word, to have everything in the right quantities and not go overboard with work. But even though I say that all the time, I'm still unable really to do it. So after talking to all of you, what goes in my head, oh my God, I need to get a psychiatrist or a psychologist to help me.
That's the first step for happiness. Go ahead.
I need someone to really take care of me and tell me how to do it.
You will be friend with yourself. This is the first step. نبوظ الدنيا خلاص. Dr. Farrell, can we be good in all our feature of our lives?
You have to decide that you cannot be 10 everywhere, but at least try to be 8 at most places. And taking care of your health is something that we have to do consciously. I have Hashimoto's thyroiditis, and I have gained a lot of weight because of that. But if I continue sitting on my laptop and working and writing papers and books, it takes away the exercise element altogether, and it's a downward course. So I'm the only person who's going to help myself. And I have to recognize that.
I think that it's a bit, we are facing multiple duties, and the duties, the only duties that we allow ourselves to not be perfect is the one in front of ourselves, the one of ourselves, the duty that we have against ourselves. So we don't allow us to be a bad doctor. We don't allow us to be a bad daughter. We don't allow us to be a bad wife. We don't allow us to be a bad mother. We do our best in all fields. But when it comes to us, we say, خلاص عديها, it's okay, today it can be fine, I will do it later. It's years and years in our life, and it's over, it's done.
You very beautifully put it, because I may not be able to run a marathon, but I've got to make myself walk at least 10,000 steps. So yes, it's the realization that has to come, that you got to move.
And it will be your great success.
Absolutely.
Because you do it to yourself. This is the present that you give to yourself.
Absolutely. And that's what this body is, our place of worship. And we need to take care of it. And that's something we all need to remind ourselves.
Yes. We agree. So we won't speak ophthalmology. Don't see, look at me like this. But maybe we can make a sort of brainstorming those 10 last minutes. Maybe we are about 55% women in the workforce in ophthalmology. So we are the majority. But till now, just between 5 and 10% reaches podiums. Which is a real inequality. So being you all speakers and well-known person in your fields, what do you think the cause of this inequality? Is it less, is it from us? We don't make the effort to be present enough? Or is it just while waiting for the circumstance to be okay and to push us in the? Let me. What's your point of view about this topic? Why we are not enough as multiple as men on the podiums? They're better than us? Don't tell me that. I'm not sexist, but I know that we can do all what they do. Maybe, maybe I have one feeling that man, when he began his working day, he starts from zero. But we will start from -10. So we do more efforts because we deal other tasks. We manage many things in our brain before telling Bismillah and we start the first patient, for example. The men, I think that maybe they can be more active. I don't know. I don't want to say that, but I think that we can get more place in podiums. But I don't know why it is not the case till now.
But I actually think we're improving. I think that the number of women is increasing all the time, and at least in pediatric ophthalmology, because most of the pediatric ophthalmologists in Egypt are women. And so I really don't see that. I guess in other fields, this is more obvious, but I think it's improving though.
Yeah. If we see the podiums, those 2 or 3 years, and we compare it with the 10 or 20 years ago, we will really be thankful. That's sure. So we can be better, I think.
First of all, as you mentioned, the man they start their day with a 0 effort, and we start with a 10, because before when we get from sleeping, we think about family, what we should go today, what task we should provide to the family. A lot of the things around us. But men, they will get from sleeping, dressing, going to the job, and take coffee and starting their first patient.
Yes, I agree. I agree.
Also, our society, it is the man society, يعني مجتمع ذكوري. They have time to go and call each other, come to sit on such coffee and to discuss this point, to start to do some
all the environment should be made to make him more comfortable
Yeah, and as we are ladies, we are going back home. We have duty. We have somebody have children. They should look about their children. They don't have time to think about what they will do next step in the rest of the day. For
That's
this
it.
reason, the man they have more time to think, more time to be very obvious in these lectures and to prepare these things. And
Read newspaper
I'm
like
reading. Anyhow, yeah, but we should have time management. If you have time management and you can manage your time, you can do whatever you want to do.
I think it's not about time, all about time management. I think that we are victim of ourselves, society, and even our character as a woman. We are really afraid from criticism. We are the more one who critic the woman is the woman itself. يعني أنا how do I look? How did I speak? Was I fast? Was I? And this is make us afraid from the public.
Yes.
Maybe they are less less stopped by this fear.
The lady is she feels shy sometimes to come in front of the man and speak. Some of the ladies they are refusing to come on the audience because they say we feel shy to come in front of the man and
shy. كنت قاعدة في بيتكم من يومك شاي.
والله في ناس they are some very excellent doctor but they don't want to go for show up. They don't like to be in show.
Okay.
This is one of the reasons يعني.
Do you think that there are some patients who would like to be operated by a male surgeon as compared
Yes,
to
of course. Here in Morocco, they prefer male surgeon in every specialties. Don't you think that, Dalila?
Yes.
And they choose men first. And they ask us, they come, we do the diagnosis, we explain, we had that. Okay, everything is okay.
All is good.
And I tell me, no, the surgery, will you operate me, you?
Yes. You, doctor, you are young, doctor, you operate.
Yeah, some patients, they are do. They are who will do operation. And some people, if, for example, will you explain to them and you tell them everything, then I think they're not trusting you as a lady doctor. I'm calling Dr. Ahmad, he's the eldest one in the Shahada. When they see the white head, what Dr. Ahmad said, it's
the white head. He should have a mustache, white head, and it is respectable.
Let's trust him. But anyhow, and really, my patient, they like me to do for them operation. They ask me, will do operation?
Thanks God, we do too. But it's we are facing this category. And I thank you for this question because I thought that it was just in our society. And
everywhere.
Oh, that's
everywhere. Even in our hospital, our patient, they ask him, who will do operation?
So 10 years back, I had to lay my credentials on the table so to convince the patients that, you know, I can do a good job. You just got to give me an opportunity. Now, as I'm getting more towards the middle ages, and so they now think that she has enough experience to, you know, take care of us, their surgical confidence is increased. But the fact is that it has not been an easy going. You have to prove yourself even to the patient, let alone our own colleagues, to show our worth. So that's like an extra job which women have to do as compared to our male counterparts.
I will ask another question. If the pilot is a woman, you are trust to travel with him? To fly with him?
Yes.
Maybe I will think. Maybe I will think twice.
No, I think I definitely.
Oh, yes.
I think I would always, if I see a pilot who is a woman, I would remember myself. And I agree with everything that you said. When I started out, it was difficult to convince a patient that I would do the surgery for them. And there was very little room for failure, very little room for making mistakes.
Yes.
For us as women,
unforgivable, because it was you.
Exactly. So it was double hard for me than a man to become known for doing surgeries. I thank God I don't have this problem anymore, but because of that, if I see a woman driving, being the pilot of the plane, I would get on the plane because it's been so hard for us. So
even small ladies, you trust her?
If what?
And small lady and very small.
No. She will. Dr. Hala will trust. Yani if she's not an elderly woman, yani, without experience.
Doesn't have to be an elderly woman. If she's qualified to fly the plane, I'll be on the plane.
And I think that last one in Saudi, there is an Omani Airlines. There is one pilot. She's very young. I give her 16 years old age.
Oh.
And she's told us I am the pilot. I don't have a people travel with her.
You delayed the trip. خلاص قلت لها أنا راجعة بيتنا. I'm not traveling anymore. No, but no.
You said we asked so many questions. Are we looking good? Did we do it the right way? So everybody is anyway so self-critical about their own selves that they will do a good job because they would have reevaluated themselves so many times that
Yes.
from their own side, they would have tried to reduce the room for error.
Yes.
So I would, that's why I trust a woman, because the
Yes,
amount of effort they would have put in to think and make a plan would have been way more than a man. Yeah.
Sure. I'm okay with you. I'm okay.
That's
with you.
true. Very true.
But in my opinion, the one and the only cause that blocks and slows down most women comes from themselves and their own beliefs. Of course, we live in different society, but a common factor all over the world is the inequality between men and women that our parents instilled in us through their education. And we have here so much about it that has become a truth in our heads. We have all here replicas of this kind. It's a job for men. Only men can do this kind of task. Men are better in this field, etc., etc. Moreover, it goes back very, very far. Women did not even have the right to schooling. This is the greatest discrimination. Unfortunately, this is still the case in certain regions of the world. And it's true that the woman is multitasking. She must fulfill her role of mother, doctor, nanny, psychologist, drive, cook, coach, which exhausts the majority of women. And sadly, it makes their task 100 times more difficult. When a man is single task, once he leaves home, he focuses only and strictly on his work. He forgets all the other roles in his life, which facilitates his evolution in the socio-professional scale, I think, in my opinion.
Yes, I totally agree. I don't know what about the Emirates and Egypt, but we still here have many parents that doesn't send their daughter to school here in some rural places. So we are still facing some inequalities, but as Dr. Hala said, things are improving in a very high speed, and we are good. We will stay positive. We are good. We are making our voice heard, and we are winning challenges. And maybe we don't need to be fully like men. Maybe just we need to be what we are, working in our rhythm, working but being recognized. What we really need is to being just estimated at our real value, because sometimes we feel that we are underestimated, not because of something, just because of people or men don't see all what we do above work. We do many things and we do work with this thing. So maybe we need to be more recognized and more evaluated. Maybe we have some last words to each one of us to say maybe goodbye. It was a great session, and I was really happy to know each one of you, wonderful women. So I'm gonna let you say bye, each one of you, and I hope that we will meet in Mayom next October. Huh? Inshallah, if we're still in life.
Inshallah. Inshallah.
Well,
Wait,
more
thank you.
power to everyone. Yeah.
Congratulations once again, Dr. Hala. It's really, 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 I'm really pleased to hear it. I just heard it from Dr. Amri a few minutes ago. He called me
Thank
to-
you. I take it as a recognition of my unit of pediatric ophthalmology
Yes,
in
the
Cairo
whole
University,
team. Yes,
not myself.
of course.
It was great seeing you, and I hope I get to meet you in person really
Yes,
soon.
it's really the same for us. Dr. Paro.
Thank you. More power to every one of us. And I'll take this moment to thank one man, Dr. Mohammed Al-Amri, because he brought us together. So yes. Yes.
Thank you, Dr. Amri, if you are
Pleasure.
here now.
Yes.
My pleasure to meet all of you, and thank you for accept our inviting to QOIC, and inshallah we'll see you again in Mayom and in Kuwait next year, inshallah.
Thank you very much. Thank you very much for inviting us.
Thank you very much.
It was really nice meeting you all, and really that empowered us. When we talk about our personal struggling and our really, it's a personal issue that we have to improve other things in our life other than work. To think about other things other than work and family, actually, other than work and family.
Nobody will do it
Really?
for us. That's very
Yes,
important.
we have
do
to
many
think
things
about
for
it.
others, but nobody will think for us. So let's think for us for a bit.
Yes. Maybe wait to hear from you next year. What did each of us achieve?
Yes, we will take the challenge, okay? Next
Yes.
year we'll meet.
Next year, I want to hear it from all of you. What did you achieve in taking care of yourself?
Maybe I will begin walking, and after next year I will run. Next year.
Yes. At least any sport.
Yeah, any sports. So let's take a picture, a screen. Do your beautiful smile. 1, 2, 3. Yes, that's great. Nice. So we'll.
Thank you.
Yeah, we'll end the
Bye-bye.
session. Thank you all. Bye.
Thank you. Remember that we are exceptional women and we deserve an exceptional life.
Yes,
Let's
we deserve
go.
it. Yes, we deserve it. Bye.
Bye.
Yeah, good evening, dear friends. Am I audible to you?
So,
Yeah. So shall we start?
so there are 2 minutes left, sir.
Okay, sure.
You can start, sir.
Yeah. So good evening, my dear colleagues. So today we would be discussing on a very important topic of the role of dexamethasone implants in the management of diabetic macular edema. So as we are aware, macular edema is one of the most common features of retinal diseases. So whether it is diabetic retinopathy or whether it is vein occlusions, or to that extent, even in uveitis, it is the macular edema which is very commonly seen, and it contributes to one of the most important causes of vision loss. So the main reason why macular edema develops is because of the inflammation, and the inflammatory mechanism plays a very major role in the formation of macular edema. So having said that, the role of inflammation is because there is accumulation of leukocytes on the surface of the retinal capillaries, and this in turn, that is the leukostasis in turn, produces reactive oxygen species as well as inflammatory cytokinins, which causes increased vascular permeability. This in turn causes upregulation of intracellular adhesion molecules, that is ICAM, which causes the release of interleukin-6 and pigment epithelial-derived expressions, which have been contributing to the formation of diabetic macular edema. So the role of inflammation in the development of macular edema is quite obvious, and as can be evident with this particular slide, there is increase in the vascular permeability with extravasation of fluid in the extracellular space. So what should be the optimum treatment for diabetic macular edema? So as we know that there are many players in the formation, it is just not the VEGF alone as what has been described. It is also because of the upregulation of ICAM1, the MCP1, as well as the interleukins in the form of interleukin-6 as well as interleukin-8. So just by targeting anti-VEGFs may not be a suitable way of actually treating diabetic macular edema. So with this, and also as per the EURETINA guidelines, it is suggested that the corticosteroids produces an anti-inflammatory effect to various mechanisms, and this in turn causes a decrease in the synthesis of inflammatory mediators, and also it decreases in the formation of VEGF. So the corticosteroids, the implications of this is there is a significant decrease in the inflammatory process, and also there is a significant improvement in the blood-retinal barrier through inhibition of the expression of ICAMs. So what does the EURETINA recommend? As per the EURETINA recommendations, the anti-VEGFs can, corticosteroids can be used in patients who are not responding to anti-VEGF. When we mean non-responders, it has been said that when you have given 3 monthly injections of anti-VEGF and when there is no significant improvement, then you can label these patients to be non-responders, and it would be a good idea to switch. Also, pseudophakic patients can be a good candidate, and patients with history of major cardiovascular events or high risk can also be considered. And patients who are not willing to come for a monthly injection of anti-VEGF can also be a suitable candidate for corticosteroid implants. So this is something which is very, very important, because there are many patients who would be not having access to healthcare, and these become suitable candidate to have the corticosteroid implant. So the Ozurdex suppresses several inflammatory mediators by inhibiting inflammatory cell proliferation and migration. It also reduces intracellular swelling and helps in the restoration of fluid drainage of the Muller cells. It also reduces the breakdown of the blood-retinal barriers and also targets the local inflammatory mediators by addressing both intracellular and extracellular edema. So the benefits, as you can see, the vision changes absolutely mirrors the central retinal thickness, and the effect of Ozurdex can be seen as early as 1 to 3 days. That is, as close to about 72 hours, you can see a rapid resolution of the macular edema. Also, the external retinal layer status correlates strongly with visual acuity gains in these patients. So the benefits behind Ozurdex can also be correlated with the fact that the inflammatory mediators which have been targeted by Ozurdex plays a significant role, and this causes a reduction in vasoactive factors which can be correlated with the reduction of the central retinal thickness. So coming to the benefits, this is a demonstrative case. It can be seen that soon after the injection of Ozurdex, the central retinal thickness dramatically improves with rapid improvement of vision. Now, coming to the treatment and what are the options which are available, Ozurdex can also be used in treatment-naive patients, wherein which there is a significant improvement of vision versus patients who have already been treated with anti-VEGF and who have been refractory. So when such patients were treated in the naive group, it is seen that the improvement of vision is close to about 11.3 letters versus those who have been refractory, which can be close to about 7.3 letters. So Ozurdex can also be used as a switch when patients have not been responding to anti-VEGFs or when the response has been suboptimal. So it can be seen that on long-term basis, with Ozurdex, the number of injection frequency can also be brought down dramatically. So one thing which is commonly been spoken about is the increase in the intraocular pressure after the use of corticosteroids. Certainly, it causes a rise in the intraocular pressure, but this can be controlled with either 1 or maximum by about 2 anti-glaucoma medication, and there is nothing to panic about. It has a predictable way of rise in the intraocular pressure, and which can be managed with anti-glaucoma medications, and it is very rare that the patient may need any kind of a glaucoma filtration surgery. Also, another important thing which has been discussed is with steroids is the risk of cataracts, and it is characteristically seen close to about 18 to 30 months of repeated injections. As such, most of the patients with diabetes, they are also prone to have diabetic cataracts. So eventually these patients will need a cataract surgery. So I would like to discuss the non-diabetic indications of the use of Ozurdex. I would like to present a couple of cases wherein which we have used Ozurdex for other than diabetic indications. My first case is a 37-year-old male who's not a diabetic, but who's been a hypertensive since 7 years. he presented to us with a best corrected visual acuity of 6/6 in the right and 6/60 in the left eye. So his intraocular pressure was normal, and the fundus in the right eye showed hypertensive retinopathy changes, and in the left eye there was a non-ischemic central retinal vein occlusion. So to present with, the patient had a central retinal thickness of close to 637 microns, and as you can see here, post Ozurdex, now in 1 month, there is a rapid resolution of the macular edema, and it has come to 295 microns. My second patient is again a 47-year-old male with no history of diabetes and hypertension. He presented with a vision of 636 in the right, and left eye he had a vision of 66. So he had a right superior temporal retinal vein occlusion with macular edema, as can be seen here. He had a massive central retinal thickness of about 834 microns. And 1 week post intravitreal Ozurdex, the macular edema had subsided to 306 microns. 1 month post injection, he maintained a central retinal thickness of 245 microns. So my third case is again of a 46-year-old female who is a hypertensive on treatment. Her vision was 6/6 in the right and 6/24 in the left. Intraocular pressure was normal, and in the right eye, it was normal, and in the left eye, she had a superior temporal retinal vein occlusion with macular edema. So at the time of presentation, she had a macular edema of close to 664 microns, and 1 month post injection, it had subsided to 349 microns. So as you can see, we have had amazing results with the use of Ozurdex, be it whether in diabetic macular edema as well as in vein occlusions. We have found to have amazing results even in macular edema secondary to uveitis too. So if there are any questions, I'm ready to take. Am I audible?
Yes, sir, you are, sir.
Yeah. So this was a brief insight about the use of Ozurdex in the management of diabetic macular edema. Of course, I've given an insight even in non-diabetic patients. So yeah, if there are any patients, if there are any questions, I'm ready to take them. All right. So shall we call it off then? Thank you. Thank you for your patient listening.
Hello, is there anyone here?
Yes, sir.
Okay, can you remove this one? This one, because now we already over the.
Done, sir.
Okay. Mute everyone, and we can start connecting the speakers.
Can you hear me?
Good evening, Dr. Majdi. How are you?
Good evening. How are you? Hi,
Fine.
Sam. How are you?
Fine, fine. How are you? All good?
I'm
Hello,
fine.
good evening.
Long time no
How are
see.
you?
Yeah.
Yeah, long time. Where are you? Many years.
I'm in Emirates now, behind the sea.
I am in Egypt.
You are in Egypt? Okay.
Yeah, I'm in Switzerland.
I like that.
Yeah.
You know, I just arrived from the clinic.
I now just know that all the times I'm between a naughty. I don't know what to do. Everybody is.
Don't do anything.
I have
pray.
Fair enough. Fair enough. One person. You are also. Okay. We are missing. I think Fahad, he will join. Brasam,
Ahmed.
you, Ahmed, who's Ahmed رشدي دكتور مجدي من عندك والله.
انا بقول لك انا لسه واصل من العياده حالا.
طب اعمل له الو بس. اعمل له الو بعد اذنك.
اعمل له الو اقول له الو.
لا معلش. We will take another 2 minutes to start. No problem. So we will delay. We'll take it out from Dr. Brasan. He is very fast to do everything very fast. No problem.
You want a 3-minute presentation or 10-minute presentation?
I know you can.
I need 75 minutes presentation. I'm just finished the clinic. I didn't have lunch or dinner, so I'm waiting. يا احمد دخلت ولا لسه؟
العلم
مستنينك انت اللي معطلنا يا احمد. بقول لك طنطا هي اللي معطله البشريه كلها.
Science is the food.
لا ده امبارح اللي كان 8:30 النهارده 7 النهارده 8.
Nothing.
مستنيينك اهو ماشي. Ahmed is coming, and please serve the lunch until he comes in.
Yeah, please prepare your channel because we will send it through the YouTube, please.
Okay, squeeze it, and I will expand it after delivery.
Enter. I make enter is in the way.
And please, the fruits, make the fruits like squeeze the fruits, so it will be like a juice. It will be easier. Yes, squeeze that. Squeeze that.
You see it? Yes. It is very ready. I'm telling you. What else you want? Mango?
How about some dessert?
Oh, nice.
Manga? Okay. ماشي. حنس المشاهدين.
Okay. What else you want?
Do you have toys? Do you have toys?
This is the only thing that you can never get it in UAE, but now it's available every time. They are now in UAE making in Abu Dhabi, and this.
Congratulations, Mohammed. Yes,
thank you very much. So I will just.
I can see.
I will mute myself, please, and you can start whatever you want because I need to.
No, what to mute? You are the moderator. You're going to be moderating the.
Okay, I think if you you want, we can start. So we can, or you want to be in the same organization as it's prepared.
No, I'm supposed to be the first one to start, I think, right?
Yeah.
Yes.
And I have a long presentation, 150 slides.
Yes, you can make it within 7 minutes and a half, no problem.
7.5?
Yeah, because you tell me you need only 6 minutes, so I give you 1.5 minutes more.
It's everybody yesterday took 10 minutes and we have extra time at the end. So we are not going to leave you any extra time today.
Today, yes. Okay, go. Let me start. Assalamu alaikum. Good evening, dear colleagues and friends. We'd like to start the second medical retina session in 8 quick conference. Today, I'm really happy that we are having a very eminent speaker in this session. As usual, you know, all of them, they are eminent and they are very experienced in their field. So I have Professor Dr. Majdi Musa, my dearest friend, and I have my dearest Professor Brasan Rao, Dr. Ahmed Rushdi, also he is joining in a few minutes, and Dr. Fahad Kuhel. So today we will talk about wide field imaging, so multimodal imaging and wide field imaging in the management in vitreoretinal disorders. We will start with Dr. Majdi Musa, and he will give a talk about wide field retinal imaging in real life practice. So Dr. Majdi, the floor for you, please.
The floor is mine. Thank you, Dr. Muhammad, for the kind invitation. Thank you for the fruits you showed us. We didn't taste it, but we will taste it at the end. I think you can see my my presentation now. Can you see it?
Yes, please.
Shall I start?
Please.
Okay, let's start. Thank you again for the kind invitation. I'm glad to be there and with new colleagues today. My introduction or the first lecture is about ultra-wide field imaging in real life practice. So there is a consensus on the classification and guidelines of wide field imaging, which was published in Ophthalmology Retina 2020, because there was a lot of debate. What is the meaning of wide field? How many degrees? What's the wide field OCT, wide field OCT angiography, wide field fluorescein angiography? So they gathered together and they put like a consensus, what is wide field in 2019? So this is the consensus definitions. As we can see in the picture, the posterior pole is the retina within the arcades, which it used to be all the fluorescein angiography machines getting. Then the mid periphery, which is the region of the retina up to the posterior edge of the vortex ampulla, as we can see here in the wide field ICG. Far periphery region of retina anterior to the vortex vein ampulla, and wide field single capture, which is not mosaic, centered on the fovea, capturing the retina in all four quadrants, posterior and including the vortex vein ampulla. Ultra wide field is a single capture view of the retina, far periphery in four quadrants. As we can see here, this is the ultra wide field. And pan retinal is a 360 degree. No machine up till now can get a 360 degree. Only contact lens can get you 360 degree, which is the pan laser photocoagulation lens. So wide field in real life practice and ultra wide field, we speak about color fundus, fluorescein angiography, OCT, fundus autofluorescence, ICG, and OCTA. We used to have 15 degree color fundus and fluorescein at the beginning, that's at the late 70s, and then came the 35 degree, and the standard cameras is the 50 degrees. Till the last 2 decades, we have only this, and we used to do this. But sometimes it is not quite good enough, because most of the lesions, when you see this, it's in the extreme periphery, and we need that in one field. And then came the wide field spectralis and the wide field optus. Spectralis could cover up to 102 degrees, as you see the picture on the left side. And this is the optus up to 160 degrees, which is an ultra wide field, and it's beyond the ampulla of, as we can see, of the vortex vein. How about evolution in OCT? We used to have a 6 millimeter at the beginning, then we get 9 millimeter, and then we get 12 millimeter in one line scan, which can show us what is going on in the center and in the paramacular area. As we can see here, vitreous splitting into 3 layers. If we don't have that long line scan, you will never be able to see these changes, especially if you are going to surgery. And nowadays, the maximum you can get is a 16 millimeter line scan, which can be done with many machines nowadays in the market. How about the evolution in the OCTA? They started by 3 by 3 millimeter cube, and then 9 by 9, and then 12 by 12, which is the maximum any machine can get. Not speaking about the mosaic, but speaking about single picture. The ultra wide field imaging, there was contact and non-contact lenses, and like the red cam, it's a contact. The optus is a non-contact. Spectralis, they have contact and non-contact. This is the red cam imaging we can see in children, where we can get a peripheral lesions like this, and you have to take many quadrants to make mosaic. About the spectralis has 2 types of wide field, ultra wide field lens, which you have to use a contact. This will get in contact with the cornea. It's very annoying, and I don't think it's used anymore after the optus. And this is the non-contact, where you can get 102 degrees. So this is a wide field, this is the central, this is a wide field, and this is an ultra wide field, which you can get by the optus. Spectralis versus optus, as we can see, the spectralis, the maximum you can get is 102 degrees. The optus is up to 160 degrees in one capture. And as we can say, the optus is not a real color. It's a 2 laser source, which can get similar to true color, but it's not a true color. And it has different wavelengths and autofluorescence and ICG. And this is what we can see by the optus, 160 degrees, and then you can magnify the picture you want. And this is another wide view with the Optus California, the new machine in the market a couple of years ago, where you can get up to the ampulla and beyond that. And this is a wide field ICG, which is very important nowadays in studying the pachychoroid. Is it really important in real life practice? And which system we can use? I showed you most of the system, but this is the 7 ETDRS standard field. And we can see we were missing a lot of things if we go beyond this, like new vascularization and proliferative diabetic retinopathy. And I think Dr. Raoul will cover that. But let me give you 2 real life examples. This is a patient who was diagnosed as non-proliferative diabetic retinopathy with the standard view. But if you go peripheral, you will find new vascularization. So you can change even the degree of diabetic retinopathy from non-proliferative to proliferative if you go further peripheral. Also, mild non-proliferative to severe non-proliferative if you examine the periphery. And if you count on this, you will miss these lesions. Also, following the treatment, why the patient every now and then is getting vitreous hemorrhage like this picture, because it is not quite good enough PRP, missing a lot of ischemic areas at the retinal periphery and mid-periphery. And this is what we need PRP sometimes if you have repeated vitreous hemorrhage. Florid NVE and NVE, you need to examine the periphery before diagnosis. And again, targeted retinal photocoagulation, if you target the periphery, you examine the center, it's free, but if you target the periphery, the center will keep dry. Again, sometimes during the retrobulbar injection, you can get a penetration, and it's easy to get that with a 1-color fundus picture. Real life practice giant tear is very important to examine and to document by Optus. Again, dropped IOL with retinal detachment. It's very fine and very documented to see that preoperatively. Again, acute retinal necrosis, the extent in the periphery, you can see that at the periphery, and it's only 1 picture which will help in the diagnosis and the follow-up of these patients. Angioma at the periphery, you can see the feeding vessels and the draining vessels. ROP, which Ahmed Rojdi will speak about in a few minutes, how you can examine, diagnose, and treat PRP by documenting preoperatively patients with ROP and then do the retinal photocoagulation. Juxtafoveal telangiectasia, we always look at the center, but most of the lesion here is at the periphery. The ischemia, the light bulb configuration of dilatation of the capillaries, the extensive ischemia is mainly at the periphery. And again, we have to look at the periphery in RVO, in uveitis, where the periphery is very important, where the source of leak in this Harada disease and the multifocal choroiditis. Long-standing retinal detachment with demarcation line, you need to examine the periphery to know the extent of this retinal detachment and how the retina is severely ischemic in this long-standing retinal detachment. And even if it is self-limited, you need to laser at the periphery, so you will forget about this for a long time. In wide field OCTA, as I speak, in the proliferative diabetic retinopathy, this is a 12 millimeter. You can see 12 millimeter cube, you can see the NVEs. But if you combine both of them, I think this is quite good enough to see the center and the periphery. Start treating the patient, combining OCTA with structure OCT. And this is the Zeiss Flex Elite, which is a very good machine. It's not in Egypt yet, but it's a very good machine, giving you a mosaic of 12 by 12, and you can get up to 16 millimeters. Also in retinal vein occlusion, this is a hemi vein, one of my patients. And I did OCTA. I looked at it and compared it to the fluorescein. It's very comparable, where you can find where is the NVEs. And after the intravitreal injection and laser photocoagulation, you can see the regression of the NVEs. Still, the ischemia is there, but it's already treated by laser photocoagulation. There is a limitation. Once you get a very wide field, you see the artifacts at the periphery because the retina is concave. And whatever the periphery you reach with fluorescein, it is not comparable to OCTA. OCTA is still limited in the periphery. And we all know that montage will not solve the problem, especially if you do multiple 12 by 12. You will find out that this retinal periphery will never be able to be seen in focus. Also, long line scan, 12 by 12 millimeter, you can see the traction in the center and nasal to the disc. So you will never forget about this. And once you diagnose traction and macular edema, there is another traction nasal to the disc. Long line scan, which can give you the staphyloma. Look at the 16 millimeter line scan, where the peripapillary staphyloma can be clearly delineated. And we can see and study this staphyloma to detect if they have any breaks around the staphyloma. In color and fluorescein, in proliferative diabetic retinopathy, fundus autofluorescence is very helpful. So you will never augment the PRP without doing fundus autofluorescence. So you will not hurt the retina anymore, and you can pick up where the the laser is not done, and you can fill in the spaces. This is one of my cases who had retinal attachment in the right eye, came with metamorphopsia in the left eye, and look at the huge 2 large tears. The patient is only 6/6, but he's complaining of metamorphopsia and photopsia, and floaters. And I found 2 large breaks, and I did laser photocoagulation. And during the follow-up, only 1 shot to see if I already sealed this break or not. Also, fundus autofluorescence in macular dystrophy or retinal dystrophies, you can see how much the affection of the RPE. This is one of the funny cases who's complaining of floaters every now and then after intravitreal injection. And look at this. This is the silicone bubble we can see after repeated intravitreal injection, and it can be documented by 1 shot. Again, you can use a very wide field color, very wide field by montaging the OCT, by montaging multiple 12 by 12 millimeter scans, so you can get up to the mid periphery, and you can combine this with OCT angiography, and I think this can replace fluorescein angiography nowadays. So my take-home message: through retinal examination, including slit lamp, thorough retinal examination, including slit lamp and indirect ophthalmoscopy, is still the standard of care of all patients. So if you are efficient enough to examine the patient with a non-contact lens or even a contact lens, it can overcome any kind of investigation, but it needs a very good skill, and it's objective. It depends on the subject, but using ultra-wide field imaging is very helpful in the diagnosis, documentation, and monitoring of this patient. Thank you so much for your listening.
Thank you very much, Dr. Majdi, for this an excellent presentation and comprehensive as usual and direct to the point. Really impressive. So we can move to the next talk. It will be by Dr. Prasan Rao, and he will give a talk about role of wide field imaging in diabetic retinopathy. Prasan?
Am I audible and my slides are seen?
Yes, we can see it clear.
Good evening, everyone. Thank you, Dr. Amri, for giving me this opportunity. I'll be speaking on the role of ultra-wide field imaging in diabetic retinopathy. So it's basically a little continuation of what Dr. Majdi just said. So we have to be very clear about the nomenclature here. As Dr. Majdi mentioned, ultra-wide field imaging is a single capture showing retinal features anterior to the cortex ampulla in all 4 quadrants. So as seen over here, this is ultra-wide field. And pan-retinal is an image displaying the aura to aura for 360 degrees. It is obtained through montaging of the optos images. So this is how we understand what is ultra-wide field and pan-retinal imaging. So what are the various machines we have in the market? We have the optos, which has a maximum view of 200 degrees, Mirante, which is 163 degrees, and the Clarius, which is 133 degrees. And each of them have their own advantages and disadvantages. So let's start with what is the role of ultra-wide field imaging in diabetic retinopathy. So the first and important thing is screening and diagnosing diabetic retinopathy. So when you do ultra-wide field imaging, it improves the detection of diabetic retinopathy lesions and leads to more precise diabetic retinopathy grading. This has been shown by various authors, and it also detects higher retinopathy levels in approximately 10 to 15% of the cases what we see. So this is an image of a wide field angiogram, where the patient, if you look at the posterior pole, has most of the lesions, but in the periphery, you have this peripheral vascular leakage noted over here. Next, if you look at another few things, ultra-wide field angiogram detects greater number of neovascularization and capillary non-perfusions. So this is a patient where, if you look at the central, if you take 2 images in the center, the majority of the angiograms are neovascularization is in the peripheral temporal quadrant of this patient. Also, ultra-wide field color images show improved detection of rates of peripheral neovascularization. So how is this important? Because if you miss these lesions in the periphery, you might fail to treat these patients, and eventually they'll end up with vitreous hemorrhage and the other sequel of proliferative diabetic retinopathy. So these are some of the black and white images where you can clearly see the presence of neovascularization in the periphery, in the superior and the inferior nasal quadrant. Next, how do we monitor diabetic retinopathy? So we know initially we looked at the 7 ETDRS fields which are basically localized over the disc, macula, and around around surrounding areas. But Silva et al. Described predominant lesions were in the peripheral visual fields. So we coined a term for this as predominantly peripheral lesions, or PPL. And these have been defined as microaneurysms, hemorrhages, venous bleeding, IRMA, NVE, in eyes where 50% of these graded lesions were outside the standard 7-field images. So this is where you can see in this patient, the predominant images are in the peripheral part. So what is the significance of this? They looked at eyes and they showed that eyes with PPL had a 3.2-fold increased risk of a 2 or more step DR progression and a 4.7 increased risk of progression to PDR compared to eyes without PPL. So if you see patients with peripheral lesions, just keep a watch because they have a higher incidence of progression, both in terms of the number of steps of diabetic retinopathy and progression to proliferative diabetic retinopathy. Also, ultra-wide field imaging can predict the risk of post-vitrectomy bleeding. So post-vitrectomy bleeding is a big challenge in eyes which are treated with vitrectomy. They often have multiple bleedings and you want to find out these causes. So you can see these patients have more peripheral predominant lesions as seen on the angiograms. What about DME and peripheral ischemia? Now, this was a big debate or a topic which was discussed about a decade ago. We know that the peripheral retina largely, if it's ischemic, produces a large amount of VEGF. But is there any correlation of this peripheral ischemia and DME? So certain authors looked at peripheral ischemia and they tried to compare it with the rates of macular edema. And they found that eyes with retinal ischemia had about 3.75 times higher risk of rates of macular edema as compared to those without retinal ischemia. And a strong correlation between peripheral vascular leakage and focal macular edema were also seen in eyes without peripheral non-perfusion. However, some authors had a contrary view. They said that there's a moderate correlation between the foveal avascular zone areas and peripheral ischemic index, and between the peripheral leakage index and the foveal avascular zone. Some of them even said there's probably no association between non-perfusion, the ischemic index, and the clinically significant diabetic macular edema. So the jury is out here. We really don't know what plays a role here. But if you look at the images here, this was an article published in British Journal of Ophthalmology where they measured the amount of peripheral ischemia and they tabulated it, and they clearly demonstrated that diabetic macular edema and retinal ischemia are significantly related to each other. And from this route turned out the next thing, So if you say that the peripheral ischemia is the driving force for diabetic macular edema, does targeted retinal laser photocoagulation help? So what is targeted laser photocoagulation? It's a selective application of laser only to the areas of non-perfusion, which is detected by the FA. And the principle behind that is to reduce the VEGF produced and also to minimize the side effects of the laser. So this was a study which was published in ACTA Ophthalmology and even in British Journal of Ophthalmology, where at 12 weeks, they found that the PDR regression occurred in 76% of the eyes. The complete disease regression occurred at 37 weeks, at 37% of these eyes at 24 weeks. And there was a significant reduction in the central retinal thickness as measured on OCT over a period of time. So this is another clinical trial where they compared 3 types of laser treatments. The targeted retinal photocoagulation with a standard pan-retinal photocoagulation, and something where they called as minimally traumatic PRP, where the burns were not visible. And when they did this, they found that despite similar rates of PDR regression in all the 3 groups, a significant reduction in central retinal thickness was found with targeted retinal photocoagulation and minimally traumatic PRP. So this is important because now we can actually look at lesions when you're doing the angiogram and see which are the areas which are ischemic and target those, rather than doing those large burns which used to get in the past, which always compromises patients' vision in the periphery and also the contrast. Finally, what is the role of telemedicine in diabetic retinopathy? Now we have these excellent cameras which take wonderful images of the retina, and ultra-wide field imaging has found to be utility in telemedicine programs for diabetic screening because of the speed of acquisition, patient comfort, because most of these cameras are non-mediatic. The acquisition time is very fast. You don't need to dilate these patients. So telemedicine in conjunction with ultra-wide field device increase the coverage of screening, increase the referral base, improve the clinical compliance of screening. However, it is associated with mild increase in visits here. What is the use of ultra-wide field OCT imaging to differentiate between severe and NPDR and DR patients? Now here they looked at OCT to differentiate between IRMA and NVE. Why is this important? Because we know eyes with severe NPDR, if you have IRMA, then you generally we may or may not treat, but eyes with PDR you generally want to treat. And it's important to differentiate between the two. So one of the ways for doing that is an invasive fluorescein angiogram where you inject a dye, and this can be associated with various complications. So some of the authors looked at this, and they defined IRMA as characterized by hyperreflectivity lesions in the inner retina, stage 1, and outpouching of the ILM as stage 2. And they characterized NVE as disruption of the ILM, which is stage 1, horizontal growth along the posterior hyaloid, stage 2, and multiple breaches of the posterior hyaloid and linear growth as stage 3. So these are some of the images which are published in the article. This is an unmagnified view highlighting the area which was captured here, and this is a magnified view. And here the OCT scans clearly through the area of suspicious IRMA clearly demonstrates this hyperreflective lesion which is breaking through the ILM. Similar images in the other eye. So when you examine this patient, you probably think this patient has severe non-proliferative diabetic retinopathy. But however, you scan a certain area of this large IRMA, you can clearly see the presence of NVE, which is detected on the OCT. Another patient here with very few features on the retina. However, if you look in the peripheral part, you can see this NVE. So it is sometimes confusing for us because we generally look at the hemorrhages and changes on the venous side. However, you might find up a very innocuously looking lesion in the periphery, which might actually be a NVE. Finally, what is the use of a wide field OCT imaging here in OCTA imaging in diabetic retinopathy? So the authors actually looked at alteration of retinal microvasculature in eyes with preclinical diabetic retinopathy using the ultra-wide field swept source Octa image. So here you can see peripheral areas where there are changes in the peripheral part where the patient didn't have any lesions on the color photograph. You can see areas of capillary non-perfusion in the lower inferior quadrant and in the upper nasal quadrant in this eye. They showed clearly that peripheral areas presented significantly more microvascular dilatation and tortuosity than the central areas. And there were more non-perfusion areas than center with borderline significance. And the important thing to remember is the number of lesions were associated with HbA1c levels. So higher the HbA1c level, more the changes in the peripheral part. And this is again important because we again just look at the colored images and say what is the staging, but however, there might be underlying changes happening in the microvascular level, which goes undetected. Again, a wide field OCTA image in a patient with diabetic retinopathy, where you can see this is the OCT image. You can see the V-scan with the overline flow values here. And this is the wide field image on the fundus angiogram, where you can see there's a sort of a correlation, almost a good correlation when you do the ultra wide field OCTA in PDR patients. What about AI in ultra wide field imaging in diabetic retinopathy? Now, Optos retinal imaging and its ability to capture the peripheral lesions has been clinically validated. And recently, this was an abstract from RO where Optos AI for DR demonstrated excellent disease detection performance with a sensitivity of over 96% and a specificity of over 93%. So AI can now be used to diagnose and look at these cases. So finally, what is the take-home message here? Early assessment of diabetic retinopathy using ultra-wide field imaging is very important for managing our patients' visual health. Ultra-wide field retinal imaging captures the peripheral lesions, and this has been clinically validated, and it facilitates early detection, management, effective treatment of diabetic retinopathy, and finally, it seems to be irreversible for early diagnosis and management of retinal diseases. So thank you very much for your patient hearing.
Thank you very much, Dr. Prasan, for this excellent presentation, as usual. We can move to the next, then we can have the discussion at the end. We will have now Dr. Ahmed Rushdi, and he will give a talk about wide field imaging in ROB. مساء الخير يا باشا.
مساء الخير. Good evening.
Good evening to you.
Thank you very much, Dr. Mohammed, Dr. Magdi, for the opportunity to participate in this prestigious meeting. Give me just a second to share my screen. Can you see my screen now?
Yes, please.
Okay, so my talk will be about ultra-wide field imaging of retinopathy of prematurity. We know that ROP is a leading cause of childhood blindness worldwide, and early and accurate diagnosis is significant for early treatment and good prognosis. We know that the binocular indirect ophthalmoscopy has been the standard technique for screening ROP in premature infants, but has many limitations because this technique is subjective and needs qualified ophthalmologists, and images are not stored for future reference. But what about digital imaging in ROP? Digital imaging using wide-angle digital retinal photography has been an alternative method for screening ROP. RetCam has a high reliability and accuracy for detection and follow-up of ROP, but however, it has many limitations. So the RetCam limitations are, there are many limitations because it requires a position to the cornea, so it's contraindicated in infection and early postoperative period. And because the camera's weight can decrease the perceived severity of the stage and of the disease and the blast disease. And there have been reports of retinal hemorrhage during RetCam examination due to the weight of the camera. And it captures only 130 degrees of the fundus. What about ultra-wide field imaging? We know that the ultra-wide field imaging can capture 200 degrees image of the retina, and it is non-mydriatic. However, for easier capturing in premature babies, I usually dilate the pupil. And of course, it's non-contact, and this is a huge advantage of ultra-wide field imaging. So how can I capture images using Optos in those infants? First, the infant is wrapped for more comfort during capturing and for prevention of hypothermia. And I use topical anesthesia. Then I use eyelid speculum to open the eye. And I usually place a few drops of lubricant to prevent corneal dryness due to opening of the eye by the speculum. So in this photo, you see low quality of the image and artifacts from the corneal dryness. Just after applying a lubricant, you can see how we can capture a high resolution image without any artifacts. And then one assistant holds the infant, and a second assistant holds the infant's head to keep the head stationary during the capture. Then when the light on the screen turns green, the photographer presses the shutter button. But sometimes due to excess mobility of the head or movement of the head, sometimes we cannot capture on the green color. So if I can capture on the blue color, that's good. I can still get a good images by capturing on the blue color. So ultra-wide field imaging can accurately detect and diagnose stages and zones of the ROP. Like in this photo, we can see here stage 0, which is immature blood vessels without any ROP. And here is a stage 1, which is demarcation line that divides the vascular retina from the avascular retina. Then as the disease progresses, we go to stage 2, which is a ridge. The ridge has height and width and develop from the demarcation line as the disease progresses. Sometimes you have a ridge with excess vascular branching close to it, but as we see in this case, here there is a blood vessel crossing the ridge. If you see a blood vessel that start to cross the ridge, this indicates a regressing disease. This is a good sign. As the disease progresses more, we go to stage 3, which is extraretinal fibrovascular proliferation. We see here new vascularization extending from the ridge into the vitreous, like also in this photo. And here we can see also new vessels, and we can see clearly the ridge and the vascular branching adjacent to that ridge. If the disease is not properly treated, we go to stage 4. Here in this photo, we see a stage 4A, which is partial retinal detachment, not involving the macula. When the macula get involved, we get stage 4B. If we have total retinal detachment, we get stage 5. As the severity of the ROP increases over time, the retinal blood vessels develop dilatation and tortuosity, giving the blast disease. Here we see in this image the blast disease. There is dilatation and tortuosity of the blood vessels. Also, ultra-wide field imaging allows us to accurately follow up the progression of the disease. So here we see a shunt vessels and the flat ridge at zone 2. And after 1 week, there is progression to stage 3. Here we can see that the flat ridge developed multiple new vascularization. But still, we don't have a blast disease in this case. This is the other eye of the same patient. Here we have a demarcation line with mild peripheral vascular branching and tortuosity. And after 1 week, there is progression also to stage 3. We can clearly see new vascularization. Here is another patient that progressed from stage 2 to stage 3. Here we can see a stage 2 in zone 2 with no plus. But after 1 month, the ridge evolved into a new vascularization, indicating the progression of the disease. Here we can see new vessels that developed over the ridge. But then vascular growth happened or occurred distal to the ridge. So the ridge developed a new vascularization, indicating a progression. Then the vascular growth happened at more peripheral location, meaning that we had a regressing disease at some point, but then the disease progressed again, leading to formation of a new ridge at a more peripheral location to the old one. So in ROB, we can have regression and the progression of the disease, multiple attacks of progression and regression of the disease. There is a special entity of retinopathy prematurity, which is called aggressive retinopathy of prematurity. It's a rapidly progressive severe form of ROB. Its clinical features are characteristic and different from the classical ROB. And if not treated at the proper time, this disease usually progresses to stage 5 ROB. And it is usually seen extremely premature and low birth weight infants, and those associated with bad general conditions like sepsis, pulmonary disease, and necrotizing enterocolitis. As we see here, this is a case of aggressive retinopathy prematurity. It's usually a posterior location. We have a prominent plus disease with tortuous retinal arteries and dilated retinal veins at the posterior pool. But the hallmark of that disease or this entity is that plus disease is out of proportion to the peripheral pathology or the peripheral retinopathy. So we don't see here the ridge and the extra retinal new vascularization we see in the classical ROB. But what we see here is shunt vessels and large vascular loops as the junction between the vascular and the avascular retina. This is very important because we don't develop here a ridge and we don't develop here an extra retinal fibrovascular proliferation. So we see a plus disease out of proportion to the peripheral pathology. We see shunt vessels, we see vascular loops, and here we see also the vascular loops and the multiple shunts between the vascular and the vascular retina. And there is also a very important characteristic of this disease is that we see a large avascular area within the vascularized retina. So if you see here, there is large, at the site of these arrows, we see a large avascular areas inside the vascularized retina. And we see a flat network of new vascularization early in the disease, and as I said before, without a pre-existing ridge. So it is usually a flat network of new vascularization without ridge. Sometimes we in aggressive ROB we can have hypoplastic major arcades and hypoplastic macular vessels. So as we see here in this case, the arrow is pointing to the fovea, but as we see here, there is a very poor development of the macular arcade. So the arcades are just developed just beyond the very little distance beyond the fovea, but most of the macular arcade are not formed. Here's the other eye of the same patient. We have also a hypoplastic major arcade and hypoplastic macular vessels. As I said, this disease, if not properly treated at the proper time, it usually rapidly progresses to retinal detachment. This baby was examined by another retina specialist and diagnosed as aggressive ROB. The case was referred to me, but the parents came after 3 days. Just after 3 days, we started to have a retinal detachment here peripherally. So now we have a stage 4A just in 3 days. Also, ultraviolet field imaging helps in follow-up of ROB patients after treatment. In this case of aggressive retinopathy prematurity, I gave an intravitreal injection, and after 1 month, we can see the regression of the blood disease, and we can see the disappearance of the hemorrhage. But we can see that there is still vascular loops, as these arrows are pointing to the vascular loops. But after I followed this patient for another month, after 2 months of the injection, we can see that all the vascular loops have disappeared. and the blood vessels started to go to a more peripheral location. But as we see here, we still have a large avascular area. I'm still following up this baby to see if this large avascular area will vascularize or not. This is the other eye of the same patient. 1 month after treatment, also we have still some vascular loops persistent, but after another 1 month, after 2 months from the injection, we can see that all the vascular loops have disappeared. Case 2 is also an aggressive retinopathy prematurity. After injection, we can see disappearance of the blood disease, disappearance of the vascular loops, and just a very minimal loops remaining. But after 5 months from the injection, we can see that the retina is completely vascularized. The other eye of the same patient with aggressive.
We are behind the time. If you can.
Okay. This is all. These are the same cases of aggressive ROP. Just is the last one. This is follow up after laser treatment. This infant had injection 2 times and then had in recurrence after the second injection. I lasered the retina and now we can see the good laser treatment with no skip areas. Ultraviolet field imaging can help to make sure that you don't have skip areas of laser. And finally, we can assess the persistent avascular retina after injection. Here we have this infant at 65 weeks post-menstrual age. We have a large persistent avascular retina. Here we have also a persistent avascular retina. In this case, we have a very small persistent avascular retina, less than 1 disc diameter. So take-home message that ultraviolet field imaging capture a 200 degrees image of the retina. It's non-mediatic, it's non-contact, allows accurate diagnosis and follow-up of the ROP, but has many limitations. May be difficult to capture images if the infant is very irritable with excessive head mobility, and it's difficult to capture images as the infant gets older, and it cannot be safely done if the examination requires general anesthesia, and there is artifacts from the lashes and the speculum. Thank you very much.
Thank you very much, Dr. Ahmed, for this an excellent illustration about using a ultra-wide field imaging in retinopathy of prematurity. Maybe we'll come back to you at the end of the presentation for discussions. Okay, so we can move now with the last presentation by Dr. Fahad Kuhail. He will talk about the role of wide field imaging in uveitis. Dr. Fahad.
Hi, Mohammed. Can you, first of all, thanks for the kind invitation. Can you hear me clearly?
Yeah, we can hear you. Can you share your, please?
Of course. So again, thanks ever so much, Mohammed, for kindly inviting me to participate in this symposium. So I was very interested in both the 2 previous talks, particularly Prasan's. You know, it's fascinating to see that wide field may become more, quite quantitative and not just qualitative. Much like we use OCT. So there seems to be a lot of research invested in using how to use wide field imaging diabetic retinopathy to better make treatment decisions. In uveitis, I think it's still at the qualitative stage, and we're still kind of finding our feet, and the research isn't as well developed as, say, in diabetic retinopathy. But when I trained as a fellow, you know, all we had was a color fundus photograph that had a 30-degree field of view. So this is a patient with serpiginous choroiditis. He's got fingers in the right eye. Yes, you can delineate some of the chororetinal changes affecting the macula. But in the olden days, when you had the old camera, if you wanted to get outside of the macula, you had to do what we call a 7-field photograph, where the disc and macula would be photographed, the posterior pole would be photographed, and then you'd get the patient to look up and left, down and left, up and right, down and right, to get those supranasal and infertemporal quadrants. And then using clever software, you'd stitch this together in order to make a montage. And you know, as far as 2013, this was a patient of mine with diabetes, and you take this kind of sequence of images, and then, like I say, the software was clever enough to stitch it all together to make a montage, but still you're getting a very limited field of view. You're talking 50, 55 degrees possibly. But you know, and you've seen it in all the talks today. You know, Optos wide field, in one image, you're getting vast swathes of retina at one time, and just really helps in identifying pathology, identifying features that sometimes you might even miss on slit lamp biomicroscopy. So, it's really made a difference to my own practice. So this is the same patient. So this is the serpiginous chorioretinal atrophy. I look at how much more information you get from one particular capture. So, for example, although my biomicroscopy is going to be good, I'm going to identify all of these changes. Do you really think my drawings will be as accurate and as precise in order to monitor this disease over time? And sometimes with some of these uveitis patients with very low-grade retinopathy, so they're not got aggressive vitritis, aggressive cells, pain. Sometimes it might just be chorioretinal lesions. How am I going to detect that my immunosuppression over time is keeping the disease under control? Well, it's simple: OCT, autofluorescence, but also wide field photography, because then I can compare the same patient, the same eye over 12 months. And if I see the same distribution of chorioretinal lesions, then I'm confident that I'm keeping the disease under control. So really it has made a difference in the treatment decision-making, as well as the diagnosis. So in my own practice, I use the Optos, I use the autofluorescence, I do wide field FA, wide field ICG. With the Heidelberg, I tend to image with the 55 degree or 105 degree and use wide field infrared reflectance as well as FI ICG. And I kind of use all of that together to kind of make treatment decisions about the patients, either in terms of diagnosis, but also monitoring the patient over time, particularly if it's a cold uveitis. So the patient hasn't got pain, the changes are very, very slow over time. How do you know what you're doing is enough to keep the disease under control? Imaging is the way forwards. And we'll very quickly skip over this, but essentially, you're getting this wide field image because you're looking at the light reflection along an ellipsoid mirror that's then reflected on the back of that eye. And then these are the lenses that I would use on the Heidelberg. So this is the 55 degree that allows you to do wide field infrared reflectance, autofluorescence, but also you can capture wide field OCT. Not quite as good as the Optos wide field that Prasan showed us, but still gets really good quality images. And then this is the 105 degree to allow you to do a wide field fluorescein angiography and ICG. So this is a patient who came with toxoplasmosis. She had significant sudden loss of vision, first ever episode. She had this area of retinitis supratemporally. You've got widespread periphlebitis. And so I treated her with orosteroid, azithromycin. This is her left eye. And again, if you pick up, you can see these subtle chorioretinal changes in the nasal fundus of the left eye. This is the autofluorescence that you get with the Optos. So that's probably a leopard spotting or bear track change in the left eye. And then this is the wide field OCT. As I said to you, taking the 55 degree, and there's a cut through the active lesion. You've got an elevated hyperreflective lesion with choroidal shadowing, with vitreous cells in the pre-retinal space. This is very typical of toxoplasmosis, and there's a really good paper by Dr. Agarwal from Cleveland in the Survey of Ophthalmology, where he really describes some of the OCT findings in various forms of retinitis. And urge you all to read that very, very useful article. But this was her eye afterwards, about a month afterwards. And as you can see, the retinitis is getting better, the view is improving. You can now see some of the RPE scarring, which kind of helps you confirm that you're dealing with toxoplasmosis. And these changes here are just artifact, dirt that's within the lens. And obviously her periphlebitis is improving. And then this is the wide field autofluorescence. Again, you're seeing a regression in that area of retinitis with some hypofluorescence on the autofluorescence, confirming that we're dealing with an RPE or chorioretinal lesion. This is another patient who came in with Behçet. So he comes to casualty back in Sheffield, where I used to work in the United Kingdom, with sudden loss of vision in the right eye. He had hypopion, he had previous history of penile ulcers and erythema nodosum. He had a macular infarct in his right eye, but as far as I was concerned, the left eye looked to be normal. There was no AC inflammation, the vitreous was clear, disc was healthy, macula was healthy with normal retinal vessels. And obviously, as you know, with Behçet's, we like to see bilaterality to be confident that we're dealing with Behçet's, because otherwise you see retinitis like this, you need to be thinking about acute retinal necrosis or a viral retinitis. In this case, I was more relaxed because of the other constellation of symptoms that made me feel this is Behçet's. But as always, you want to kind of see that bilaterality to reassure you that you are treating the right thing and you are along the right lines. So this was his fundus fluorescein on the spectralis, again, 55 degree. So you get a bit more of a view than the disc and macula. And as you can see, he's got widespread leakage in that right eye with hypofluorescence due to the retinal ischemia. But the key thing is the left eye. So again, if you look at the 55 degree, the left eye looked to be what we call normal. But on the optos, you can see disc leakage and peripheral leakage that I could not identify clinically. So without wide field fluorescein angiography, I would have missed this subclinical peripheral retinovascular leakage. Really helpful in cementing that this was the right thing, and we could escalate him straight away onto anti-TNFs. And he was started immediately on intravenous methylprednisolone. He did well. This is another case of a patient with just on color fundus photography. So although I've examined him, the view is sometimes very hard. I'm suspecting he's got sarcoidosis because he has chronic cough, shortness of breath. His chest X-ray shows bihilar lymphadenopathy. But again, I'm trying to identify all the periphlebitis lesions. So I've spotted some of them, but you can take an optos and you identify even more, and you've got something to compare to over time. And then this is his fellow right eye. And again, fluorescein really helpful in identifying these kind of peripheral vascular changes. And the wide field fluorescein was helpful in this case, because although you could identify periphlebitis on the fundus photography, on clinical examination, it wasn't a particularly exciting fluorescein, no significant retinal ischemia. So I decided to treat this patient with topical steroids only and not institute systemic immunosuppression. So here, wide field fluorescein angiography had a real bearing on my treatment decision making. So does wide field influence management? So this is really good paper from Dan Doe and Kwan from the United States, where they studied the impact wide field retinal imaging has on management in non-infectious uveitis. And just if you look at the highlighted section, management was altered in 16% of patients based on examination and limited FFA, whereas in 48% of patients had a management change with the use of ultra-wide imaging and angiography. So clearly, ultra-wide field allows you to detect this greater disease activity and really helps you as a uveitis consultant to escalate the treatment decision making should you need added evidence to be more aggressive. And like I say, if it's a hot uveitis, it's easy because the patient will be in pain, the vision will be blurred. It's when it's cold uveitis when the problem. Mohammed, do I need to stop? Do I need to stop?
Yeah, please. If you
no
are
problem.
okay.
No problem. Thank you.
Thank you very much, Dr. Fahad, for this excellent presentation and in the form. Okay, so let us just have a few questions. We have Dr. Majdi, Dr. Ahmad, Dr. Prasan, and Dr. Fahad. They cover most of the use of wide field in diagnosis and their effect also in our treatment. Is there any question to Dr. Majdi? He gave us an overview about the role of the wide field in diagnosis and management, effective management in different things in related to retina and either age-related or whatsoever the disease he mentions. Any questions, Dr. Majdi? Prasan, because you are the one who was with us.
Dr. Majdi, I want to ask you the role of peripheral OCT in retinoschisis. do you use it regularly, and how do you use the peripheral OCT? Because I find it a very interesting tool. Because in the past, one of the ways to monitor these patients with peripheral retinoschisis was to do sometimes a visual field, because we know that retinoschisis usually causes an absolute scotoma, and if you want to see a progression, one of the ways was to do visual fields in this patient. But you have some patients who are very small, young patients like 11, 12-year-old who have these schisis in the periphery. So do you regularly do OCTs, peripheral OCT for these patients?
Thank you for the question. It's not all the patients, because again, sometimes the young age is not that cooperative, but I use the swept source. So sometimes I sweep the periphery by radial line scans, 12 millimeters, just taking multiple line scans through the periphery to examine if the schisis, how it's extending, how much elevation of the retina, if I can detect any inner or outer holes. But still, it's a bit difficult. It can be done, but it needs full dilatation because you need the periphery. It needs a rapid screening. You cannot do the cube because the cube is not that high definition. So I use the radial 12 millimeter for the periphery, 2 radial line scans, 12 millimeters, so I can detect. And as your question, I have just a case yesterday with a retinoschisis, and I need to see the progression in the periphery. And he was 26 years old, so he's very cooperative. And I see the macula and I see the periphery. So it's another way to, to monitor these patients and to see what is going on, especially if the patient develops new symptoms sometimes.
Yep. Yes, Fahad, please go ahead.
I mean, it's really good, Professor Magdi, that you do have an ultra wide field kind of OCT. I mean, do you really feel it's made a big shift in your practice or your diagnostic ability? And do you think people should just swap their current Optos for this, or wait till they need to upgrade their Optos so their Optos breaks down and they're looking for a new one? Or should we just get rid of our current ones and buy this because it's a game-changing development?
I don't think we can afford doing that in Egypt. We don't afford these things in Egypt anymore. So again, whatever you have, keep it and use your talent to do that. But you see, the Optos is, I think it's one of the best up till now. And I've seen a late presentation by Dr. Paulo Stanga where there's a navigation, OCT navigation on top of ultra wide field in the California Optos. So they can, just demarcate where the area you want after taking the color. You just put the demarcation.
Dr. Majdi, we lost him, or are you still hearing him? Prasan?
No, we are not hearing him. I think we lost him.
Dr. Majdi, we have
We've
some
lost
issue
him.
of connection. Okay, I want to ask you, Prasan or Fahad or Dr. Ahmed, can you use a wide field imaging in just to without examining the patient? So if you are in a busy and they give you the photos, so you can make a decision on that, because sometimes even you can see better than when you are examining by yourself sometimes. What do you think about that in practice? I mean, yes, Fahad, please.
So in the UK, we were doing it all the time because there was one doctor for a lot of patients. There was absolutely no way I could physically see them all. So what we used to do, we used to take an Optos or a Claris with an OCT, vision, pressure, and then myself and a team of optometrists who are kind of very trained in assessing diabetic retinopathy would use that to make decision-making regarding anti-VEGF, laser. And, we were very successful with really good outcomes. And very few patients kind of came to casualty because we'd missed some neovascularization or missed some diabetic macular edema. I don't particularly do it in the UAE because I'm working in a private setting. And so the patients want to see me. But definitely, if I was in a government hospital and my burden of treatment was greater than my ability to deliver, then I would definitely use these imaging in order to assess patients. I think it's just as good. And then from time to time, you would catch up the patient for that human face-to-face interaction.
Okay.
And I was doing it for the last decade in the UK.
Okay, Prasan, please. Yeah, Prasan, because we have no time. Can we go fast, please? Yeah.
Yeah, Dr. Amri, just to say that we are all trained with indirect and scleral depression. So that's our bread and butter sort of. But the only indication where I really feel Optos plays a role is pediatric retina cases. Because these pediatric retina cases, invariably, they are very uncooperative. Even if you have a full dilatation, you sometimes miss findings. So I think one way to look at the retinas of pediatric patients to do an optos, and then you can get a very wide field image and also very magnified image. So you can try and pick up subtle changes happening in the pediatric retina. So that's why I find it very practical to use optos.
Just one comment. I want to take this one from Dr. Ahmed. You know that sometimes you don't want to dilate. You know, some patient, they come to you and he is following with you, and you want just to, yes, he want immediately to go, and he don't want to be dilated. So whenever you do this one wide field imaging, it can, I mean, take a lot of burden from you and make you can be, I mean, satisfied that you have seen, is there any medical legal about this one, or you can go ahead and make a decision on that. Ahmed.
Yes, absolutely. So for pediatric retinal disease, almost I use it routinely in every visit for ROP patients. But in adults, I see a huge advantage for non-dilating subview. So let's say if I have a patient with BVD, I want to examine him every 2 or 3 weeks. I don't want to dilate him every 2 or 3 weeks. So if he comes to me every 2 or 3 weeks, I will just do an optos. I will not dilate the patient. So I think this is a huge advantage that we can examine the entire retina without dilatation, as you said.
Okay, I mean, for follow-up with diabetic patient having diabetic retinopathy, or he is not having any diabetic retinopathy, can you depend, okay, to take a decisions about that?
Yes, absolutely. I can take decisions only on depending on options. Yes.
Okay. I think we don't have a time because we move little. The time is move very fast, but the presentation was superb, and it was very nice and excellent. We need a lot of time to discuss, especially your cases, Dr. Ahmad and Prasan and Fahad and Dr. Majdi. But unfortunately, we are behind the time, and I think Dr. Muhammad Awadallah, he is steering to me by his eyes looking. He wants to take over. So we want to conclude our retina, and we can pass the mic and floor for Dr. Muhammad Awadallah for surgical retina in this hall. Thank you very much, Prasan, Fahad, and Ahmad and Majdi, and see you inshallah in the future. Bye-bye.
Thank you. Thank you, everyone. Thanks a lot.
Here with Awadallah, no problem. You can join us also. It's a great honor if you want to have.
Thank you. Thank you.
Thank you, Dr. Muhammad, for this great opportunity and invitation to QOIC. And it's a real pleasure to have such a great lineup of speakers from all over the world. And our session today is going to be on the challenge of dealing with intraoperative complications, as we can see. You know, the more you operate and the more you run into complications, and what makes a good surgeon is the way he deals with complications when they happen. And without further ado, let me introduce our first speaker today. I'm not sure he is here, Dr. Hussein Khan. Is he with us now?
I don't think so. I will just contact him. Can you move to the next speaker, please?
Okay. And Dr. I don't see neither Dr. Ahmed Salam. So
he's in some.
Is Dr. Ahmed Salam here?
Yes, Ahmed Salam here, please. Yes.
Okay. So we'll introduce our first speaker, Dr. Ahmed Salam. He's an associate professor of retina uveitis and director of uveitis service in Jones Eye Institute, University of Arkansas in United States. Please, Dr. Ahmed, can share your slide?
Yes. Sorry, just 1 second. Some issues with the camera.
Sure.
But we can see you even if you are not seen, Dr. Ahmed.
Yeah, we can see you, Dr. Ahmed now.
All right. Well, thank you so much. Great to be here, and thank you so much, Dr. Awadallah, for the kind introduction. Sorry, I was playing with the video, so let me just get it to play. Okay. Okay, can you see my whole screen or?
Yeah.
Okay.
Yeah. Okay.
Or it's just part of it?
It's a part of the. I can see a part of the fundus.
Sorry for that. I don't know. Let me just try something.
Okay, sure.
So I apologize.
Yeah, we can see it. Yes.
Yes, sorry. I don't know what happened.
You just pressed on the button on.
Yes.
Down and to the right, Dr. Salam. Can see
screen.
Those arrows.
Okay. I think I got it now. Okay.
Okay.
Okay, can you see my whole screen now?
Yes, yes, yes,
okay.
we can.
All right, this is a very interesting case. It's actually, maybe probably I've made it more interesting or more complicated for myself. So this is a patient who comes on with a MAC-off retinal detachment. She is 50. And all what we can find is that 2 retinal breaks here. I don't know if you can see me like circling. One of them is a horseshoe tear and one of them is an operculated tear. So we know that this patient has PVD. And for some reason, I wanted to put a radial buckle on this patient. I thought I can nail this with a radial buckle. And I gave the patients all the options and I've skewed her to choose a buckle. I've made her like feel that the buckle would be the best thing for her. She's on the young side, clear lens. And that's what we decided to do. And I kept dreaming of me putting a nice radial buckle there to get the 2 tears together. So that was the plan. So here we go. So this is the surgery here. So we open the conjunctiva, we hook the medial rectus and the inferior rectus, and we put 1 trocar just for elimination when needed, opposite to the detachment and the breaks. And this is here localization. And I already, usually before opening the eyes with buckle, I would do a 360 indentation 1 more time to make sure there are no other breaks in detached retina so that the plan would not change. So I didn't find any other breaks, those 2 breaks there, a bit posterior, but I thought I can get these on radial buckle, on a radial buckle, a 5mm buckle. And that was the plan. This from another surgery. So that's the technique I would do. I would localize and then go 1.5mm times the width of the buckle I chose. So be like here about 7.5mm, put the suture. And it's usually a wide suture. And then after that, I would put the 5mm, press it. And that's what I would do. And then I may or may not drain, depending on how things are. And the plan was here and drain. So this is the plan, and that's what I wanted to do. The problem is when I opened and I localized the break, that's the situation here. You see, this is the issue. It's actually just very next to the vortex vein. So the question is what to do now. Shall I just try to put a buckle there, or cut the vortex vein, or leave the vortex vein, or change plans? And I just was not expecting it, because on examination, and you'll see later during the surgery, it didn't look like it was near the vortex vein. But the problem is the breaks were near the exit of the vortex vein from the eye. So just a reminder here, there's an anatomy picture just to show you what the position of the vortex vein in the oblique quadrants, more towards the vertical recti. And that was the situation in her. And we know that if you damage the vortex vein, you can get problems including choroidal detachment, vitreous inflammation, vitreous hemorrhage, and raised pressure, and even up to anti-segment ischemia. But what I really did not know, if I just damage 1 vortex vein, is this going to happen or not? So it's all going through my mind. So I just decided to back off and change the plan. So that's what we did. We now converted, we set up for vitrectomy, and we converted here. There's a 3-port vitrectomy. the fellow was happy because he took over and now he's doing it. And again, I'm just playing with the filters here, trying to annoy him. But here it is. So vitrectomy. She had PVD from the detachment. We tested with Scanalog, and she's phakic. So we're changing hands here to remove the vitreous. And I'll show you my technique for retinal detachment that I do usually. Here we remove the operculum, and then we remove the flap of the tear just to remove traction. And then just continue with the vitrectomy. And then the important steps. So we finish the vitrectomy on both sides, and we do internal search, make sure no other breaks are there. And then internal search the other side, and we have the two breaks, and you will see them here. And you'll see them, they are away from the vortex vein. You'll see them there in a minute, but it's just the exit of the vortex vein. We found a small thing here, which ended up just being an operculum. We touched on with cryo, which probably was just not needed. And then here, he marked one of the breaks. And then we go under air. And the modification we do is just we drain only from the break. We do not drain over the disc, because the idea is that, or in my mind, if you drain over the disc, more fluid is shifted towards the posterior pole, and that may lead to retinal displacement. So I try to avoid that step. I just drain from the break and that's it. And I end up with a smaller gas fill, but for this break, it's fine. So here, drainage from the break. And again, it's the fellow operating. And you can see now with the vortex vein, but it's just the exit of the vortex vein that was just behind the anterior break. We're draining from the posterior break here. So again, this is the step. We're going to drain from here, and that's it. We don't drain over the disc. Then laser or cryo. One or two breaks, I like cryo. It's very quick and very cheap. So cryo, and then that's here. Surgery finish, and we replace with 25% SF6 just to give us a bit of a more fill. So it's a segmental bucket that we converted to vitrectomy and cryo and SF6. Thank you so much.
Thank you, Dr. Ahmed, for a nice presentation. Let's assume another scenario that you went for the buckle. Okay, how would you what's your plan? I mean, do you think if you just put the sutures are narrow in a narrower, not to get wider sutures, could have avoided the vortex veins, or
I think it's a great question, and I really don't know. I thought I could not do it, and I thought it's just not going to work. And I re-looked at the video several times. I mean, thinking could I have like undermined it, but I think I would not be able to do it. I think I could have done it without cutting the vortex vein, which probably is the important thing. And maybe when I showed the video to several colleagues, they said one vein is not going to cause a problem if you just press on it. But I really did not know, and it took me by surprise, and I didn't know what to do. That's why I converted the situation. But yeah, I would love to hear from you and the other panel.
Talking about a complication. So if, God forbids, you had some injury to the vortex vein, what's your management then?
I honestly don't know. I've never encountered this situation. I think as long as you don't cut it, but I think if you cut it, it may bleed in the eye. I really don't know. I mean, I think I would clamp it and diathermy, but I would love to hear from you and the others.
Any of the speakers we have today, Dr. Singh, Dr. Samir, Dr. Borden, has any encountered such a complication of having a vortex vein injured during buccal surgery?
Hello, everyone.
Okay, you can go.
Thank you. Oh, thanks all for the invitation. I'm Arnaldo Bordon from Brazil. I myself never had this complication, but however, in our hospital, we have 12 fellows. And of course, they're learning and we encounter some complications once in a while. So once one fellow was doing a surgery with another preceptor, and accidentally he put the needle in the vortex vein and started bleeding a lot. What he did at that time, he put some with a Q-tip, a lot of pressure to the vortex vein and stayed there for like 4 or 5 minutes compressing, and eventually he stopped bleeding without doing diathermy as you suggest. So I think we can manage, bleeding in several ways, such as compressing or diathermy or even laser. Sometimes depends on where you are. So I think it's a rare complication, but it causes a lot of stress during the OR, and eventually you can stop the surgery. You even stop the surgery and schedule for another day. So.
Dr. Samir, I know that you do buckles, especially macular buckles, a lot. Do you encounter such a complication? How would you avoid this?
First of all, I would like to thank you for the invitation and thank Dr. Mohammed Al-Amri for the invitation. I would like to welcome my friend Ahmed Salam and Dr. Arnaldo and Dr. Devendra. I think Ahmed's case is a very nice case and he had a very nice presentation. But I think the case is not a case of buckling because the break is post-equatorial. But I think it's very hard to put a buckle in that place. We can put buckles more posterior by using the macular buckle, but we put it between the lateral rectus and superior rectus. Okay, so we don't encounter in this place. It's away from the vortex vein. If there is any injury for the vortex vein, it is a hell in the surgery. It can cause choroidal detachment. It can cause unstoppable bleeding. So I think Ahmed had done well, had managed very well the case. And I think that the case was from the first in my hands for vitrectomy more safe because it's a very posterior break.
Yeah, I think, that sometimes you think, actually, I can do this. And I think I just try to do more buckles. And I think if the vortex vein was not there, we could have easily got it on a nice radial buckle. But no, I agree. I mean, it's how the situation went. Thank you so much.
Yeah, I think can I add one comment? Yeah, thank you for inviting me. Am I audible? Yeah, I think I just quick question to Dr. Ahmed that if this break was close to vortex vein, wouldn't laser would have been a better option? Doing cryo, I don't know what kind of injury cryo can bring to vortex vein also, but I would rather prefer doing sealing it from inside if it's close to vortex. And second, we don't do too many buckles here, but still, whenever we encounter this vortex vein, we go needle from the other side, the side which is attached to the thread, and we put that needle underneath the vortex vein, and this is how we negotiate the vortex vein. So we go underneath, but we don't go to taking the pointed tip underneath it. We go from the other side. Reverse needle.
I mean, I think, shall I reply for the point on the, I think cryo is absolutely fine. I mean, we never had any issues with cryo on the vortex vein. I think 1 or 2 breaks, cryo is very good, really. And I don't think there's evidence to show even like that cryo increased PVR for 1 to 2 breaks. It's just very quick, very cheap. And it's just easy, you don't need to dry. I think more than that, then we definitely laser. That's what we tend to do. It's just very quick.
Yeah. Dr. Awadallah, you have to unmute yourself.
Okay, sorry for that. So I used to hear from the masters of implants before they were doing implants, clear implants. They put in a pocket. They used to ligate when they encounter the vortex vein. You just ligate the veins and you use the thermy. But again, at that time, we didn't have such, safe vitrectomy surgeries. But I think what Dr. Ahmed did is just great, converting to vitrectomy on the spot. Thank you, Dr. Ahmed. And let's move to Dr. Mohammed Samir presentation. Next, Dr. Mohammed Samir is a VR consultant at Alexandria University in Egypt and Harvard associate. Please, Dr. Mohammed, can share your screen.
Okay.
Okay. Yes, we can see your screen now.
Okay. Thanks again for the invitation. I will talk today about a very common complication and a very common backfire of the diabetic vitrectomy, which is bleeding. How to attack this bleeding, how to attack this problem. We have preoperative maneuvers, intraoperative, post-operative maneuver. The post-operative maneuver are directed to decrease the post-vitrectomy vitreous hemorrhage. The preoperative maneuvers mainly considers the preoperative systemic evaluation, blood sugar level, blood pressure, bleeding profiles, anti-VEGF and PRP, and I'm going to speak about them later, and the anesthesia. The local anesthesia plus sedation is more preferable than the general anesthesia, because general anesthesia tends to decrease the post-operative blood pressure. This decrease in the post-op blood pressure while awakening the patient opens the blood vessels and invites the post-vitrectomy vitreous hemorrhage. So its local blood sedation may be better in these situations. Here I have, according to the preoperative assessment of the patient, if the patient is on anticoagulant coagulation therapy. This paper has concluded that the patients undergoing diabetic vitrectomy who are on anticoagulant or antiplatelet agent do not exhibit a higher risk of intraoperative or post-operative hemorrhage. So it may be safely continued during the operation without stopping, and at the same time you may put the patient to the complication secondary to their initial disease or systemic disease. So in my cases, I don't stop anticoagulants or antiplatelets during the surgery. What about the anti-VEGF usage in these cases? Another paper or literature review, antivascular endothelial growth factor therapy for PDR, it concluded that the use of anti-VEGF agents before the PRP, or in our situation here before vitrectomy, may decrease duration of surgery, may be associated with fewer breaks and less intraoperative hemorrhage. Although there is evidence for decreased incidence of early post-operative hemorrhage, the quality of evidence is low. The available data therefore support an anti-VEGF agents as adjuncts to the PRP and pars plana vitrectomy may decrease the intraoperative hemorrhage during the surgery and the post-vitrectomy vitreous hemorrhage, and decrease the rate of break formation during the surgery. And as we all know that the anti-VEGF injection before the surgery by maximum 48 hours or something like that, it facilitates the dissection of the fibrovascular membrane and it decreases the incidence of intraoperative bleeding in vitrectomy. Intraoperative bleeding during vitrectomy for traction retinal detachment with and without the preoperative anti-VEGF, which the IBETRA study, it concluded that the preoperative intravitreal bevacizumab injection was associated with reduced intraocular bleeding during 23-gauge vitrectomy in macula involving traction retinal detachment. And there's other randomized controlled study with intravitreal bevacizumab injection 1 day before surgery for the proliferative diabetic retinopathy, and concluded that the intravitreal injection of bevacizumab 1 day before the operation blocked the vascular endothelial growth factor production in vitreous and significantly decreases the incidence of reoperation due to post-operative recurrent vitreous hemorrhage. And this paper was published in Retina 2015. So this was the attacking of the vitreous bleeding during diabetic vitrectomy before surgery. We are going now to discuss the hemostasis during the battle itself. We can elevate the infusion pressure. We can do thorough endodiathermy to bleeding points, good shaving, good membrane dissection without leaving of fibrovascular islands, good segmentation, diathermy of the vascular edges, and decreasing the IOP at the end of the surgery to check bleeding points and attack these bleeding points at the end of the surgery with low IOP by endodiathermy. Preventing post-operative hypotony, which is very important to close the sclerotomies and to be sure that there is no leak from the sclerotomies, and preventing post-operative cough or vomiting by the aid of the anesthesia consultant. So this is a video showing the how to do the shaving. It's about 6,000 to 7,000 cuts per minute, and with 150 millimeter mercury, extending to all the vitreous base, like we are seeing here at after performing the core vitrectomy. In this case, this is a case of combined traction rheumatogenic retinal detachment with subretinal blood, as we are going to see here in the video. So how to stop the bleeding points? This part of the video will show the power of air in doing the hemostasis, as we are going to see now, converting to air fluid exchange, and getting, this is the main break, getting the viscid subretinal fluid, which is like the viscosity of the vitreous, as we're going to see here, and elevating the blood, elevating the pressure of the infusion. This part you can elevate to 80 or 100 millimeter mercury to 1 or 2 minutes to stop the bleeding, especially the bleeding from the retina artery and retina central retinal artery and veins. This is another video. We have always a debate about the stump, the optic disc stump. Is it better to leave the stump or it's better to remove it? In this video, you will see that removal of the stump will induce a bleeding, and this bleeding may be unstoppable bleeding. So in my opinion, it's better to leave it, but doing diathermy at the vascular edges of this stump will be better, because it will cause the central retinal artery and vein or central retinal vessels bleeding, as we are going to see here, and it may continue bleeding for a good amount of time, even by doing every maneuver to stop the bleeding. Here I use the air as a tamponade, as a hemostatic element, by elevating the pressure to 80 to 100 for 1 or 2 minutes, and it stopped the bleeding at the end of the surgery. And at the meantime, securing the sclerotomies at the same time is very important, because securing the sclerotomies will prevent hypotony, and this hypotony will invite post-operative bleeding. And in this case, after I finish, I left the patient on air, and I inject intravitreal bevacizumab as well at the end of the surgery. This case, as we see here, with multiple bleeding points, with subretinal bleeding points. At the end of the surgery, I used to do hemostasis using the BFC. The BFC will do a third-hand job. It will decrease the bleeding points at some extent, and at the same time, it will help removal of this broad blood clot submacular, as we are going to see in the video, and remove this huge blood clot, just submacular blood clotting, as we see in this part, getting it out and using the BFC as a third hand to fix the retina and stabilize the retina, and doing vitrectomy to this huge blood clot, and after that using the air and doing laser at this retinotomy, and at the end putting silicone oil tamponade. And this is the photo of the patient at the end of the surgery. This is another patient after closure of the sclerotomies. Some hypotony occurred and leaking hemorrhage had dribbled from the sclerotomies to the macula and to the optic disc, as we see here. And the patient is, I think, silicone filled. So I entered again. Sorry, the patient was air filled. So I entered again to remove this hemorrhage, this blood dribbled through the sclerotomies, and I used here. This is not silicone. This is viscoelastic material. I put this viscoelastic material through the float needle. I put the float needle on the viscoelastic material, and I injected this viscoelastic material over the optic disc and the macula. Even if any other dribbled blood occurred, it will be away from the island of the viscoelastic material at the early post-operative minutes. Something is very interesting in these cases. In post-vitrectomy vitreous cases, you can be confronted by post-vitrectomy hemorrhage and hyphema at the same time. We are used to this, but at some times you may be confronted with something else, which is a surprise. So what is this surprise? This is the amalgam. This amalgam is very, very hard to remove and very, very sticky to the retina. And once you started to remove it, you will remove about 1/3 or 2/3 of this amalgam, and at the end you will be confronted with the anchored parts to the retina, and you will do by a very high percentage a break in this part if we are going to remove it all. So my advice is not to remove it all, as we are going to see now, because removal of the base of this amalgam is very dangerous and more hazardous to the retina, and it will cause many breaks, as we are going to see here. I'm trying to dissect it by the PIC 23 gauge dark PIC, but at the end I left the part away from the macula and put after that silicone oil tamponade, and this is the wise maneuver to get out from this trouble. I had many cases before that. I tried to remove this amalgam, but I failed, and I did many breaks, and it ended not much well like this case. Some people think that, or there is misconception that silicone is always the good solution for this post-vitrectomy vitreous hemorrhage, but this is not the truth, because you can be confronted by a sub-silicone bleeding like this case, which will be trapped behind the silicone, and this trapment behind the silicone is sometimes make what's called fibro or perisilicone proliferation, or sub-silicone proliferation, which will be difficult to remove, as we are going to see here, which is another surprise for the cases of silicone oil injection, that we may put silicone to decrease, in our conception, to decrease the incidence
of post-vitrectomy vitreous hemorrhage. And as we're going to see here, there is here a break. And if I continue like this, it will induce more breaks. So I just remove the parts attached to the macula to free only the macula and leave the else parts. Is there new techniques for the hemostasis during diabetic vitrectomy? Yes, there is new techniques. For example, there is what's called the end aspirating laser probe. This is an end aspirating laser probe. It is a probe like float needle. It's aspirating. It will aspirate the hemorrhage and at the same time will do the laser at the same time, because sometimes we have a bleeding, so we can't do laser while there is an active bleeding. So this instrument is like end aspirating float needle with a laser probe at the same time. So removal, aspirating the blood and doing laser at the same time, and it was developed by Chang. Another thing is the simultaneous blood aspiration and laser coagulation. Other than the aspirating laser, we have a coagulation laser, not the PRP laser, the last slide. We have aspirating probe with laser coagulation of the bleeding terminals. So it uses the laser to act as a diathermy with the blood aspiration. So it's float needle, for example, and at the same time, laser coagulation of the bleeders. This is the second instrument. And there is what's called disposable 20-gauge bipolar endoillumination, in which it is endoilluminator, and bipolar at the same time with illumin, but with excellent illumination. So it gives us a good illumination and at the same time gives us a bipolar diathermy. And thank you very much. That's what I have for attacking the diabetic vitrectomy bleeding, and I am welcoming any questions.
Thank you, Dr. Samir, for your nice presentation, the challenging cases. I think bleeding, intraoperative bleeding with diabetic vitrectomies is quite a challenge. Let's hear from any of the panel, any comments or tips regarding this. Start with Dr. Salam. Do you have any tips for managing such bleeding, Dr. Ahmed?
Yes, I think the first thing starts before the surgery. So in addition to what Dr. Samir said about anti-VEGF, which I like it, it's important to tell the patient that 60% of the patients would have bleeding after the surgery. I think this makes a big difference.
That's very good. That's a very good point, Dr. Ahmed. Yes, I usually tell the patient that 50 to 60% of diabetic vitrectomies will have post-vitrectomy vitreous hemorrhage. That's very nice.
And I think that makes a big difference, so that they are not panicking, and also when you tell them after the surgery, you're not just surprised. And I tell them about 10% of those 60% will need resurgery, full stop. You know, so I've made my life easy. The second thing, I think less is more. I use diathermy. I diathermize only the proud things. So if something is standing proud, I may put diathermy, but I don't like to diathermy flat things on the retina, because I think it increases the risk of retinal tears. And I try to just dissect reasonably. I wouldn't like attack everything. And in my mind, I want to get out of there quickly, avoid breaks, and avoid using oil. And I think that works. And I think bleeding is going to happen, whatever you do. And I agree with Mohammed that bleeding in an air-filled eye is much better than bleeding in oil-filled eye, because you get this membranes under oil. I mean, oil in diabetics is terrible, really. So these are my...
According to the diathermy, I want to add, Dr. Abdullah, please. According to the diathermy, you can adjust the diathermy before usage. You can try it at the fibrovascular membrane or something like that, or fibrous tissue, just to diathermy, just to have a very faint mark. It will do. Okay. But heavy diathermy, of course, as Ahmed said, it can cause a break, for atherogenic break for the retina.
Good points, Dr. Samir. Let's go ahead with presentation of Dr. Arnaldo Bordon. Dr. Arnaldo, would you please share your screen? Dr. Arnaldo is the head of retina and vitreous sector in Sorocaba Eye Hospital, Brazil.
Oh, thank you. I think we need to unshare the screen so I can share my screen.
Yes. Okay.
Well, first of all, meanwhile, I would like again for the kindly invitation to participate in this meeting. And so far I've been learning a lot with all you guys. I'm going to share some experience here with you.
Samir, can you stop sharing the screen, please?
Yes, I'm trying. It's something wrong. I have a glitch. It's not okay. Okay. Yes.
Okay, now. Yes.
Yes. Okay, now.
All right. Let me start here. So, can you all see my screen?
Yes, you can see now.
All right. So, I put in the, okay, now in the full screen. So, the hospital that I run the retina session is a teaching facility. And it's very good to teach because you learn a lot. You learn from the questions, you learn from the everyday challenges. And of course, during the OR is the part that you learn really, really, really a lot. I'm going to start with this case. I'm going to talk about with some perfluorocarbon complications that you can see and how things may lead to another, and you can see the surgery turning to like a test to your heart condition. So if you have a good heart and you pass through some surgeries, you don't need to check with your cardiologist because you already done. So this patient, this is a reoperation. This patient had a retinal detachment, and the retina was pretty much all attached except for the inferior part, as you can see. But this patient had some bubble of perfluorocarbon underneath the retina, exactly underneath the macula, as you can see here. So at this point, we start to displace the bubble inserted with the 38 gauge needle and displacing even further, putting some perfluorocarbon. So as we did that, some part of the bubble underneath the macula were moved away, but there is some still parts. So we did some air fluid exchange, no good. We were back to fluid, and as you can see, the retinal detachment increased. And then we did another bubble and try again to do under air to drain that fluid underneath in the peripheral area, as you can see. But again, no luck. So as you try to reach, you see there's a lot of laser from the previous surgery. And meanwhile, when we were just exchanging instruments, when we went back inside the eye, look at how was the detachment. So what we did, we drained the fluid from underneath the retina. And as you can see now, it starts subretinal bleeding. So one complication led to another one, to another one. So to avoid the blood to go to the macula, we put some perfluorocarbon, and just to prevent that the blood goes there. And after everything, the retina finally was attached, and we did some laser. We didn't try to remove this blood because it was in the inferior part, and we thought we would make a lot of worse to the condition, to this eye, instead of making any good. So since it was inferior, we let like this. I'm going to move to the second one, the second video. This patient had surgery before, and this patient has a coagulation problem. As you can see, there's a lot of blood from the conjunctiva. The pupil was small, narrow, with several opacities in the posterior capsule. So this patient had silicone oil and a large amount of perfluorocarbon left in the eye in the previous surgery, about 30 to 40 days before this surgery. So we start, of course, just cleaning, just blood from the conjunctiva and trying to make some good view by doing a capsulotomy. And you can see here, this is the actual view for the surgery. It's not a video that is in a bad quality, but we try to aspirate it, remove the silicone oil, and then we are trying to aspirate the perfluorocarbon with a 33 soft tip, but no good. You try to remove anyone that removed perfluorocarbon during the surgery that you just put, you see that it comes very easily. But this one, look at the bubble. We are pushing, we increase the vacuum to 400 and nothing. The bubble was adherent and couldn't remove it. We couldn't take this out. So at this point, we try some maneuvers like to move the bubble, to rotate the eye, increase again the vacuum, but nothing. So at this point, I said to the fellow, well, we're going to lose another thing. We're going to use 18 gauge gel coat, so to go inside the eye and try to remove and see how sticky is this kind of perfluorocarbon, which I think is mixed and is somehow blended with the previous silicone oil that was left for 45 days, 40 days at least. And then remove almost all of them and go after the last bubble. And then we had some bleeding, of course, during touching. And finally, we were able to remove the last bubble of this sticky perfluorocarbon. So I would like to hear comments for you. I'm going to unshare my screen. So this is perfluorocarbon is a very good tool. And of course, we can discuss since how to prevent the perfluorocarbon to go underneath the retina, and when it's underneath the retina, how to remove it if you need to remove it. And this is for the first video. The second video, this was very unusual. I think I never saw this before. So because it's a mixture of silicone oil and a large amount of perfluorocarbon that was left in the eye for a long period of time, more than 30 days. And I believe that this make a mixture, a blend, and prevent us to remove the perfluorocarbon in the usual fashion that we used to do regularly. And with this complication, we move ahead and do another thing, and we were able to manage that. The retina was attached through all the time in the second video. So I would like to hear, the comments from the panel.
Thank you, Dr. Burdon, for such interesting cases, and you really need to check your heart condition before you go into such cases. So let's start with Dr. Singh. Dr. Singh? Why do you think a PFCL bubble would escape into under the retina during surgery, like as what happened with Dr. Burdon's first case? And how to avoid, in your opinion?
I think this every time we see this case of subretinal PFCL, all of us, I think we are surgeons, we keep telling ourselves that we need to go back to basics. But yes, is it easier said than done? You have to keep it as a single bubble and relieve the traction first, especially on the posterior brakes, and I think minimize the turbulence. I think use valve cannulas. If there is too much of turbulence, I think that can also create fish egging. And also depends on kind of cannulas you are using to inject PFO. I think that's again a very important. I think most of us have discussed this very frequently, that how to avoid PFO going subretinal. But this is, as I said, it is easier said than done. Sometimes visualization doesn't allow you to adopt all these practices, and there are a lot of dynamic things happening in OR. So it does go subretinal once in a while. We see this in almost all the meetings. I think in general, if it is subfoveal, I think that's very important, that then we have to remove it. Not all subretinal PFO has to be removed. This is one thing I would like to say. And I have also encountered a case where PFO got mixed with silicone oil, and it is really bad. It takes a lot of time to remove it. So that means that if you have a retained PFO, then I think better you remove it thoroughly and then only you inject silicone oil, especially you are going for a resurgery.
Thank you, Dr. Singh. Dr. Salam, being a minimalist, as I know, so do you like to use PFCL in all cases? And is there a second question? Is there any reason nowadays to leave a PFCL in the eye for some time?
Yes, I've put there. We're trying to put a book together on as a manual of retinal surgery. So I've put there in the chat the tips that we put in one of the chapters about how to avoid PFCL going under the retina. I think the best thing is not to use it, or to use it minimally. I use it only for PVR detachment and giant breaks. That's what I use it for. I mean, of course, you want to inject slowly and don't inject over traction areas and don't double dip. But I think it's like what do you call it? Like the Russian roulette. You'll keep using it and something would happen once. So I would use it very minimally. Yeah.
And have you encountered before a case with a mix of silicone and PFCL as Dr. Burdens and Dr. Singh? And what's your experience?
Yes, it is very difficult to remove it. And in England, we had access to heavy oil, so it's even worse than heavy oil. And I think, again, I would try to avoid using oil and PFCL as much as I can. That's really my advice. Some patients, giant retinal break, we sometimes leave PFCL as a tamponade. I think this is really a good technique as well. It makes life easy. But otherwise, I would use it in this context.
Okay, great. Thank you very much. Thank you, Dr. Borden. I think we have only less than 10 minutes left to go with Dr. Singh presentation. Dr. Singh, would you please share your screen? Thank you. Dr. Singh is the Medical Director of Retina Services, IQ Subspecialty Eye Hospitals, and President of Gurugram Ophthalmological Society of India.
Yeah, thank you, Dr. Avadallah, and whole NU1 team for inviting me once again. And it's a pleasure interacting with such a senior and experienced vitreoretinal surgeons. And once you told me that we'll be discussing intraoperative complications, yeah, first thing that comes to our mind is our own fellowship, and then now your own fellows. But because I thought, let me share some videos where, they are the complications where we could have avoided them if we were a little more careful, or, we would have been following certain steps. So I have tried to collect 4 cases to be shared with everyone. So this is again a very old video where we were actually operating a young patient with combined rhegmatogenous RD. Patient had retinal vein occlusion, and I'm peeling this ischemic retina, and as you watch, I think there is some dragging happening, and which I was ignoring. Here you will see, as I am trying to peel ILM, retina is getting dragged, and I am ignoring it, and this is almost going to give way, still ignoring, and you see this. I ended up creating a large macular tear in this ischemic macula. And you all know that nothing can be done now for this. Even this doesn't even need laser, but this will create a very bad macular scar. So I wanted to share this with everyone for this reason only, that these days also, whenever we have to peel ILM in ischemic retina, we don't do it routinely, but if there is a epiretinal membrane or there is a need to remove ILM, then the difference from that earlier video is we go slowly, and if there is too much dragging happening, then we just stop it and we avoid that extremely ischemic area. So as here you will see in this combined rheumatogenic RD and PDR patient, you can see there is a break underneath this regress neovascular complex. And what I am removing here is the posterior cortical layer of highlight. And again, going very slowly. And if the more the drag, slower you become. And if you feel that you are not able to feel it safely, just give it up. And when I'm going to now remove ILM, again, going slow. I think light pipe is a little more close than it should have been. And like you will see, I'll just peel around the fovea, but I will avoid this extremely avascular area. Because I know if I try to peel over this area, I'll definitely get a retinal break. So that was one case. You want me to stop here or shall I finish all 4 cases, Dr. Avadallah?
Yes, yes, sure. No, you can go ahead, doctor. You still have 5 minutes.
Yeah, I think I'll just quickly rush through. Another thing what we have observed is when we are now peeling for these PDR cases, I think pre-op OCT angio is also helping us. And if you are able to find small neovascular twigs at macula, that is the area where ILM is going to give you maximum resistance. So if you can localize it pre-operatively, just avoid that area. Somehow I was not able to find a couple of videos which I have collected. I think that's again a very small tip to avoid macular tears during peeling these ischemic retina. Now the case number 2 was a routine macular hole. I think we thought it will be a simple macular hole surgery. And it was going well, as you will see, routine PVD induction. And plan was to peel off the macular, temporal macula and create a temporal flap and do inverted flap technique. The visualization was little compromised. And as you see, as I was just crossing this temporal area, I ended up avulsing a retinal vessel, which I didn't realize. I thought it's a minor ooze, which you often encounter during peeling. And of course, my assistant has raised the intraocular pressure and still you can see the disc is not pulsating. So it was not raised enough. And I am still busy peeling the flap and ignoring the blood. I was still trying to cover the hole with the flap. I finished the remaining part of peeling superiorly, and again, I'm just not doing anything for blood. And this is at that point I tried to flush it out, but I knew that it has now clotted. Again, it's a macular hole case. This amount of blood, gas, I thought probably it will work like an adjuvant. Let's not fiddle around too much. And I just left it. And the patient had, no visual recovery for almost 3 weeks. Gas bubble also remaining very less. And it was almost looking like a endophthalmitis cases, but no reaction, nothing. So we went ahead to drain it, do a vitreous lavage, and you can see the amount of clotted and fibrotic blood coming out. And when I went inside, it was like almost like in fibrosis bulbi interna with just within 3 weeks. And again, I'm trying to poke, but then I was probably reminded of my last experience. I stopped there, but I was really worried about this clotted sub retinal blood at macula underneath the macular hole. And of course, at post-op 4 weeks follow-up, hole did close, but not a very good outcome. You can see outer retinal layers almost gone and patient highly unsatisfied. And you can see when autofluorescence telling us that this macula is not seeing well. So I think one small message, don't ignore hemostasis even in macular hole cases. And this was one. This another case, again, a progression of diabetic TRD. And you see this foveal drag visible. So we planned surgery. And I was going bimanual nicely, dissection, just like we do for all our cases. And now I realized that this is a thick sheet. I'll change my hand. Yeah. And at this point, probably I just forgot that I have a forceps in my other hand and I started going uni-manual. And till then it was fine. And here, as you will see, I just went through the retina. Even when I had forceps in my right hand, I was not using it. So this is something I would like to show the fellows. I think all experienced surgeons know that if you have a, you are bimanual, stay bimanual. I think it is much more safer in these scenarios. And then again, now I wanted to clear all the traction very meticulously around the brake. So we encountered another one. Normally what I do if I get a break in PDR cases, I do this diathermy of the edges. It will prevent subretinal bleeding. Otherwise it keeps on oozing. And by the time you finish, you will have a massive subretinal heme. So again, I think rest of the surgery like healing ILM and all was same. And although this patient did well, but still we had to use silicone oil just because of that break, 2 breaks. So the message is again, if you have started bimanual, there is no harm in doing going ahead bimanually, and I think go for with higher magnification when the adhesion is tighter and go slower. And this is the last case. I'll just show this again.
For the last case,
yeah.
Just very comments
quickly.
from.
I'll just
Very, okay,
this
go
was
ahead.
Actually very interesting case. I was removing an IUL. There was iris prolapse happening, and you can see there was a choroidal detachment. I thought probably my cannula has gone suprachoroidal, but I am inserting the light pipe. It was not the case. Now I realize that I am dealing with a suprachoroidal hemorrhage. So what next? And then I could stop the suprachoroidal hemorrhage, and we were really lucky that day. But question is, should we drain it then and there only, or should we wait? So in general, I think I'll skip the discussion part. And in this particular case, actually, I could drain it then only. And you can see blood coming out, but most of us would otherwise advise that let it be there, and we will go back, once blood has liquefied. So that's it. Thank you.
Okay, great. Thank you very much, Dr. Singh. Very interesting cases with complications and how to deal with them. We can have some, Dr. Amri, is Dr. Amri with us? We can have some time for comments from the panelists.
Yes. Yes, go ahead, Dr. Muhammad.
Yes, so we have the cases of Dr. Singh. Any of the panelists would like to comment on any of them? The first case with the ischemic retina, and we had this retinal tears after ILM peeling. Yes, Dr. Samir, go ahead.
First of all, thank you, Dr. Devendra, very much for your nice cases and their consequences. It's very nice. But I would like to ask you, is the ILM peeling for you is a routine procedure in your vitrectomy cases? I think we don't do this in our retina surgery community because the ILM peeling has complications actually. And if you are going to do ILM peeling to decrease the incidence of epiretinal membrane formation, for example, it's already very low %, and the studies had found that there is no significant difference between removal or non-removal of the ILM peeling. So what's your regimen in removing ILM in a case of
I'll quickly answer it. I think if we go for proliferative vitreoretinopathy, especially PDR, my criteria for removing ILM is only if there is a new vascularization within the arcade, or if I have a new vascularization at disc. And especially if this new vascularization is still active, you have some vascular component, then I would definitely like to peel ILM, because it prevents ERM formations once this new vascular complex is going to regress. We presented a poster at ASRS a few years back on this, that what are the cases where we can peel ILM in PDR. In DME, I think I am not a big fan of peeling internal limiting membrane, and I agree with you. It has complications, more complications when you are peeling on a compromised retina. So my criteria is if you have a neovascular complex within arcade, if intraoperatively or preoperatively, I have seen it, I'll go for ILM peel. Otherwise, I'll avoid it.
Okay, great. Dr. Burdon, do you have any tips for peeling ILM in very thin retina, whether the ischemic ones or the highly myopic eyes, where you have this very thin and fragile ILM? Do you have any tips or any technique you would like to add?
Yeah, this is very challenging because, you know, in myopic patients, you have a thin retina. If you have an ischemic retina, it's also even thinner. So you are dealing with a, you know, unfair fight between the doctor and the eye. So if possible, I try to start the peeling very as close as possible to the posterior pole. Why is that? Because the IOM is a little bit thicker in the area than in the equator and periphery. So if it's the case, I try to do this way. One can use some of the scrapers. I'm not a big fan of a Teno scraper, but I've used for some cases, you know, the finesse loop from Alcon, that you can just create a very thin edge to start the peeling, because the most difficult part is to create the edge. Once you create the edge, then the removal of ILM is safer and less complicated. So what I think I use as a tip. And sometimes what you can do, especially in macular holes, when you try to drag some ILM from the equator to the hole, especially in reoperations, where you don't have any more ILM around the hole. What I do is I just lift just a little an edge, and then I put some perfluorocarbon, and then I complete the peeling and drag underneath the perfluorocarbon the ILM to the hole. This is another technique. It's different from the case presented, but it's we're talking about difficult removal. So I think this is another thing to share with you.
Okay, great. Your last case, Dr. Singh, the interesting one with the choroidal, suprachoroidal or choroidal detachment. Do you think there is any reason that this should happen, and how to avoid such, horrible complication?
Even today, I had an OR, so I was telling my fellow same thing, that don't leave eye in hypotony for any amount of time. It's like we should always keep a watch, like we are doing vitrectomy, we are watching optic nerve head. We don't want to create pressure induced damage, and this is just opposite of that. You should always keep a watch for hypotony, and this is very common when you have extended the limbal wound. Whenever you are doing any manipulation in anterior segment and you have extended the wound, sometimes you are waiting for something. This is probably the first and maybe I hope the last time I have encountered suprachoroidal. But a lot of my colleagues who refer to me, their story goes like this. I was waiting for an instrument, I have extended the wound, I was waiting for cutter, I was waiting for IUL, and this waiting, and patient getting anxious, blood pressure shooting up, and hypotony not addressed. I think these are, and a high myopic eye. This all makes a right combination for landing into a suprachoroidal. So high myopics are even much more sensitive. I think even if you have a 2 millimeter wound, yeah.
Also, elderly patients are more prone to such complication. I guess also you should have an eye on the systemic blood pressure on the monitor. Sometimes you find the shooting, especially if local anesthesia is kind of not deep and the patient is irritated, moving, and the patient gets anxious, wants some instrument, forget to look after the wound. So you get hypotony from one side and high systemic pressure from the other side. Dr. Salam, God forbid this happened. What would you do or advise your fellows to do or teach them to do immediately if on the mere suspicion of getting a suprachoroid?
I just close quickly. We can always come back. Just close quickly. I mean, there's actually a great study from Taiwan that showed even during vitrectomy, it doesn't happen during the first vitrectomy. It's usually in vitrectomized eye when you come to do something. And I presume this may have been a vitrectomized eye. It's usually in this context. So I would just close, and then we can sort out things later, but close.
Okay, great. So any comments from the from any of the panelists or speakers, or before we conclude this great session?
Yes, just a quick comment about the suprachoroidal. You can happen also. I teach my fellows to always look up for the infusion line, because sometimes with movement of the eye, they tend to move a lot the eye, and then the infusion can be a little bit outside, but not totally outside the eye, and goes under the choroid, and then you start a big and sometimes massive choroidal effusion. It's not with blood, of course, with BSS, but it causes a lot of trouble during the surgery. And sometimes you have to stop the surgery. But I agree with Dr. Salam. When you encounter like this, I had the opportunity, not a good one, just like Dr. Singh, once in my life, and you have to close as soon as you can, as faster as you can. So just to make, the pressure and everything inside the eye. Otherwise, you have, completely disaster.
Thank you, Dr. Wellens. Great point. Okay, I think we came to an end of this great session. We learned a lot from complications as usual. And as I have said earlier, the more you do and the more you do surgeries, you encounter complications. And what makes a good surgeon is how to deal with such complications. Finally, thank you, Dr. Amri, for allowing us this opportunity. We had a great surgical session with the great pioneers from all over the world. Thank you. Thank you very much.
Thank you, everyone. Thank you very much.
Thank you, Dr. Abdullah, Dr. Ahmed, Muhammad.
Thank you.
Thank you,
thank you very
everyone.
much, Dr. Bendra. Thanks for all.
Thank you.
Thanks for all. Dr. Mahmoud Ismail, how are you?
أهلا وسهلا. كل سنة وحضراتكم طيبين. Thank you very much for including me in your fantastic and outstanding written discussion.
Are you going to work
our cousins from
خلاص؟
دكتور حسين ودكتور عوض الله ودكتور محمد سمير، الناس كلهم الحبايب كلهم. Thank you very much for including me with you.
كل سنة وحضرتك طيب.
طيبين أهلا وسهلا.
Dr. Mahmoud Ismail, for those who don't know him, he is the head of the Egyptian Ophthalmological Society, which is the older society of mother society of all ophthalmology in Egypt. Thank you for attending, Dr. Mahmoud. It was our pleasure.
شكرا يا باشا.
You can join us also. We'll have Dr. Mahmoud now as a speaker, as a guest of honor for the coming 30 minutes, inshallah. It will be an honor to be all of you with us. Thank you.
Thank you very much.
Assalamu alaikum wa rahmatullah. Good evening, dear colleagues and friends. So we will come to the last, but not the least, session in 8 quick conference. And I am honored and have a pleasure to introduce one of the eminent and elite and pioneer ophthalmologists in our area and worldwide. So let me introduce Dr. Mahmoud Ismail. Muhammad Ismail has completed his PhD in ophthalmology from university. Sorry. Okay. I lost. Can you hear me? Because I feel I lost.
Yes, yes, I hear you. I hear you. Thank you.
Just 1 minute, sorry. I don't know where I lost the sessions. I'm sorry, just 1 second. I will be with you. Yes. So I will continue. I'm sorry, Dr. Mahmoud. Happened. I don't know what's happened with the.
No problem.
So Dr. Mahmoud Muhammad Ismail has completed his a PhD in ophthalmology from University of Alicante, Spain during December 1996, and master degree in ophthalmology and ocular surgery from the University Al-Azhar in 1989. Had the Bachelor of Medicine and Surgery from the same university. He is a professor of ophthalmology and head of cornea and refractive surgery unit at University of Al-Azhar, Egypt. Dr. Mahmoud is also awarded with many prizes during his academic work. He has published many papers in reputed journals and also participated in various national and international conferences. He is the president of Egyptian Ophthalmological Society. He is a visiting professor, University of Miguel Jimenez in Spain. Thank you, Dr. Mahmoud, for giving us the chance to be with us. And it's our honor and pleasure. And the floor for you, please. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Muhammad Basha Al-Amri and all our colleagues from Yom Academy. I think after the long day, we have to be very precise in our presentations, and I will try to open.
Everything is fine, Dr. Mahmoud?
Yes. Can you hear me, sir?
Yeah. Thank you very much. Yes, I can hear you very well.
I will start by some basic knowledge first in the cornea about the healing. The healing in any corneal injury, it starts by the epithelial plug, and the epithelial plug fills up to about 70%. And this, if it's open once again, like in a chronic ulcer, it gets healing by secondary intention. Secondary intention meaning that you have converted the case to a chronic case. Of course, the cornea had a lot of diseases. The most important, and today's discussion is about infectious keratitis. And in our course to explain the infectious keratitis, we have to know that there is a lot of vicious germs that can attack even intact epithelium, like in cases of acanthamoeba keratitis. Of course, as we all know, the history of contact lenses in the hot, humid climate, that's why in Florida and the United States, they have the highest incidence. Foreign body and pounds, water pounds are the most vulnerable people who are working in ponds. And it's characteristic by something very unusual. The manifestation is called ocular pains. As we all know, pain is not a plural, it's a single. But to emphasize about the horrible pain that the patient suffers, we call it ocular pains. And it's always unproportional. unproportional pain, ulcer and serial injection, and corneal edema with the hell of rapid deterioration. Small, tiny ulcer manifests the patient with horrible pain and the ocular manifestation consequence with it. Healing, if it's in the periphery, you are lucky. If it's not in the periphery and in the center, like in this case, is very peripheral and the patient ends by a faint opacity. This is very unusual, but sometimes it's very resistant. As we all know, the bioguanides and the neomycin with the chlorhexidine is the basic knowledge about, and I insist on the neomycin because sometimes we don't find the bioguanides in the market. Unfortunately, in our zone, at least in Egypt, sometimes it's not out of stock. And sometimes we prepare the chlorhexidine by ourselves, and it's very easy. If you get any product, even mouthwash of like this one, in 0.3%, and you are diluted in 0.01% in polymyxin B, like our commercial eye drops in Egypt at Neopol. So you can manage until. However, if the region is central, that's the ugly part. And as you can see, the infiltrate is very huge. According to the ulcer is small and the infiltrate is huge. And this is in cases of central part, it might take months to reach this situation, months even. Also in fungal infection, as you can see, this is beautiful creases, very colorful and very nice, but they are very vicious. This is the fungal ulcers and fungal infectious keratitis. Fungal infectious keratitis in our zone are very common with the fusarium, with the hyphae, and that's why it jumps from one part to another. This explains the satellites. And sometimes the less vicious, which is the candida, and it occurs in hot, humid complexion without foreign body even, but it needs to be have an ulcer in order to penetrate. And the following one is the aspergillus. Thank God it's not even here in Egypt. It's very rare in Egypt, but it appears with a coliform hyphae, and even the infiltrates, it's in coliform appearance also. And this is a typical fungal keratitis, the feathery appearance, the consolidated hypopion, and this is how it looks. And meaning of consolidated hypopion, meaning that if you turn out the patient's head, the hypopion stays the same, and the feathery look and the small satellites. And unfortunately, the patient can get the injury, the plant origin, and it may take even weeks until it manifests itself. And this is another resistant ulcer, cases with undermined edges. As you can see, the ulcer is here, but it contains contented and undermined edges more than the manifested ulcer. This is another case, as you can see, satellite LASIK surgery. The edge of the laser surgery was contaminated by fungal infection, and rapidly, after 2-3 weeks, it starts to have such satellites, as you can see. And obviously, this LASIK flap was created by non-septic microkeratome or blade. Also, it can mimic dendritic or herpetic. The only difference between this case of dendritic-like or herpetic-like infiltrates is the interlacing areas are hazy. In cases of pure herpetic or viral keratitis, the intermediate areas are completely clear. Also, it might have a very tiny ulcer and a huge stromal keratopathy. like in a case like this. Look at the ulcer is so small, so tiny, but the keratopathy is huge. The keratopathy is taking more than 2/3 of the cornea, while the ulcer is very tiny. And this is very typical of some of our cases. The treatment includes two main families: the conazole family, the fluoroconazole, itraconazole, or voriconazole, according to the zone where are you working, and the natamycin and amphotericin B, which is more to the candida. Natamycin is more to the hyphae type. And we don't forget the neomycin and chloramphenicol as an adjuvant in cases of fungal infection. However, in cases of viral keratitis, we change the gear. We have two main, simplex and adeno. The adenovirus, you can start with giving topical steroid. However, in cases like this, you have to be very careful not giving any type of steroids. The adenoviral, or Apollo 8, as we call it, it comes in raids. You have a zone, infection zone, like in our 2 years ago in the in the north of Egypt, in the area of from Alexandria to Marsa Matruh, there was an epidemic of viral adenoviral, and you have to treat with steroid, otherwise it will leave some kind of opacity. This is an unlucky patient. He had an activated herpetic ulcer after LASIK, and this is a typical dendritic ulcer for originating from starting from the LASIK flap after taking some kind of steroids. This is also a deciform keratitis, and this is immune reaction, and it's more or less in children more than adults, and it occurs suddenly. Previous symptoms, just for eye, and you find the keratopathy and deciform without any kind of ulcer. This also you have to get topical fluorometholone to enhance the fluorometholone, dexamethasone, and prednisolone. Fluorometholone, they are not weak. They are connected or concentrated in the cornea. They have low penetration, and they don't affect more on the intraocular pressure, and they have low duration for. However, the dexamethasone is intermediate. They act late, and they take some times, and they are more or less devoted to the intermediate uveitis. The prednisolone more and more prolonged, and they the spikes, they have low spikes of intraocular pressure. However, they more or less confined to the posterior uveitis. During the COVID area, we have noticed some kind of conjunctivitis, which is a viral conjunctivitis, very rare. It's a pink-like hyperemia with tinge of blood in the secretion, and it resolves by topical steroids with mixture some of the mocofloxacin, and they don't have lymph nodes like other kind of lymphatic. Some cases, they are very query infection with a circular and infiltrates. At the beginning, we thought that this is acanthamoeba, but unfortunately, the patient swear that he never wore contact lenses. And after some time and taking more and more culture, we found that some cases we have mycobacteria, especially in debilitated patients. And this is a typical bacteria, and you have to treat it with azithromycin. So in post-infectious keratitis, post-surgery, like in vitrectomy, when our colleagues doing posterior segment, they scrap the epithelium in diabetic patients with hypopyon. If you are, let us concise, if the patient in the second day manifests hypopyon ulcer, most probably staph or pneumococci. But if there is huge or rapid deterioration, unfortunately, this is the very vicious Pseudomonas. If in 1 week it appears for us, this infection, it might be a typical mycobacteria, and if it takes 2 to 3 weeks, this is most probably fungal infection. And this is the most common affection for it. Last but not least, I have been lucky to see in the last few months 3 or 4 cases of Terence mantle degeneration. I don't know why. I have just saw a couple of them from Terence and one case of very vicious Morin ulcer. I want to emphasize on both of them because they are completely different in managing, because secondary infection might toss off the case. And this is how to differentiate between one of them to another. The Terence is always bilateral, non-symmetrical, but always bilateral. However, the Morin ulcer are more unilateral. The inflammation in Terence marginal degeneration is hardly seen, and it's always superior. However, in cases of Morin's ulcer, the eye is horrible and inflamed and red, and there is also a very significant ulcer, and it can appear in any area from 360 degrees around the limbs. I think we have to stop here because I am sure that Dr. Amri, this is a long day, and I'm sure that our colleagues might need to ask something. And before leaving with you, this is a simple diagram of how to treat a dry eye if there is an aqueous deficiency or evaporative lid deformity. And please don't forget the Sjogren syndrome, either primary or secondary. Also, if there is local problem like a meibomian gland dysfunction, post-LASIK, drug like antidepressants or thyroid drugs. Also, there is some people, they lack blinking. People are working long hours on computer screens and smartphones. They lack blinking, and this is one of the very, very noxious cases of dry eye. I would like to thank you once again, Dr. Mohammed Al-Amri, and we are looking forward also to see you once again in Cairo, and please save the date. It will be the 24th to 26th of April, and we would love to host also in the same place, in the same center of Cairo, and we would love to have you once again with us, Dr. Mohammed Amri. Thank you very much.
Dr. Mahmoud, thank you very much for this excellent and comprehensive presentation. It was a great to have you also with us. Maybe we can have only a few questions if you don't mind. I know also you are still wearing like you are still, I think,
I'm still in clinic, actually.
Yeah, in the clinic. I can see that, so I don't want to make a lot of burden, but it was a pleasure and to have you, and it is an honor also to be with us in this and to have you as a guest of honor in our conference. Dr. Mahmoud, sometimes do you think we need just to take all the measures that whenever we are saying to diagnose it is viral, it's bacterial, to have scrubbing of the ulcer and these all measures, or you are going to depend, empirically the treatment according to the history and taking in consideration the information you have just shown with us now?
Dr. Amri, let us be honest with you. I address to all doctors, they have to depend on their clinical sense, because from the time of scrapping, if you are lucky, not less than 3 days until you get the right answer. In such 3 days, a lot of things can happen, especially if you have an aggressive, noxious Pseudomonas, for example, or horrible acanthamoeba, and you have given the patient topical steroid, like sometimes it happens. So you have to depend on yourself, your clinical sense, and as you said, the history. History is crucial in these cases.
There is another question, Dr. Mahmoud. You mentioned in adenovirus subepithelial infiltrate. I think that you are treating by steroid. Is there any chance now for cyclosporine or Zedra to treat these cases because instead of using steroid?
In resistant cases, but if you use fluorometholone from day one with a reasonable dose of 3 times per day, with lubricants and a systemic antiviral, you don't give, in cases of adenovirus, you don't give topical antiviral. You give systemic antiviral. You give topical steroids, lubricants, and mild antibiotic once per day, like moxifloxacin, for fear of secondary infection. But if you give a reasonable dose of topical fluorometholone, believe me, in few days you get a rapid improvement.
In case of chronic, sometimes you treat the patient and he improved, but he came with you with the subepithelial infiltrate after a while. So are you going to give a chance for steroid?
Yes, or steroids combined. In such cases, I agree with you. You have to add cyclosporine, but unfortunately, the chronic cases are very, very tedious, and they take time, and they affect the visual. I had a girl who had this adenovirus, and it took her about 1.5 years to improve. Actually, it was long time.
The majority usually within 6 months?
6 months, yes. But I don't know if you have an epidemics epidemic break of adenovirus. You have seen it in here in the north of Egypt. Every couple of years we have an epidemic, and it's always it's very curious, Dr. Muhammad. It's always in the same region, from Alexandria to Marsa Matruh towards Libya, in such area, and it always at the end of the summer. Very curious, and we don't know why. It repeated itself every 2-3 years. It happens once, and it's an epidemic spread. Everybody, in the end of the summer, everybody in the north, and everybody comes. Very easy to get contagious.
But I think the people get now, all the doctors get about information, and they are well known about this one, so they can manage
now,
it easily.
Yes, now they know. But the viral conjunctivitis of post-COVID conjunctivitis, we have seen it a lot in Egypt, but it was reported in one of the studies, as I have shown to you. We were underestimating it.
Dr. Mahmoud, we cannot, we will continue with you hours and hours, and I know it will not finish. I would like to thank you for accepting our invitation. Actually, I was enjoying being with you in last Egyptian Ophthalmology Society conference. It was a great.
You promised to come next year. You promised.
First of all, we will have you, as you know. We will have you, inshallah, in Miom, inshallah, in October this year, and you will enjoy. Then after that, we will decide about the next year. We will be together, inshallah. We'd like to welcome you and thank you very much for this, giving us this opportunity to learn from your experience, and have a great day. Thank you very much, and thank you. Thanks a lot. At the end, I would like also to thank all dear speakers who participate with us in Miom during the last 2 days. I'd like to thank also the management, all dear colleagues, those they prepared the scientific program with us, And I would like to thank Dr. Fatma for her support to make this event. And I would like to announce also that the CME accreditation will be ready after the meeting by a few weeks, and it will be calculated according to the time you spend in the sessions. And I would like also to welcome you to first Breast MENA conference and fifth MUOM conference that will be from 19 to 21 of October 23. Thanks a lot and good night. Assalamu alaikum wa rahmatullah. Alhamdulillah Rabbil Alamin.